Okay, everybody. Hello, good morning. Welcome. We're going to try to get started on time today because we've got such a packed day for everybody. Welcome to our first cardiac nursing series of the year. Our theme this year is Journey of a Patient with Heart Failure. My name is Tori Temple, and I'm the Regional Program Nurse Educator here at the Ottawa Heart Institute. We have a wonderful series lined up for you today, touching on most aspects of heart failure. We'll be discussing the basics, the in-hospital management, some specific heart failure therapies that we implement here at the University of Ottawa Heart Institute, and we're even going to chat about discharge considerations relating to our heart failure patients. Before I get started, however, I have a few housekeeping items that I must mention. So as we know, this is a hybrid event, and it's wonderful to see so many people here in person, but I also want to shout out to the people who are joining online. For the people who are here in-house, we ask that you please put your devices on vibrate mode. Washrooms, if you need them, are located just outside the auditorium and on the left-hand side. When it comes time for questions or active participation, we ask that you please raise your hand and a runner will come over and bring you a microphone. There's also a microphone situated in the aisle for people who are nearby. For our online guests, please use the chat to ask any questions or make any comments. We do have online moderators working, so you will not be forgotten about. And now I would just like to read our land acknowledgement. The University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin, Anishinaabe, and the people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for the heart health of all people in the region. And now, without further ado, I would like to introduce Dr. Lisa Mielniczuk. Dr. Mielniczuk is a cardiologist and clinician investigator here at the University of Ottawa Heart Institute, as well as an associate professor of medicine at the University of Ottawa. Dr. Mielniczuk is the director of the Heart Failure Program, the medical director of the Cardiac Transplant Program, and the medical director of the Pulmonary Hypertension Clinic here at the University of Ottawa Heart Institute. Dr. Mielniczuk also co-leads the Ottawa Region's Strategic Research Innovation Cluster on Heart Failure, and we are so pleased to have her here today with us to provide her opening remarks for our cardiac nursing series. Thank you, Doctor.
It's just he's going to sit down. Awesome. All right. Well, listen, thank you very much for the invitation to be here. It really is just incredible that we're going to spend a whole day talking about heart failure. I think that's wonderful. I wish that I could be here all day with you as you go over these really great lectures. So thanks so much for the introduction, and really thank you guys for coming out. I think this is just such a real signal of how important heart failure is in our region and how people understand why this is an important topic and why at all levels of collaboration we're here today to sort of discuss it. My role here today is to basically provide just a bit of an overview, a grounding, if you will, of why we're all here and why this is all important. And I think probably I'm preaching a little bit to the choir. You're here because you know it's important. We know that heart failure is one of the most significant causes of morbidity and mortality in our patient population. We know that if you're over 65, it is the #1 and continues to be the #1 reason why you come into hospital for heart failure. We know that once you come into hospital for heart failure, your outcome is completely different and your trajectory is much worse. And we also know that the burden that hospitalization places on a patient with heart failure is not just on the patient, but it's on the healthcare system as well, owing to the costs, the risks of readmission, and all the resources that are spent on our patients. And so it's really important that we have a discussion about how we're going to manage this and how we're going to manage this over time. We know that the population is aging. The prevalence of heart failure is about 1.5%. That means 1 to 2 in every 10 people are going to get a diagnosis of heart failure. As the population ages, the proportion of patients who are diagnosed with heart failure is going to increase. And this is not just a Canadian phenomenon. We know that heart failure is a problem globally. If you look globally, there's an overall prevalence of about 2% in Canada, but if you go to some places, you'll see prevalence estimates ranging anywhere from 4, 5, or more percent. So this is a significant problem. And unfortunately, for most of our patients, we recognize that heart failure is a progressive disease, right? It starts with patients at risk. And so for many of you guys, you look after patients who are at risk for heart failure. If you have diabetes, hypertension, coronary artery disease, you are at risk of heart failure. If you drink a little too much alcohol, you're at risk for heart failure. And so one of the things we like to do is think about heart failure before patients have heart failure. And that's the whole importance of prevention of heart failure. Now, unfortunately, once you develop heart failure, you really shift your focus to the management of heart failure. And we're going to talk a little bit about what that looks like today in 2024, really sort of focusing on the really impressive changes that have been made over time for patients with a heart failure diagnosis. And we'll talk a little bit about what worsening heart failure looks like and why some patients just don't follow the path that we want them to follow. And then, of course, the concept for many of our patients is end-stage heart failure. And we'll talk very, very slightly a little bit about what options there are for patients who have end-stage heart failure. So sort of jumping right in, I alluded to this earlier, right? A lot of patients have heart failure. They may not realize, the significance or the gravity of that diagnosis. And if you Google heart failure, your patients will come up with this statistic right away that says median survival 5 years. And patients will be like, oh my God, I've got 5 years left to live. And that's not the case, fortunately, for many of our patients. That is a population statistic, but unfortunately, it is a valid population statistic. Across all patients diagnosed with heart failure, many of them will pass away in the first 5 years. And so for those patients, the risks are very high. Now, we understand that heart failure is really more than just the signs and symptoms of congestion. And we try to classify it because that has implications to how we're going to treat it. And for those that do a lot of inpatient medicine, you'll hear people say, oh, well, they have HFpEF or they have HFrEF. And we think about heart failure in terms of its ejection fraction. And that currently we believe that if your ejection fraction is less than 40%, that you have low EF heart failure and should be treated on a very specific paradigm. And if your ejection fraction is over 50%, which is actually probably most of the heart failure we see in elderly patients, then you have HFpEF and your treatment pathway is quite different. Now, I don't have a lot of time to go into the nuts and bolts of how we treat patients, but I think it's important that we have sort of an overview of an understanding, mostly in sort of the idea or the conceptual framework that things have really changed in the last few years. And so there are guidelines that help us to make decisions around how we treat our heart failure patients. And we now recognize that if your ejection fraction is less than 40% and you have clinical heart failure, you should be on 4 medications. And those 4 medications are what we call the foundational therapy. Every single patient should be on them if they can tolerate them. And I'll tell you why in a few minutes. And that after you're on those 4 medications, you personalize the therapy based on the treatment response, right? So you might add in additional medications. You might refer for a pacemaker or a defibrillator. And that's all very appropriate management. And it seems kind of easy, right? I've got a patient with heart failure. I need to get them on 4 drugs. If I get them on 4 drugs, it's a win, but it's not easy at all. And for those of us that do this every day, you know that this is tough, right? Patients are not always as textbook as we would like. And getting on these medications can be a challenge. And we'll talk a little more about that. But if you like numbers, here's why it's important, right? And this is a great study that looked at the benefit of being on those 4 drugs compared to being on just 2 drugs, a beta blocker and an ACE inhibitor, how we treated heart failure when I started my career 15, 20 years ago. And if you can get on all 4 drugs and let's say you are 55 years old, relatively young person, you will improve your survival by 6 years. You will improve the survival and risk of getting into hospital by 8 years. I mean, that's substantial, right? So that's not on no therapy. That's on sort of circa 2010 therapy compared to 2024 therapy. And that benefit is persistent even after the 7th and almost 8th decade of life. So there is value in being aggressive for heart failure therapies. And if you want to look at it a different way, if you've got a patient who's on no heart failure therapies, their risk of dying in 2 years is about 35%. For some more, for some less. And each drug that we add to our patient's regimen reduces their mortality quite substantially. And you can see that with each drug's added. And so that's why it's really, really important. Now, I've already alluded to this, right? The problem is very few of our patients are ideal heart failure patients, right? They don't come to us with blood pressures of 140. They don't come to us walking around feeling great. That's not what we see, right? They come to us on 10 other medications. They come to us frail. They come to us with renal disease, and it's really tough to get treatment onto these patients. And we see this in large registries. This was a registry done in the US. It was a few years ago now, but in the US, they looked at patients with low EF heart failure, and they saw that less than 1% of patients were actually on all appropriate therapies at all the right doses. And these are in really good heart failure clinics across the United States. And we see this in the context of clinical trials as well. This was a clinical trial that looked at BNP titration of heart failure therapies. And these were done in the hands of experts in heart failure. And they saw that only 15% of patients were able to get onto the appropriate therapy by 6 months. Now, maybe if you're lucky enough to get your patient on the therapy, you still have to get them to stay on the therapy, right? And I love this study. This is a multinational study, over 60,000 patients in 3 different nations that looked at new heart failure patients. And they said, how many of these patients are still on the therapies that we started at 1 year? And you might not be surprised that at 1 year, 40% of people had stopped the spironolactone, a third of patients had stopped the ARNI, a quarter of patients had stopped the beta blocker, right? That's real world heart failure medicine. And so this is what we struggle with. And there's so many reasons why that happens. And it really does take a village, right? Heart failure management is all of our responsibility because we know that there are many impacts and things that influence why those patients aren't getting on the drugs or staying on the drugs, right? And it has to do with certainly patient preferences, patient knowledge. It has to do with clinician knowledge, clinician time, resources, institutional practices. Do we have the right practices in our region to help support patients getting on these medications? And in Ottawa, I think we do. And so we're going to talk a little bit sort of at the end about what some of those practices are and how we can really try to minimize that gap. Because ultimately, if our patients are not on right therapies, they will get worse. And worsening heart failure is a bad thing. Worsening heart failure can be anything from death, obviously, coming into hospital for heart failure, but even just getting IV Lasix at the rapid intervention clinic or from the community paramedics or going into the emergency room. That is clinical worsening. And when you have clinical worsening, you have now put yourself on a completely different trajectory point. You are not going to do as well. And you're going to have those valleys, and those valleys that decrease your functional capacity, you'll never often quite get right back up to where you were. And the more you have clinical worsening, the worse your mortality is, right? So we absolutely know that your median survival after your 4th hospitalization in 2 years goes down to months, right? And we see that. Our patients that come in and out of hospital, we know that those patients aren't going to survive. And so there's really opportunity to ask that patient about goals of care. And that's often something that we miss. Not only, though, do frequent hospitalizations increase your mortality, but you probably know this intuitively as well if you work on the inpatient side, that the gap between hospitalizations narrows with every hospitalization, right? So the first time they get readmitted, there's 168 days between those two admissions. By the fourth time they're admitted, there's like 40 or 50 days, right? And we see that. The writing is on the wall for these patients. So what can we do? So I thought I'd talk a little bit about in-hospital management, because I think many people in the room are looking after these patients in the context of a hospitalization. And it used to be that the main goal of an admission was to diurese them and then send them home. But we know now that the hospitalization is so much more important than that. And this is the right time to look at the patient and say, what else can I do to prevent this patient from coming back in? And one of the things is to optimize that GDMT, or goal-directed medical therapy. And there's good data that this is not only safe, but it's effective. Simply switching to Entresto in hospital can reduce their readmission rate at 1 month. We never used to use Entresto in the hospital, when it was out 5 or 10 years ago, but now actually that should be our standard of care. More recently, SGLT2 inhibitors, start them in hospital. We never used to start them in hospital, but in fact, there was a study just published a year ago called Impulse that said if you started your patient on the SGLT2 in hospital before they went home, they had a much lower risk of readmission. They had better quality of life. They had less mortality. So these are really important things. And so there's a number of centers that are looking at this rapid initiation of heart failure therapies before patients go home from hospital. This is only one example where in 4 days, and now recognizing not everybody can do this, right? But in 4 days, you get the patients on all 4 drugs, and that you titrate them up early once they go home. And we'll talk a little bit about the use of our transitional care programs here at the Heart Institute to help enable this, because I think this is really an important concept. And so being in hospital is about decongestion. It is about diuresis, but really importantly, it's about optimizing that therapy. It's about adding in right from the beginning all those foundational therapies that will help keep your patient out of hospital. And one other thing I'll say about that is another study that was just published called the Strong HF study, which took this very aggressive approach, randomized patients to usual care. They either got the therapy or they didn't. They had standard therapy, or they had to get on all 4 drugs before discharge. And then they were titrated with the goal of having them on all doses optimized by 1 month. And the study was actually stopped early because there was such a benefit in patients who got the aggressive treatment arm. And these were all-comer heart failure patients. And the risks, the adverse events, non-fatal adverse events, things like hyperkalemia, acute kidney injury, they were greater in the aggressive arm, but overall survival was much better as well. So there is rationale to support this. But if we're going to do this, again, we really need to think about beyond just the physician ordering the drug or the nurse making the decision, monitoring the vitals in hospital. It's so much more than that, right? We need programs. We need help with our pharmacists. We need help from our institutional administrators. We need help from our regional partners because much of this work can get done once patients go home as well. Now, I mentioned advanced heart failure therapies, and the last thing I want to talk about is the reality that not every patient is going to be able to do this. And even if they do this, some patients are not going to do well. And so recognizing, I apologize, the colors aren't coming through very well, but recognizing that transition to stage D heart failure or advanced heart failure is really, really important. And this is a mnemonic called I need help. And you can see some of the determinants there of increased risk. And so I encourage you just to think about that when you're looking after the next heart failure patient, because this is a real important transition point for your patient, right? Where you either need to start thinking about goals of care and asking them about advanced directives and helping them to understand the gravity of their illness, or you're going to ramp up and you're going to refer to things like transplant and VAD. And I will say that heart transplant has changed substantially. The outcomes are great. Patients are living event-free survival well beyond 10 and 12 years now. Similarly, with LVADs as an alternative to a heart failure therapy, LVADs are really, really great tools. And the current generation of LVADs, if you compare it to medical therapy, survival's better with an LVAD. So as LVADs get better and better, their complication risk goes lower and lower, and patients are living well with destination LVAD therapy for a long time. So these are all appropriate things. Now, I'm running short on time. So I don't have time to talk about the regional heart failure programs. I do want to just mention a couple of things that we have here in Ottawa, if I may, before I sign out. And that's some of the tools that we have in hospital and out of hospital to help keep our heart failure patients well. And I encourage you to talk to the team and the organizers of this event today over the break to get more information. But we have standardized order sets, care plans, and what's called a GAP tool, tools that we can help use not just here in Ottawa, but with our regional partners to make sure that patients can get on those right therapies, to remind clinicians to get them on the right therapies. We have tools to give to patients when they go home so that they can empower themselves with knowing what clinical worsening looks like. And this is really important. We also have discharge webinars for our patients so that patients can continue their learning, lifelong learning of heart failure management once they go home. And I mentioned this earlier, we have a wonderful transitional care program to really help to provide support to patients, particularly the highest risk patients when they go home. And that can be in the form of something called IVR, which is automated calling to the patients to remind them about their medications, to inquire whether they have questions or concerns, or it can be a more intensive program like Telehome monitoring. And I think you're going to hear more about that today. So I'm going to skip through that. I also want to put a plug into some of the discharge plans for patients that go beyond medications. Really important things like cardiac rehabilitation, a phenomenal cardiac rehab program here in Ottawa. You're going to hear more about it today. There's virtual rehab here in Ottawa. There's virtual exercise classes. I mean, they've just done a tremendous job. And then finally, we have a rapid intervention program for patients here in Ottawa to keep them out of the emergency room. We can give them IV Lasix. We can give them blood transfusions. We can give them IV iron. And we have a palliative care program here for our patients. And if that's not enough, the last thing we have before I sign off, the newest kid on the block is the GDMT clinic. We actually have clinics here run by our nurses that can put low-risk heart failure patients on these therapies for the clinicians to help to get them through. And in fact, we've just looked at our early data, and we've been very successful at getting a number of patients on therapies within 3 months, much better than we would have been without. So that's a whirlwind. I'm going to stop there. You're going to hear lots more about the things and the activities that are coming and being done today. And I thank you for your time. And I don't know if I'm allowed to take questions, but I'm happy to take questions if there are any questions. So have a great day, everyone.
So much, Dr. Mielniczuk. Are there any questions in our live audience for Dr. Mielniczuk? We're just getting warmed up.
Yeah. No,
thank you so much.
Though, if there are. Thank you so much.
Perfect. Thank you. That was a wonderful way to get us started today. Thank you so much, Dr. Mielniczuk. Our next speaker will be Carolyn Doyle-Cox, and she's going to talk to us about the pathophysiology of heart failure and how we treat chronic heart failure.
Hi, good morning, everyone. And I think about 100 people online. Good morning. Yep, hard to follow that act. You know, Dr. Mielniczuk is brilliant and a great speaker. I don't know if she speaks to you at the end of the day too. No, okay. So I'm going to start. You know, all the stuff. Hi, Kate. All the stuff that she discussed. I'm going to bring you back now, and I'm just going to talk a little bit about the pathophysiology of heart failure. So, as Dr. Mielniczuk said, yes, it's a condition where patients are loaded with fluid, but why? And what can we do to stop that process? So it's going to be a bit about that, and then I'm going to go into a bit about chronic care management. And I'm totally fine if you all want to ask questions throughout. It doesn't bother me if you raise your hand and want me to go over something or correct something, okay? And I'll try not to talk fast. Originally from New York, so I'm up. Okay. I don't know if there's a pointer, but if there is at some point, oh, it's here. And this can do my slides too? Perfect. Okay. Okay, so here we go. I know it's a little bit small. I'll just read a little bit. So, what is heart failure? Heart failure is when the heart cannot pump enough blood to get volume to the body like it should. Cardiac output is 4 to 6 liters a minute. When you have the heart pumping less, which is an ejection fraction less than what's normal, which is about 50%, the body gets a lower output. The volume and the blood flow is less than the 4 to 6 liters per minute, and the body begins to react in compensatory type mechanisms, which then therefore create this condition called heart failure. So it's a syndrome of something else. So we need to find the something else, correct the something else to help the patients feel better. So the definition is the same wherever you go in the world. It may be a little different here and there, but it is a clinical syndrome characterized by breathlessness, ankle swelling, fatigue, accompanied by signs of an elevated jugular venous pressure, maybe some pulmonary crackles if you're holding fluid in your lungs, and it's caused by structural and or functional cardiac abnormalities. All right, so that is the definition of heart failure. It is a syndrome. Its definition is based on the left ventricular ejection fraction, which should be around 50%. Okay, it's not 100. And as Dr. Mielniczuk mentioned, there's HFrEF, previously known as systolic heart failure. We like to change definitions over the years to keep us all on our toes. So that is a left ventricular ejection fraction less than 40%, less than or equal to. Mid-range, heart failure with mid-range ejection fraction. So that's somebody that may not be as low as 40%, but they're certainly not normal. And then there is, as Dr. Mielniczuk alluded to, the HFpEF, which used to be diastolic dysfunction. That's a stiff heart. The heart is pumping around the 50%, but because of years of hypertension, atrial fibrillation, these are patients often with diabetes, the heart is stiff. And even though it may pump at 50%, it's so stiff that when blood comes back from the lungs, it doesn't fill well. It's sort of a bounce back effect, and you end up with pulmonary venous hypertension. So those are the types of heart failure. Our heart failure clinics here at the Heart Institute, we take advanced patients. So Dr. Mielniczuk's group will take patients that are basically would meet the criteria for a lung transplant, a ventricular assist device in the future. So we no longer take the chronic patients, but we take the advanced patients, and pretty much no heart failure clinic will take the HFpEFs. It's a different condition, different treatments, and so that's often not a patient that would be in a heart function clinic. You can have this low ejection fraction due to ischemic heart failure. So somewhere the patient either had an infarct and part of that left ventricle is not pumping, it's dead tissue. That is called ischemic heart failure. Also, if you have angina, if as you get up and move around the room and you are now getting chest pain, but you haven't had a heart attack, you are getting low flow because of that blocked coronary artery. It's causing pain, it's causing less oxygen to the heart muscle, and you can end up with heart failure. Often, if these patients come to the heart failure clinics and they have an angiogram because they have chest pains, if they have a PCI or a CABG and they have, revascularized that heart muscle, the patient can therefore come out of heart failure. That is the best news, right? But if it's an actual infarct, that muscle is dead tissue. And often if it's completely not moving, if it's akinetic, as we see on an echocardiogram, there's not much we can do, but those therapies will help. And then there's the non-ischemic cardiomyopathy. So these are patients that have heart failure and it's not due to any kind of coronary artery disease, angina, a heart attack. And it can be many things, as you can see here. You can have a viral cardiomyopathy. We used to get those a lot in the heart function clinic. They still do. I just mostly work in a different clinic now. Toxic alcoholic cardiomyopathies. You can have somebody peripartum, sarcoidosis, tachycardia mediated atrial fibrillation, fast rate. So why is that? Why are the tachycardias causing heart failure? If the left ventricle is opening for blood coming in from the lungs, nice and oxygenated blood to pump to the body, if it's going like this, it does not fill well, right? So if it doesn't fill well, it's not going to pump enough blood out. If we slow the heart rhythm down and we allow the ventricle to fill, you're pumping out now enough blood. I hope that makes sense. End-stage renal failure, some autoimmune systemic lupus diseases, and there are patients who actually, because of poor nutrition, can go into heart failure with thiamine or selenium issues. So the and the hypertrophic for sure, cardiomyopathy. So we have a lot of these patients in the clinic, and that's the non-ischemic heart failure. So going into a little bit of the pathophysiology, you have a structural or functional problem with the heart. It reduces the cardiac output, either structural or functional. And now there's going to be some changes in the ventricle. There's like remodeling changes that happen with the ventricle itself. And we'll go over why is that happening. Why are there changes within the cells of the myocardium? And then you end up at that point with those changes impaired contractility. So the heart can't contract as well. And if you leave this untreated, it will just keep worsening and worsening. You get an enlarged left ventricle, further changes in the contractility. And as Dr. Mielniczuk said, this will often lead to palliative and care and death. So I would like to now take some time to go over why there are changes happening at the cellular level of the myocardium. And so you can therefore understand why we treat the patients the way we do with the medications we do. So the heart the whole body actually is quite amazing how it compensates. And you have these hormones in your system that will begin to compensate as the body recognizes low flow. The body does not understand that the low flow is due to the heart muscle not squeezing and pumping enough blood, but it thinks, and we have some paramedics here who can understand this, if you have a patient who has maybe been in a car accident and now they're suddenly massively bleeding, the body recognizes there is a problem here. It is, my kidneys are not getting the right flow. I need to pump up my heart rate right now because I need to get more blood flow to the body as fast as possible. And I'm going to hold on to sodium and fluid right now so I can do the best I can to maintain cardiac output. Higher heart rate, hold on to sodium and fluid. If you're bleeding out, that's a wonderful thing because that's saving your life a little bit while the paramedics and the emergency departments and the operating rooms save someone. But if it's a chronic problem because the heart is itself not doing its job, then that becomes the maladaptive changes over time. So we have the renin, angiotensin, aldosterone system that is basically turned on to hold on to sodium and water. And we have the sympathetic nervous system, increase the heart rate. All right, and so we will now, as this happens, and this is happening over a long period of time because the body's not turning off, this will turn into hypertrophy of the left ventricle and some fibrosis. Eventually, you can't really do much about it. So hence, the studies, and way back, as Dr. Mielniczuk said, when we all started about 20 years ago, we had, we had basically the ACE inhibitors. That was about it. And Lasix, right, to pull off the fluid and turn off that renin, angiotensin, aldosterone system. And then in, I think it was the 80s or 90s, beta blockers came along and that was like superb. And it's been sort of stagnant for a long time. And now we have a lot more, which is great and helping patients quite a bit. So the renin, angiotensin, aldosterone system is triggered. It's basically starts its pathway. And as you can see here, it's the decreased perfusion that turns it on, right? To the kidneys, it's hypotension, decreased perfusion, and it's turned on. That happens too with patients who are dehydrated. So anybody in the hospital that takes care of patients who are dehydrated, they may be a little tachycardic. That's also, you'll see that just from that. And then you have the renin formation, angiotensin 1, and then angiotensin 1 turns into 2 by the angiotensin converting enzyme. And so what we do is we block that as best we can with ACE inhibitors. And then we also have the aldosterone on this pathway. So for that one, we have the spironolactone, right? That's one, okay? So we have medications that we're gonna use now, and we have to start them right away. We wanna stop the process so that the patient can, begin to not hold on to the fluid as we're diuresing them with Lasix. So we're doing the job that we wanna unload them, and we wanna stop a process. So the next one here is just talking about the actions of the angiotensin II. So basically, if we didn't turn it off, we have increased sodium reabsorption. We have aldosterone release. We have inflammation and fibrosis. We have myocyte, which is the cell of the myocardium, hypertrophy, which is thickening. We will get some vasoconstriction, and we will have sorry, where am I? I'm lost here. And vasoconstriction and glomerular capillary hypertension. So that's happening at the level of the kidney. The actions of aldosterone promotes potassium hemostasis, promotes vasoconstriction, stimulates thirst. They're always thirsty, right? They're always thirsty. They tell you that when we're trying to diurese them, but I'm really thirsty. Increased sodium reabsorption, again, fibrosis. So bad thing for long-term, good thing for short-term. And if you go into, I won't go over this slide, it's very busy, but I wanted to let you know that these slides at the end of me talking about a certain pathway, the guidelines, the Canadian guidelines for treating patients with heart failure gives you some practical tips. Things you really should think about when you are treating a patient with each therapy. So this is an extremely good tip for you if you're working with these patients at the bedside. And for MRAs, so they have one for MRAs as well. And now switching into the sympathetic nervous system. So we talked about the renin-angiotensin-aldosterone system, which we are going to treat with either ACE inhibitors or angiotensin receptor blockers, right? If the patient has a cough from the ACE inhibitor, we'll switch to an angiotensin receptor blocker. It's no problem. They both work the same. And then we had the spironolactone. But now flipping over to the sympathetic nervous system, this as well is the body's compensation for low flow, meaning I'm going to have to pump up the heart rate, right? Cardiac output, which is supposed to be 4 to 6 liters a minute, is equal to heart rate and stroke volume. So if my stroke volume is down, meaning my blood flow to my body is down, the natural thing is it's going to pump up the heart rate. And so these patients are very tachycardic. We have to slow that down. So the sympathetic nervous system is turned on. Beta receptors on the heart are being, bombarded with the sympathetic nervous system message. Pump it up, pump it up. Let's go, guys. And we have to slow that down. So what we use for this system is going to be the beta blockers. So chronically, to be chronically high in heart rate is bad for the heart muscle, causing, again, that extremely bad remodeling, not like the good remodeling that we do in our homes. Again, if you go into the guidelines, the Canadian guidelines are wonderfully written. There will be practical tips for you if you use this at the bedside for you to think about when you're treating patients with beta blockers. I guess I didn't fix this slide for you, Tori. I pulled some slides from other presentations and it's cut off, but basically this was one of the newer guys on the block. Maybe some of you are aware of the BNP that we do in order to tell if a patient, so we're now going away from, by the way, what we used for a long time, beta blockers and ACE inhibitors. Now we're going into the newer things we found. Now, when I worked in New York City and Boston, we used to have a clinic where we would give patients a medication. And that was basically a medication that worked on the system. And I'll tell you why we would give it for heart failure. This BNP, does everybody know what that is, by the way? A BNP. It's a blood test that we do. Anybody familiar with it here? Not familiar with it? So not familiar. So BNP is brain natriuretic peptide. It's released into the bloodstream when the myocardium is stretched. And how high the level is gives us an indication in heart failure clinics or the doctors on the floor who have, or the emergency departments, how much it gives us an indication. Sometimes patients are a little hard to tell if they're fluid overloaded, but this will tell us how high that number is, which should be less than 300. We have patients in the thousands and the 10,000s. So it gives us an idea of how much stretch and stress that myocardium is going through. BNP is a blood test, simple blood test. And finally, the government has decided it's a good idea to maybe cover this test. So it's actually natriuresis. It's actually designed when it's released to help get rid of fluid. Its brain natriuretic peptide is actually causing natriuresis. This causes a diuretic effect, but it's called natriuresis effect. And it has vasodilatory actions, and it inhibits the effect of renin and aldosterone secretion. So way back, there were studies, and our heart failure clinics in Boston used to put patients in a chair and give them an IV of this because they thought that this would help the patients. And our patients, unfortunately, did okay, but not great. But the thinking is if we give them more of this natural thing, then maybe, they'll get better. It was not a dead thought, though, which is good because it then hence came this drug called Entresto. So it was not a dead thought at all. So we basically, and this just gives you the cutoff points for BNP versus NT-proBNP. Whatever test you're doing, always make sure you look at what's normal so you know which one you're looking at. Is it BNP or NT-proBNP? And then look at the level, what it should be as normal and what the patient is. But the basically the drug there, let me go into a different slide that might be a little bit better. So natriuretic peptides sort of, do this to the renin, angiotensin, aldosterone system. So we do know that as the natriuretic peptides go up, that it's trying to help and augment the other, the other system. And so luckily they didn't, stop thinking about this as a certain type of pathway, so to speak, to utilize for these patients. So what they did was they did come up with a drug that uses an angiotensin receptor blocker as part of it. So half of it is an angiotensin receptor blocker, and that is valsartan. The other half of it is the sacubitril, which is basically the natriuretic peptide together. When nurses here, there's several nurses in this building that use this very frequently and start this on patients as we try to titrate the medications. We do know that it's very different than just valsartan on its own. It's going to help a lot. It has made a huge difference to patients long term. But what it does is it really will drop the blood pressure quite a bit, and it will cause some diuresing effect. So it's something that we really need to watch carefully when we start them. But if we can do it with the starting at the lower dose, the mid dose, and the high dose, watching blood work and blood pressures, this drug has made a significant difference. In the beginning, they wanted us to switch patients from ACE inhibitors and angiotensin receptor blockers and then go to the Entresto, but now the guidelines are saying, nope, you can go straight to Entresto, no problem. And again, practical tips are on the guidelines for you. If you go to the Canadian guidelines for heart failure, you will see practical tips for these patients, which will be very helpful for you if you're using this at the bedside. And so that was the third, right? So we talk about GDMT as 4 therapies, right? We had the ACE inhibitors, angiotensin receptor blockers, the beta blockers. Those were around a long time. We brought in the Entresto, which was a game changer. And then this one is quite interesting. The SGLT2 inhibitors sort of fell into the guidelines without actually trying to be studied to fall into the guidelines. The SGLT2 inhibitors, it's not really fully understood really how they work, but when the United States does studies on the diabetic drugs, they make the companies have an arm for what happens to this patient's cardiac health. Let's make sure that the patients are safe cardiac wise. And so what happened is, as they're studying a diabetic drug called an SGLT2 inhibitor, and that's empagliflozin, dapagliflozin, what happened was there was suddenly this huge decrease in hospitalizations of heart failure patients that was so high that it like Dr. Mielniczuk said, they'll stop studies. They didn't stop the study, but they said, this is enough information. We don't really need to do anything else to say this drug is something that should be put in the guidelines for patients with heart failure because this number is so high. So patients with SGLT2 inhibitors should, you know, it's a challenging drug to start, not to start, to stay on. But it basically isn't, you know, it's made a difference, and it's made a difference. We don't always know why these drugs work, and I think they're still trying to figure it out. Some of the thoughts are that it's, you know, causing a bit of diuresis as well. Some of the thoughts are that, but there's got to be more to it, and I think they are studying it. It is challenging because a little bit of glucose comes out in the urine, and when a little bit of glucose comes out in the urine, germs like glucose, right? So the UTIs, yeast infections, patients sometimes are just intolerant. They get one UTI, I'm done, I don't want to do this. Or, you know, one bad yeast infection and I'm not doing this. And it's worse for diabetic patients. It's not as bad for non-diabetics. You can use it in non-diabetic patients. They're not going to become hypoglycemic. You cannot use it for type 1 diabetes though. So that is a patient population that we would not start this on. Anyway, this is, so therefore, what we all should do very well is educate, right? And so if you speak to your patient thoroughly about the benefits, why they should want to stay on it, why long-term they'll be healthier, they'll do well for, you know, as Dr. Mielniczuk had in her stats, 7, 8, 9 years, lower hospitalizations, right? Each time you go to the hospital, you are not coming out the same as you went in. So if you were up here in a hospitalization and you went to the hospital because you went into bad heart failure, you're not getting back up there. Another hospitalization, you're not getting back up there. So if this makes all the difference to that, we should do our best to educate patients. So we just say, and we're trying to develop a CQI project in our heart function clinic, if we educate them, but maybe really educate them with, you should bring something into the bathroom to remind you to wash with water after you go to the bathroom, because if you have any glucose left over, you're going to have the risk of a UTI, the risk of a yeast infection. So anyways, this would be then therefore the 4 therapies. And again, there are some practical tips for you to go to about things to think about as you're using these drugs for these patients. And what we do is we do have medical directives in this building to help us nurses titrate these drugs. Doctors sign a directive, and that doctor's basically saying, under these conditions, you can go up on the drug. But if it's outside these conditions, you have to call me. So the directives, really a lot of this information that we have here in this building come from these practical tips for considerations in the directive. You know, I'd like to say this was utilized. This is not GDMT, by the way. Ivabradine was one of those drugs that when Dr. Mielniczuk showed the GDMT, the 4 therapies, then underneath that was basically others you can use. And so this was an other you can use. And I don't know, I really don't know why we don't use it a lot. Ivabradine will lower heart rate without causing low blood pressure. The patient, say the patient can't tolerate beta blockers. It causes them to be very tired. They're exhausted. And men very often do not like the erectile dysfunction part of it. And so you have a patient come into clinic and they bring you an ECG and it's like 100 heart rate and you're like, do you have something to tell me? So the patients that can't tolerate for whatever reason, this drug, as long as they're in sinus rhythm, will lower the heart rate without causing hypotension, without causing the effects of erectile dysfunction. And, you know, Liz over here and Donna, we have a couple of nurses here that work with these patients day in and day out. And I don't know, we bring it up sometimes. If we have a patient who's either not on a beta blocker because they can't tolerate it, or just could only get to this minimal dose and they still have a heart rate greater than 70 in sinus rhythm, it should have been considered, but it just doesn't get considered. I really wish I could tell you why. I don't know why. There's got to be something to it. Maybe the risk of going into AFib. I don't know, but there's a reason we don't use it a lot. But it is not a GDMT. It's one of the step below the other to consider. Again, there's some practical tips for sure if you need to. So I've gone over pathophysiology, I've gone over the GDMT medications, why we use them, and hopefully while we're using them, we are potentially taking that patient out of the vicious circle. So this is a very bad vicious circle if we don't use them, right? So we have the myocardial injury and the decreased left ventricular ejection fraction. So somebody less than 40% or even 40 to 50, right? You've got somebody with a low ejection fraction causing that blood flow to the body to be lower than 4 to 6 liters a minute. All these things get turned on because the body thinks I have to somehow improve my heart flow. And yet that's great if it's short term, terrible if it's long term. So now you've got the neurohormonal signaling happening here, and it is a vicious circle of increased cardiac work. So the volume that patient holds on to is workload for the heart. You're holding on to fluid, the heart's like struggling anyway, and now it's got more volume and it's saying, come on. And so we're still holding on to sodium water, vasoconstriction, hypertrophy. So this, we want the patient out of that circle, out of it by putting the medication. So as Dr. Mielniczuk said, the studies are showing we should be really, really aggressive with it. It's hard. It's hard for any of us that are in it. So when we do this, it looks good on paper, it looks good in studies, but in real life, this is very hard. So it takes a village, as Dr. Mielniczuk said. Why does it take a village? Number one, the patient is, and I always get this, Donna, from Catherine, the king of their castle. When they're home, they're going to do what they want to do. We can admit them, start an IV, get all the fluid out by IV Lasix. We can restrict sodium and restrict fluid. We like to use the numbers of about 2 liters max of all fluids a day. We like to use 2 grams of sodium or less all day. But when they're home, they're going to do what they want, right? So we have to respect that a little bit. And I always just flip it to them that, you know, you can, you own 50% of this, right? I in the beginning, you know, we want to help, we want to do everything, we're in charge. We're not really in charge. We have to kind of have them be part of in charge because they own 50%. That means take your medication, take it on time, get your blood work when we ask you to, because we really want to know, are your kidneys happy? Is your electrolyte balance good? You need to take your vital signs. How is your blood pressure? Are you lightheaded? And if you eat the way you ate before, you're going to not help by more sodium means more volume held into your body. So they have to recognize they own 50% of it. I think Dr. Mielniczuk told you this. Like, you know, we can do the best we can. They have to help. They have to participate. If they don't, it's really their choice, right? We have to kind of recognize that, not feel bad about it. But this is what happens, right? Your chronic decline with all the hospitalizations. So it is there's so many studies. This is all the time. This is never different. It's always the same. The more you're admitted, the worse you're going to be long term, and the shorter your next admission is. It's true that a part of the tricky thing too is that your patients don't come just with heart failure, right? So there might be a little chronic kidney disease, there might be a little diabetes, there might be some AFib, they may have, you know, just many other things like, an anemia that is going to cause them to be short of breath and tired as well. So it gets a little tricky. Like, are you short of breath and tired because you're anemic? Are you short of breath and tired because something else is going on? So very often when these patients call us, it's very necessary to ask the right questions to find out if your patient is not volume overloaded, if their weight's the same and their vital signs seem okay, they may actually have a low hemoglobin. So it's really tricky on the phone when they're home and they're not in front of you to remember to ask all the right questions. And for sure, this has been going on for a very long time. That and I'll go over these slides quickly. We have in Canada about close to 670,000 patients aged 40 and over living with heart failure, and the new number of cases per year jumping, with patients 40 years or older, is jumps incredibly. So it's a very, very bad condition to have, and you should have the ability to get on the therapies. And I think the challenging part for us when we look at the prevalence and of where these patients live and how sick they are and how survival is really based on what we give them. If you have access to these therapies, wonderful. If you live in the city of Ottawa, wonderful. But some of these patients do not live here, do not live where there's access to care. That's very concerning. So I think, some of the things, and, I can go over the demographics with you, but you'll see how horrible it is. The demographics of those admitted with heart failure, how much it costs the system, not just the patient and their life, costing them their life if they are not treated and what happens to them long term, but then looking at the amount of dollars that healthcare pours into the revolving door patient with heart failure and the mortality rates for these patients. So basically, we have to do a better job. And Dr. Mielniczuk was alluding to the region, so we do have some of the rural areas that are getting very challenged now. So you have very rural areas that had great internists, that had an interest in cardiology. They're no longer really around and they cannot attract internists, they cannot attract cardiologists. So there has to be some thought, personally, I think, into how are we going to make sure that patients get what they should get based on the guidelines, right? The guidelines say this, and it says you need to do this rapidly, not like we used to do. We used to take sometimes a year to get patients. Let's just be cautious. The blood pressure's a little low. I'm not loving that creatinine. Let's just be cautious. No longer. It's like 3 months to 6 months. Get them on the therapies. Hospitals are like trying to make sure we get them on the low dose of all four and then titrate it later. But who's titrating later, right? Who's starting later? Who's following blood work? Who's following, vital signs? So this is something that really needs to get thought about. And yet, it's chronic condition. And I think that they just are sadly take a long time with chronic conditions. But, from my perspective, nurses can do a really good job at this. So I'm hoping that, the idea would be nurse practitioners take this over in the rural communities. Okay, so diagnosing this. So basically, you have a doctor who has a patient who's come into his office, short of breath, getting very tired and fluid overloaded. The very first thing they would like you to do is basically a BMP. A BMP is actually the very first thing to do. It's a simple blood test. If that level's high, that's a very big red flag, right? And then you kind of go from there with getting an echocardiogram. But you can see right there. Very important. So I'm glad that the government's decided to cover it. And so basically, if you suspect it, if the doctors suspect it, they will look at the clinical history, symptoms, you're short of breath, doing average, easy things. I'm walking from room to room in my house and I am breathless. I have no energy. And the next thing you should do also is a chest x-ray. That can tell if the patient has any kind of fluid in the lungs, congestion. The echocardiogram and the blood work after that, you know, you're going to look at for many things. If you suspect heart failure, yes, then you're going to now do the echocardiogram and send the patient really to a cardiologist. If not, then you just do another workup. But then I'll tell you, this gets actually quite complicated, this slide, but basically what it's showing you is what the cardiologists think of when they have a patient who comes to them. They have to really now find out the underlying reason, right? If the patient has angina, and you open up the coronary arteries and you get good blood flow to the myocardium, you have maybe just fixed that. If it's alcoholic cardiomyopathy and they sustain, they actually could get a little bit better. But this is the very, very thorough slide to show you what the cardiologists go through, right? And how they work the patient up. And, you know, you can see over here, if they're, you know, history of hypertension, probable hypertensive, you know, cardiomyopathy, toxin agents are at the bottom, inflammatory markers they look at, they do cardiac MRIs. And then at the end, they have now at least a picture of what the patient has and if there needs to be some different treatments based on the underlying reason. And so as I was talking to you, I don't know if everybody understands this. A good way of monitoring a patient is to ask them what types of things make you short of breath. So the New York Heart Association functional classification system gives us an idea if a patient's doing well or not. The next time we see them in clinic, maybe we've started one of the therapies, the second therapy. How are you doing? Are you short of breath? What makes you short of breath? What makes you tired? And we kind of plug them into 1, 2, 3, or 4. One is, I'm fine. I can do whatever I want. I work on roofs. Nothing stops me. Or all the way to 4, I'm pretty breathless at rest. Like I feel even a bit short of breath sitting down. Most of our patients fall between 2 and 3. 2 is, I'm good until I walk up a flight of stairs. I'm good until I carry groceries into my house. And 3 is the patient who's short of breath going from room to room in the house. And we use this in order, every clinic, we use this in order to find out how they're doing. Because it's them telling us how they're doing, not us looking at a test result, you know? And the treatments, as Dr. Mielniczuk told you, this is also in the Canadian guidelines, right? So here's our less than equal to 40 with symptoms. There's your 4 therapies that block the body from holding on to fluid and being tachycardic. And here is your additional interventions. Okay, so the additional interventions, we have here the consider ivabradine for the heart rate greater than 70, sinus rhythm. Versigwat is not going to be used in Canada, sadly, unless you have a private plan. The company has decided, even though it's fabulous for reducing readmission rate, the company Bayer decided it's not going to try to get it covered in the provinces, which really annoyed Dr. Mielniczuk. But if there's a private plan, it may, right? And so for patients that may be unable to tolerate these, we can choose a combination of hydralazine and nitrates instead. So we know we can consider that if there's intolerability for whatever reason above. This isn't used a lot, but digoxin is also, you know, something that can help with rate control. So we sometimes use that. Then you end up down here, right? So at the bottom is your patient who's now still, there's the NYHA, 3 or 4. We have gone up on all therapies. We are maxed out at all 4. We don't know what we're going to do. The patient is trying and they really aren't eating a lot of salt or drinking a lot of liquids, but there really isn't much else we can do. Sometimes, you know, the kidneys aren't participating with pulling the fluid off, right? You have to have pretty good kidney function in order for us to pull fluid off. Kidneys aren't working well. That's not great. So basically what we try to do is consider the alternative therapies, and the alternative therapies are the VADs, the ventricular assist devices. So that's a device that goes in, it's a surgery, it's plugged into the bottom of the left ventricle. The surgeon puts it in, and basically the blood goes from the right atrium into this system, and this ventricular assist device pumps so that the patient has 4 to 6 liters a minute. So if you can kind of bypass that inefficient, useless left ventricle and go into a device that can give you the cardiac output you need, you'll be better. Sometimes that's what we call transition to heart transplant. We're kind of trying to get you there to transplant. You need a little assistance here. Sometimes it's they're going to have that forever. They're not a candidate for heart transplant for whatever reason. And if they're not, a device may be what we call destination therapy. So we can refer for heart transplant. We can put a device in, or palliative care, which is unfortunate. But we know that this is a condition that may not get much better. The real world is that it's tough to get them on these. It's tough to keep them on these. I think Dr. Mielniczuk told you how hard it is to keep them on these. Sometimes they're coming off the spironolactone. Their potassium's just too high. The kidneys are not liking the meds anymore. Maybe they've been in and out of the hospital and their kidney function is really taking a hit. And so we're now coming off of some of these therapies. So it's challenging. It's wonderful to see somebody do better, but we also know it's going to be very challenging. And I just have a slide here. If it's busy. It's busy, I know, but it gives you sort of the drugs that we use. For the ARNIs, the ACE inhibitors, the beta blockers, the MRAs, SGL2 inhibitors, and down the line. So these are some of the drugs we use. There are starting doses. We usually start these patients all the time at a lower dose of everything to see how they do. We don't there's no jump to this drug, and they're good, right? We have to start low and and reassess. If we have 3 to 6 months, it's real quick. And you have to have a participating patient who will do blood work on time, who will call you with their blood vital signs, who will say when they're doing well or not well, who will report their weight and tell us if they're holding on a fluid. Because really, if a patient, by the way, FYI, if they're holding on a fluid, we're not titrating a beta blocker. We have to get that fluid down first. It's not good to titrate a beta blocker if they're full of fluid. So it can be challenging. We start low dose. We really aim to get as high as we can and repeat an echocardiogram so that we can see, did we help that heart function go from 26% to maybe 42, and did we help that heart pump a lot better? There is a systematic review basically that takes what a systematic review is. It takes a lot of studies, it looks at them, and it gives you an idea of what that means. And this is why I said nurse practitioners, or nurses should be the ones to maybe take over this kind of a thing in the rural communities where we don't really have access for this kind of assessment, treatment, and close follow-up. The systematic review, 7 randomized controlled trials. Those are the best trials you can do. We've got research nurses here, right? These are the best ones, the randomized controlled trials, 7 of them, comparing management of drug doses by either nurses or another healthcare professional. And it demonstrated that specialist cardiology nurses and those designed as advanced practice nurses who titrate drugs for those heart failure patients is safe and highly effective. So what did it find? It found that 4 out of the 7 studies examined all-cause hospitalizations. Patients with nurses had 20% fewer admissions. 6 studies, 27 deaths could be avoided for every 1,000 people if there was a nurse. So it goes on and on. This is a great randomized controlled trial. It just gives more, the patients are so complex. One physician cannot possibly do the entire job. So if we're looking at issues in the community, we really need to look at how can we do better for the patients. And this is, again, some practical tips about the titration, the initiation, meaning the low dose, and the further titration of these drugs. So these are practical tips for all of it, for the GDMT. Last several slides, I hope. I don't know. I guess how am I doing on time? Okay. So the heart failure exacerbation, right? This is one of my favorite pictures because when I first started as a heart failure nurse in the long time ago years, heart Heart failure exacerbation was interesting. It used to be called dropsy way back before anybody knew what was going on. So you would have patients that literally had tubes in their belly way back before there was really any kind of health care to drain the abdomen of fluid, because these patients, as the heart wasn't functioning and all those, the different systems were turned on, they were, bloated and full of fluid. It wasn't going to get much better, but they did know if I put like a tube in the belly, I'm going to get rid of some of that volume. And we still do it to this day, right? We do paracentesis for those that have like a lot of ascites, maybe they're becoming end stage, and to really help them feel better, we have to, Alex, so we have to, her face, we have to take that out. What happens when there's a lot of volume around the belly? If you find somebody that looks like they have a basketball in the abdomen, they're not hungry, they feel like full after 2 bites because there's so much volume pushing on the stomach and the bowels, and they just feel terrible. And the minute we can alleviate that by tapping it, they feel better. It will come back. It's very difficult once that starts happening to really have that just be a one-time thing. Usually it's for the end stage patients, but that's an interesting picture, and it talks about just really that exacerbation. So this again comes from the guidelines, right? So what do we do? We're trying to stop the processes for the heart to be holding on to volume and having a high heart rate. And this is basically what to do when they're volume overloaded. So we really use the loop diuretics. They're the best. We know that they're going to very quickly get rid of volume. However, the kidneys do have to be participating. So if you have somebody with really bad chronic kidney disease, this isn't as good because the kidneys are starting to say, I'm stressed, stop, So basically it gives you, and we use this for our directives again, because it gives you some guideline. If the weight change is less than this, do this, and how to increase the loop diuretic, right? Are we going to increase it by 50%? Are we going to double it? Or if the weight change, are we going to consider reducing it? So we have really good guidelines to help us with directives and help us treat patients who are volume overloaded. I think we talked about this a lot. Dr. Mielniczuk and I talked about that, so I'll go past that slide. That's just sort of where everything was, and I guess I was wrong about the beta blockers. I guess that was 2000. So nursing management. What do we do, and how do we help with these patients? Right? I mean, the cardiologists look at the tests, order the tests. Cardiologists are the ones who treat the patients. We really have a role too. So basically, we help these patients a great deal. Studies were done in the 1980s that, in the United States, they're so focused, and I can say that because I worked there, they're so focused on the dollar that, these patients going in and out of the hospital with a revolving door really was expensive. How can I fix this? And so they did studies, and they were looking at, if I plug a couple of, 2 nurses in there, am I going to help something? So they did, and nurses actually made a huge difference to this chronic patient population. We improve quality of life. We improve patient compliance. We help them navigate the healthcare system if there's something else they need. So we really have, made a huge difference. The specialized role, so it was in the 1990s, we helped reduce readmission rates. That's what they wanted to see, right? That was it, bottom line. Okay, that's it, put that position in. But the rest of it, we did also, we were able to help them with the therapies, the phone call follow-up. Super important to keep in touch with that patient on a regular basis. How are you doing? Some of them don't even know why to call you, right? You just sat down and told them your heart is in bad shape, and the outcome isn't really good, and then they don't hear you anymore, right? They're blocked. So we need to continually phone them and educate them. And it may seem like you're talking to a 2-year-old because they're not listening to you, but they're just able to absorb only so much at a time when they know that they've got this dreadful, your heart is your life, right? If somebody tells you it's not good, then you're afraid, right? So our structured telephone calls make a difference, and the education and the health management. And so we're a very vital team member. The cardiologist is the dude, right? That's the person that's going to treat this patient, but we're that person's person for like every day. And you know, so if you're lucky enough to have a nurse in a clinic, then, you know, you'll have somebody you can call, even just for questions. And we can, you know, how many times do we have to help one communicate with the other? You know, we have to almost organize the hematologist talking to the cardiologist. And that's fine because they're busy and we're there and we know they have to speak. So we can kind of do that through the electronic health records now. And we can refer to cardiac rehab, right? We know that that's a brilliant, brilliant place for these patients. Our cardiac rehab does such a good job with our patients from a psychological standpoint, from a physical standpoint, an emotional standpoint, and they have some of the best education. I'm involved in one of the eight courses for heart failure. So a patient can join, it's virtual, 1 hour on each topic they need to know for 8 weeks. I don't know how long it is. I know I speak every, I think like 6 or 7 weeks, but it's good, right? And they just love it, and they can ask questions, and they have an hour to hear one thing, and then the next time they join, it's an hour to hear another thing. It's not everything crammed into, you know, 20 minutes. And our telephone assessment is very important, right? So as I said to you, you don't have a patient in front of you. So in the beginning, I think you need to have a little list of what, if you're ever going to work with a patient on the outside, you need to have a little bit of a list of what things do I need to remember to ask? Because I'll be honest, when I first started this nursing, I'm like, oh, I have to call him back. I forgot that, you know, and you're calling him back. I'm sorry, I'm calling you back, but I forgot to ask you this. So if you have a little list of the things you want to ask to make sure you have a complete picture of what's going on so that you can then decide, can I bring this patient, can I double their Lasix? Can I bring them to clinic? Can I bring them into the rapid intervention clinic? Do they need to go to the ER? Do they need to call 911? So you'll know based on the end of your conversation where you need to go with that. And how many more minutes I could? Okay. And so, you know, you make sure that telephone assessment is good so that you're doing the right thing for the patient, talking to the doctor, you know, and just saying, this is what's going on. But we will have lots and lots of challenges, right? You're not dealing all the time with someone who's just in a perfect place otherwise besides their heart. They have socioeconomic issues. Some of them are not working or their spouse isn't working. Some of them will have a little bit of housing instability. Food insecurity. You say to them, you need to eat healthy, you need to stay away from sodium, and they're telling you, I can get a frozen lasagna out of the freezer at Loblaws, and that feeds my family, and I can't afford what you're asking me to do. Utility needs, safety issues, cognitive, self-perception, coping, stress. There's a lot of, some of them are very fragile. So we have to consider as we're speaking to each patient, what is this patient's other challenges? Because that's going to be a block in the conversation if you're ignoring the fact that they practically don't have a home and they're on somebody's couch, or they are never going to afford the food you're wanting them to afford. So you have to keep these things in mind and then think, the navigating the healthcare system, what more can I do to help them, right? We do have access to social workers. We can send them into the community. 211 is a great 3 numbers for patients to call to find out what's available to them in their community. In Ontario, I think it's 211. They call that number, they can do it online, and they can, if they have any of these challenges and they are really lost, they can call that number to find out what's available to them in their community. And, you know, when you have a patient who's just non-compliant, you know, it just may be that they also feel like they're just struggling so much that their mental health is really impacting their illness. And, you know, how do I get around that? So you know, we have to consider it's very difficult to get psychological help these days, right? I mean, you're really, really pressed. You know, you can be suicidal in the ER and they're like, should we do a psych consult? You know, like sometimes I have patients that I know are suicidal. I've sent them and I'm shocked to see they go home. The resources for that are so low. But again, that 211 may have some options for patients who are just down, down, down. And no matter what you say to them saying, you're really going to feel better. And they're like, I'm never going to feel better, even if my heart's good, because I can't afford to live. You know, things like we can really refer them to 211 and see if there's something in the community, maybe even low cost therapy at churches or some of the universities where their students need to teach, and need to do some counseling. So there's things that we don't know, and we have to kind of go outside our own box of where we live and bring them into the Ontario system, which would know what's available in their community. This is part of the guidelines that still stand. This was 2009. I'm sorry for the slide. I didn't fix this one either, but whatever. I tried to fix these slides. But, amongst what it looks like up there, basically, the emphasis is on the 6 following aspects of care for the guidelines. And number 1 is diet, and that's not shocking. Number 2, medications with a special focus and adherence of these drugs and up titrating them. And you can see here that we really have added SGL2 since 2009. Activity level, very important. Do not be a couch potato. That's actually not good for you. If you think you should sit down and do nothing, your muscles become extremely weak and you end up with, what am I looking for the word for this? Atrophy. Thank you. And if that's the case, as the months go by, and I think COVID did this really badly for patients, I saw so much of this when they came back to us. I was shocked. The atrophy means that every time you get up to get moving, it's that much more energy. And so you're now worse because it's that much more energy to get up and move around. So activity level, very important. Follow-up appointments. You can't know how you're doing unless your doctor knows how you're doing and your nurse knows how you're doing, and coming to have regular checkups. And you have to weigh yourself every day. Water weight is very heavy. If anybody has a 500 ml bottle of water in front of them, from the grocery stores, full, that 500 ml bottle is kind of heavy. You pour all that water out, and that plastic is like nothing. And I say to patients, water's heavy, which is why you can't dive too far, right? So if you carry 10, 20 pounds of fluid on you, you're not going to feel well. And you're going to say, the medications aren't helping, but they are. You're just lifting 2 10-pound weights and walking around, and you need to put those down and continue to walk. So water weigh themselves 2 to 3 pounds in a day gained, or 5 pounds over the course of a week. You're holding on to water, and you need to call somebody. You need to phone a friend. You need to phone your doctor. You need to say, I'm not sure why. Maybe you were at a wedding, but I'm up. And if you don't get that off soon, the idea is that it's like a snowball going down the hill. It just keeps coming on faster and faster. So next thing you know, you're at the ER. So that's why that's very important. And risk modification, which the, smoking cessation, of course. Maintain your blood pressure in a good range. Make sure you go for your follow-up appointments. I've said that. The diet modifications, we're going to have challenges. Some patients just culturally are not going to eat what we want them to eat. So we have to kind of work with them. Okay, so if you have that in the morning, maybe you just do that in the afternoon. So we have to work with them, and sodium's a big thing. So a lot of us are teaching this low sodium diet, right? They're like, I don't add salt to anything. I know, that's great, that's wonderful. But if you look at the labels, you are actually, we want you to have a lot less sodium. So if you look here at the difference, right, of the thing, what I tell patients is, you want to have something that's less than 10% on the label. Choose something that's 10% or less on the label. If it's 37%, it's too much for that serving for you. And this is a very slow process for patients because you're teaching a completely different way of living, and we just have to know that they're going to fall off the wagon with salt, and that's okay. I've got a great book, and I'm happy to share it with you. It's old. It's from the Heart Failure Society of America. It's, I think, in the early 2000s. But the best thing about this book is it teaches them how to read labels, and it also has food in there that doesn't have a label, so natural foods that might be naturally high in sodium that you want to just kind of avoid. So that's a great book. Plug in our cardiac rehab. It's just fabulous. I can't speak good enough about it. Activity and exercise is super important for these patients. They cannot just be sitting around. So it's very important to join a cardiac rehab or something that would help them recognize that they need to maintain activity. And they can answer the questions that I can't, right? I don't always know all those answers because I'm the nurse, not the physiotherapist. So that's a great place for them to learn. When you're teaching the patients about those 4 therapies, it's extremely important that they understand, right? As we talk today about why, it's also important if you can relay that in layman's terms, why you need to be on this and what it's good. I have patients who say, I'm fine. I feel fine. I do what I need to do. I don't want to take all those pills, right? And you kind of have to give them the later in the game, later down the road, you're still going to be fine if you do this today. And I know you don't want to, but down the line, 7, 8 years, if you don't, then you're not going to be fine. We're trying to maintain fine. So that's, I find is education is extremely important, and continuing the education, and also, you know, having the conversations about what to do if they miss a dose of a medicine, and things like that. I'm going to skip over that to this. This is has anybody seen this? This is great. This is basically the patients won't use that calendar, but they'll have their own, and they'll plug their weights in every morning after they go to the bathroom. And if they see a 2 to 3 pound change in a day or 5 in a week, they know that they're not in the green anymore. Green is, I'm great, I'm green. But yellow is now you've gaining some of that weight. You may have a cough. You may have some extra chest pains. Red is you got to go to the hospital. So this is a way for them to look at themselves every day and decide, how am I today? The first thing, the way and how you feel. And they like it. So it gives them an idea of gauging everything. I discussed this. I don't know if you know this, but a gallon of water is 8.34 pounds. So it's quite heavy. So we definitely want to make sure that they are not holding on to fluid, because that just adds insult to injury, salt to a wound. And our goals of education. So I'm going to just move into these last few slides by just saying this. We want to make sure that when we are talking about goals, that it's their goals and our goals sort of match, right? We know that they want to get back to a really good way of living, and we want them to get back to there, but do they match? You know, it's just so they're not upset. You know, I had every intention of running the marathon in Boston next year, you know, this year, and that didn't happen. Well, because that just was, you know, you might be able to run a 5K, you know. So I think that we need to make sure that they understand the significance of their disease, their heart failure, and, you know, where they're going to be at best. We want them to be problem solvers. I want my patient actually to call me and say, I am going to a wedding next weekend and I am fully anticipating having absolutely no ability to limit my sodium. So I wanted to let you know that I'm probably going to gain 7 or 8 pounds. What should I do? If that patient has somebody to talk to, then you can work that out with them. That's problem solving. That's knowing ahead of time, I'm going to do something that's going to cause me some harm. And we don't want extra volume, not just for the fact that it's heavy, but the heart has more workload. And we want the patients to be independent. We want them to be part of self-care. We want them to have an individualized approach with us. We want to make sure that they feel they're not just a passive receiver of healthcare in this crazy world of heart failure and the many changes with the drugs and how they feel and all the testing that they have to go through, that they work with you and they become a bit more in charge. When they feel they own some stuff, they're going to be more compliant with you because you are not taking control of their entire life. We control their food, we control their liquids, we control their meds, we control their visits, where they're going for blood work. And if they feel some sense of ownership to something, that goes a long way. And there are lots of studies in that. So basically, this is my last slide. Self-care maintenance, self-care management is where you want to be if you're a nurse that works with these patients for the long term, because you're going to end up with a very confident patient who works with you and won't be afraid to tell you, I ate Chinese last night, I'm sorry, but you know, like, and not afraid to tell you and working with you. So that's it. Is there any questions? I hope it wasn't too fast. I hope it was understandable for your next bunch of presentations today. Is there any questions?
Hello.
So the new heart failure guide came out with
Yes.
a change in the sodium.
Yes,
And,
we.
and yeah. So why is that?
There's this feeling, so as the SGL2 inhibitors come along and the Entresto comes along and they cause a little bit of diuresis, I think that, you know, and certainly our new doctor in rehab, Heidi, Jody Heshka, a little concerned that we're dehydrating patients and that we're not recognizing that we're, you know, we may be needing to just kind of watch that. Certainly then, therefore, any of us that work with patients on a regular basis who need less, we just tell them less. But the guide has to be for everybody. And, you know, Dr. Heshka, she wasn't involved in the guide, but what she said was something we were thinking about. We know that there might be, you know, we may have to actually come down on the Lasix a little bit when they're on SGL2 inhibitors or Entresto, maybe. We don't know, but we want to make sure we're not dehydrating patients.
Thank you.
Just wondering, the booklet that you mentioned with the nutrition and the sodium content,
Yeah.
is that available online or?
I think it is, but I'm very happy to send it to you too. I have copies of it. I don't know that it's online anymore, but I have the PDF, and I'm very happy to share that with anybody who wants to. And I don't know who your people are to talk to here, but I can send it to you and you can send it out. I've used it since I've been a heart failure nurse. It's, you know, in this country, but it's really, really well done. Yeah, hi.
This is a quick one.
That's okay.
What is the new sodium guideline? I got it wrong on the pre-test. I thought it was 2 grams.
I can't remember what we had. 2.5.
2.5?
Yeah, I can't remember what we finally came up with. 2.5. It really is a bit mind blowing for anybody that's like, what? You know, we say 1.8. We say sometimes 1.5 because we know they're going to do 1.8. You know, so like, I mean, really, that is a little shocking, but I think it's in the response to the fact that they can get dehydrated a bit with some of these drugs. And we have to consider sick days that they sometimes don't know to stop the drug and then they're really dehydrated. But it was a little like, but Dr. Mielniczuk, you know, the newer studies say that we should be a little bit more, you know, easygoing. But doesn't mean that if we recognize that work in this building, that somebody needs to have less than that. You know, we're going to say, yeah, the book says that, but you have to do that.
I have an online question. We have a question about how soon you can start cardiac rehab.
That's a good question. And I really think that if your patient is not syncable with activity, then we in our clinics at least think this is right away. So you guys see patients in the hospital. So actually you might want to ask one of the rehab people here with the microphone, because they see the patients in the hospital. From our perspective as an outpatient, you know, as long as we think a patient is not really syncable with activity, any time is good, right? So if you have something different to say and you want to answer that, no? Same? Okay. But they see patients in the hospital and patients are referred really soon, right? After a heart attack, after an admission for heart failure. I don't think there's a delay unless there's some sort of physical condition preventing it. Am I right? Yeah? Okay.
I'm curious.
Yeah.
What kind of natural foods should they avoid?
Natural foods?
Yeah, like you were talking a lot about the labels.
Yeah.
And like watching their sodium, but like I'm just kind of ignorant.
Yeah,
to,
I
like,
wish I could remember and I don't.
Okay, that's fine.
Sorry. Does anybody know naturally high sodium? What is it? Thank you. Yeah. Yeah, yeah. Yeah, these I can't recall. She's Oh, you've got it also. Donna's going to answer, but the dietitian's here, so if you can hold that, she'll have all that info. But Donna, go ahead and give your
Yeah, we even found with like Mrs. Dash, Because we're always telling the patients not to to avoid sodium, but Mrs. Dash will actually increase their potassium levels. So you have to be careful with Entresto and
Yep.
MRAs.
Yep. We don't often say those things. Yeah. But definitely the dietitian will answer lots of these questions for you too. Yeah. You have another question? Yeah.
I'm not sure if this will go to the dietitian, but are the guidelines for water intake the same when someone is sweating a lot or it is very hot outside?
Good question. All right. Good question. If you think your patient has reason that they're losing fluid, it could be diarrhea, vomiting, not eating because they're sick, sweating. You definitely have to recognize that they may need a little bit more fluid, and you'll look at blood pressure and heart rate, right? Dehydration is going to be lower blood pressure, higher heart rate. If you think that's the case, then, you can kind of ease up. If their job causes them regular stress, not if I just kind of went to the gym once a week and I'm sweating today, that's a little different than I'm sweating 5 days a week. Good question though.
Everybody
All right.
seems
Thank you so
happy.
much,
All right.
everybody. I hope you have a great rest of the day. Thank you for joining us. Any further questions, just you can ask the team and I can get back to you.
Thank you so much, Carolyn. That was super informative. And I think a good takeaway is the importance of stressing that education about GDMT for our heart failure patients. We are running a little bit ahead of schedule, but that's okay because the coffee has arrived. So please feel free to grab some coffee, a muffin. We will reconvene at 10:40 as scheduled. Friendly reminder, the bathrooms are out the doors and to the left. Okay, everybody. Welcome back. Hopefully you're all feeling a little bit refreshed now that you've got some coffee in you. We're going to carry on. I did hear a rumor that there may or may not be donuts coming, so please feel free to get up and get a snack as needed. And our next talk will be given by our newest member of our nursing educator team here at the Heart Institute. And I'd like to introduce now Laura Carley to talk about acute heart failure.
Hi, everyone. My name is Laura, like Tori introduced me. I wrote it down because I'm very nervous. And I will be presenting on acute heart failure management. Like Tori said, I've recently become the nurse educator for the intensive coronary care unit, as well as the regional referral center. And in those two units, we do see a large population of patients presenting with acute heart failure, and then the subsequent cardiogenic shock, which I'll also be talking about today. These patients are very sick and can unfortunately decompensate very quickly without prompt intervention. So my objective for this presentation is that you'll be able to recognize the signs and symptoms of acute heart failure, identify the assessment and diagnostic tools that we use. We'll be discussing the pharmacologic agents that are used in the management of acute heart failure as outlined by the Canadian Cardiovascular Society. And I will also briefly discuss some of the mechanical support options that may be available for these patients when they decompensate. I will also discuss the collaboration and involvement with the various interdisciplinary teams in the care of these patients. So I've organized this presentation into a few different sections. I want to give an overview of acute heart failure and what differentiates it from chronic, how we will assess and diagnose it, and then the management strategies that we employ here at the Heart Institute. So what is acute heart failure? Acute heart failure is defined as new or worsening signs and symptoms of heart failure and can be either de novo or it can be an exacerbation of a chronic heart failure, which is sometimes referred to as acute decompensated heart failure. The leading precipitating cause of de novo acute heart failure is acute coronary syndrome, while medication noncompliance, valvular disorders, infection, and arrhythmias are the most common triggers for decompensated heart failure in our chronic patients. The biggest concern with the acute heart failure is, unfortunately, it has high rates, like Dr. Mielniczuk had mentioned, of mortality, and creates a significant impact on the other organ functions, leading to significant consequences for patient health. In addition to the consequences for individual patients, heart failure admissions create a large burden on the healthcare system. In 2013, there were over 45,000 admissions in Canada for acute heart failure, and this number is only expected to increase as time goes on. So, how do we differentiate between chronic and acute? In chronic heart failure, there are compensatory mechanisms in place that help the body adjust to provide end organ perfusion. But in acute heart failure, the onset happens so quickly that the neurohormonal and sympathetic nervous system changes are unable to occur, or they don't occur fast enough. This leads to the rapid development of pulmonary edema and progressive circulatory failure, and if not corrected, it can lead quickly to cardiogenic shock, which is this slide. So with acute heart failure, it can progress in two ways, really. We treat the underlying cause, offload the heart, the patient recovers, and follows the trajectory that Carolyn had laid out in her presentation. The other way, the patient ends up decompensating, they progress into cardiogenic shock, which is the most severe form of acute heart failure. Patients in cardiogenic shock may have hemodynamic instability, but not always, and that's going to be really important to remember in this presentation. There are other signs of poor tissue perfusion that may present prior to hypotension, including cool periphery, clammy skin. As a compensatory mechanism, the heart concentrates blood flow to central organs. There may be oliguria, where there's not adequate blood perfusion to the kidneys, which are then unable to produce urine. Confusion, again, there's not adequate blood flow to perfuse the brain. This is why delirium is a medical emergency, because we need to know what is causing them to be having changes in their neurostatus. I have a little story to share. When I was pretty new to the ICCU, when I started working there as a bedside nurse, I cared for a patient. They were admitted fairly late in my shift, around 3 p.m., and nothing that I did could get this patient comfortable. I repositioned them. They were just squirming and looked very uncomfortable. Just a little bit agitated. And then about 15 minutes left in my shift, he pulled the pillow from behind his head, which had his pulmonary artery catheter clipped to it, so the wire's floating in his heart, rips it out from behind his head, and I was like, oh my goodness, like, you're going to pull your wire out, and then he arrested. We worked on him for half an hour, got him back, luckily, and he ended up having to go down to the CSICU for mechanical circulatory support. And I think he did okay, luckily, but that agitation, ever since that happened to me, I would have a patient who was a little bit agitated. I'd be putting my hands on their legs. Are they cold? Are they poorly perfused? And what was their last lactate? I love my lactates in CCU. So anyways, speaking of lactates, while an elevated lactate is not a direct reflection of low cardiac output, it can help identify the sicker patients who have less physiologic reserve and need more aggressive management. On this slide, you can see the SCAI classification pyramid, which was created by the Society for Cardiovascular Angiography. This is the tool we use here at the Heart Institute for measuring where patients fall on the spectrum for cardiogenic shock, with the majority of our acute heart failure patients being in the at-risk portion. And some do progress to the deteriorating or extremist phase, where they are very, very sick. Sorry. And sometimes these patients, I'm sure as you guys can attest, they're already presenting in the deteriorating or extremist phase. This classification is helpful for guiding care, especially when taking the time to consider escalating therapies for advanced mechanical therapies like Impella or LVAD or balloon pump. I do want to draw your attention to Sky Class B. In particular, the patient having tachycardia or specifically sinus tachycardia. We have a saying in the ICCU that there's no rhythm more scary than sinus tachycardia. Obviously, pulseless rhythms are not ideal either, but at least when you have a pulseless rhythm, you know what's happening to your patient. So with sinus tachycardia, the patient is compensating for something, and your concern is how long are they going to compensate for before they deteriorate. As well with tachycardia, you want to treat the underlying cause and not just treat the tachycardia. We have to be particularly careful with beta blockers in acute heart failure. I know Carolyn talked about how much they benefit our patients who have chronic heart failure, but when we give them with patients who are in acute heart failure, they have a negative inotropy, and that can actually precipitate cardiogenic shock in these patients. So while they are very helpful in the management of chronic heart failure because they prevent the heart from working too hard, in acute heart failure, that heart needs to work hard to maintain adequate tissue perfusion. So the diagnosis of acute heart failure is based on the clinical assessment. The presence of natriuretic peptides, my favorite word to try and pronounce in front of so many people, and the different imaging modalities. On this slide, I've highlighted some of the workup for a patient suspected of having acute heart failure, whether that's coming in through the STEMI room, through the emergency department, whether these patients are being seen in clinic and being identified as having an acute decompensated episode. So about 80% of patients in heart failure present through the emergency department. And unfortunately, they don't all come with a diagnosis, although that would be very handy. So the priority is stabilizing the patient, treating any life-threatening conditions like hypoxia, hypotension, and then focusing on the differential. Once the patient is stabilized, a full patient history and physical exam should be done. If acute heart failure is suspected, the history should evaluate for comorbidities such as hypertension, dyslipidemia, coronary artery disease, any chest pain the patient may be having, any histories of valvular or arrhythmias, abnormalities that they may have had. And also it's important to note when the onset of symptoms started. And also the physical exam will be important to identify signs of congestion, volume status, signs of adequate perfusion. Can anyone tell me what you're watching for signs of congestion? I know you all know it, but you're checking for, oh, sorry. No, please. Oh. So we would be watching for crackles, edema, abdominal pain, ascites, peripheral edema, elevated JVP, nausea, the list goes on. But I do want to draw your attention to this slide. I won't go through all of it, but it represents, I don't actually know how to use this. Oh, there we go. The feature of poor perfusion that a patient may be having, along with the associated physical exam and what that means to the patient. Sorry. So the patient may have crackles and dyspnea, and which would on exam look like crackles, low sats, and may represent left-sided heart failure in these patients. I know Carolyn kind of spoke already about the natriuretic hormones, but I'll just add a little bit to my presentation because they do play an important role in the diagnosis of acute heart failure. So these are hormones that the body uses to regulate circulation by causing blood vessels to dilate. They're excreted in response to ventricular distension, and they also influence the kidneys to excrete water and sodium. Patients will demonstrate a rise in their serum levels when they are experiencing myocardial stress and volume overload. At the Heart Institute, we measure NT-proBNP levels, and that's because it is actually stable for longer in laboratory samples compared to total BNP levels. That's the only reason that's why we use those. So testing for these is useful for confirming or ruling out the diagnosis of heart failure, especially for those patients that are presenting with dyspnea and you're not really sure what's going on with your patient. The blood test is fairly quick to come back from the lab. And it is important to note too, there are other medical conditions that can affect the levels in patients, such as obesity. It'll actually lower, I believe, the BNP levels in the blood. This slide, I've included a table with the guidelines from the Canadian Cardiovascular Society for the BNP levels needed to confirm heart failure. So the final component for diagnosis is the imaging that is done for these acute heart failure patients. Generally, they will have a ECG and chest x-ray. These are safe and easy to obtain tests, and they can provide you with quite a bit of information. Remember, a major part of the therapies in treating these patients is treating the underlying cause. So ECG to assess for arrhythmias, an ACS, chest x-ray to identify other causes of dyspnea. An echo is considered the gold standard for assessing heart failure and is helpful for identifying the particular phenotype. And right now there's increasing availability for point of care ultrasounds in smaller hospitals and for bedside exams when there's not the availability of a formal transthoracic echo. On the right side of the slide, the key findings for acute heart failure that may be evident in the imaging modalities used for diagnosing acute heart failure. And then if indicated, based on diagnosis and patient presentation, the patient may be sent for a left heart cath to assess the coronaries if they are presenting with an ACS. For a long time, there hasn't been a lot of evidence for anything other than revascularization for improving shock. They also may need a right heart cath depending on the severity of their condition and if there is a concern for needing mechanical support. For standard heart failure management though, pulmonary artery catheters are not recommended due to the risk for adverse events. And then also nuclear scans, cardiac MRI, cardiac CT also may be used to identify the phenotype of acute heart failure, but these modalities are not as easy to access, especially in more rural hospitals. So they're not generally part of the initial workup, but they may happen during the patient's admission to hospital. So now we'll dive into the management of acute heart failure. Depending on how patients are presenting, managing life-threatening conditions, as I mentioned, is the priority. So ventilation and hemodynamics will be the first priority, followed by treating the underlying cause and supporting organ recovery, whether that is medical management or advanced therapies like mechanical support. So this decision support tool comes from the Canadian Cardiovascular Society and is quite helpful for the general management of acute heart failure based on the patient presentation. So we will target an oxygen saturation of greater than 92% unless the patient has a pre-existing condition where we would want to target a lower saturation, such as COPD. We use oxygen and then we would escalate to non-invasive ventilation like CPAP or BiPAP. If not contraindicated, and then we would do mechanical ventilation if needed. It's important that respiratory therapy and anesthesia or cardiologists with critical care are involved with the management of these patients early to avoid a crash intubation, because that's can be very harmful for the patients and overwhelming for staff, of course. For hemodynamics, we usually target a systolic blood pressure of 90 to 100 or a MAP of 60 to 65, but it's important to be always assessing for features of poor perfusion. A normal blood pressure does not always equal adequate perfusion, so just something to keep in mind. If the blood pressure allows and there is poor response to Lasix, we have room to add some afterload reduction. In the early acute phase, we generally use IV nitro for afterload reduction. It has a short half-life, of about 3 minutes. If the patient decompensates, you can turn it off and your patient isn't going to be clearing that medication for several hours. For hypotension, our first line at the Heart Institute is usually norepinephrine, except in a small subset of patients. But for the most part, we do use levo. Inotropes, milrinone and dobutamine, are used to treat low cardiac output by increasing myocardial contractility. At the Heart Institute, ICCU participated in the Do-Re-Mi study, which compared dobutamine to milrinone, and it found that there was no difference between the two in patient outcomes. So physicians here will choose based on their preference and the side effect profile. At the Heart Institute, inotropes are titrated with a physician's order based on the patient's cardiac output and not for low blood pressure, as they can in fact lower blood pressure because of the associated vasodilation. And again, normal blood pressure does not equal perfusion. So how do we manage volume overload? First line is diuretics, of course. Furosemide or Lasix is the diuretic of choice, and that's because that's what we have on formulary here at the Heart Institute. When I started to make this presentation, I kind of made the joke that I could talk for 35 minutes just about Lasix, but I've tried to cut it back a little bit. Anyways. Quick reminder, Lasix is a loop diuretic, which have the highest capacity for diuresis compared to other diuretics. For patients with volume overload, we are targeting 3 to 5 liters of urine output in 24 hours. In the acute phase, we use intravenous Lasix, so we don't have to worry about the systemic absorption. We want to diurese these patients fast to avoid them going into worsening pulmonary edema, requiring mechanical ventilation. We start with bolus dosing to reach our urine output target, but there are a number of different factors that will influence how effective that Lasix is, including how well the kidneys are working, if there's poor adherence to sodium and fluid restriction. Usually isn't a problem in the ICCU, where we are very strict with patients' fluid intake. And then poor absorption of the diuretic. Some patients have never had Lasix and they dump urine very, very quickly, whereas other patients who've been on it for a longer period of time, they don't diurese as well and end up needing higher doses. If intermittent Lasix is not effective, we may consider switching to a continuous infusion or adding another type of diuretic, such as metolazone, to create a synergistic effect by targeting a different area of the kidney. We sometimes will also use inotropes for a synergistic effect as well. When diuresing patients, We want to have accurate ins and outs and a daily weight to monitor volume status and to monitor how our fluid removal is going. In the ICCU, we are reassessing volume status as frequently as every 4 hours because these patients are so tenuous. We also should be keeping a very close eye on the electrolytes to prevent cardiac arrhythmias. Sometimes we'll have patients who've had no history of arrhythmias or anything like that, and then all of a sudden the telemetry is showing they're in VT or they're suddenly going into atrial fibrillation. And while that could be because their heart is weak, it also could be because their electrolytes are low. So you'll check their blood work and you'll find their potassium is 2.8, and that's time for a PRN at that point. We are also keeping a close eye on their renal function to monitor for any kidney injuries. However, some patients will have an improvement in their renal function after diuretic therapy when they have less congestion. Supporting organ recovery focuses on ensuring perfusion and alleviating congestion to avoid ischemia. Patients who develop acute kidney injury with heart failure, we can try diuresis, although there is a delicate balance to not worsen the injury that they've already had. If we are not having any success with medications, consideration should be given for renal replacement therapy. In the acute phase, these patients can be very tenuous and they may not tolerate intermittent dialysis like hemo, and they may require going on continuous renal replacement therapy or CRRT. I think the main building in these situations uses SLED. The buildup of congestion can lead to shock liver and poor abdominal perfusion. Sometimes the team will consider NPO status to rest the bowels in the very sick patients because we don't want to feed them when they're having poor perfusion. You'll end up with gut ischemia. We want to manage any metabolic disturbances that arise. Sometimes the body can resolve these with medications, but other times we do need to use dialysis to remove the waste products. And usually, for ventilated patients, the less sedation, the better. But in these very, very critically ill patients, we will target a higher sedation scale to reduce the metabolic demands on the heart. And as mentioned previously, we will target oxygen scores of greater than 92%, whether that is with oxygen, non-invasive, or invasive mechanical ventilation. So early identification of shock and the use of mechanical support is associated with better outcomes for patients. So the Heart Institute initiated the Code Shock Protocol in 2016 as a multidisciplinary approach to patients in cardiogenic shock. The code activation is a similar approach to our code STEMI protocol in that it sends out pages to the appropriate team members and they are responding within 30 minutes to these patients. However, you won't hear it called overhead like you hear the code STEMIs, because in the ICCU it does happen fairly frequently. So patients who are category 1 with no prolonged downtime from a cardiac arrest and no advanced comorbidities are identified based on the criteria in step 1. Nursing and our community partners play a critical role in step 1 by assessing the patient's vital signs, urine output, reviewing the labs, titrating the medications, etc. In step 2, the CCU resident and the attending make the decision to speak with the heart failure team, who will be the ones to decide if a code shock should be initiated. When it is activated, or before they activate it, they may decide to make some suggestions with the medications and see if they can help the patient that way. And if they do not think that and they activate a code shock, they will have a meeting of comprising of heart failure CCU, cardiac surgery, and interventional cardiology to assess if this patient is a candidate for mechanical support. A lot of times this conversation happens in the unit as a multidisciplinary team. They make the, they'll make the decision whether or not to proceed to mechanical support, or they may make some more decisions for medications. They may try CRT at that point. But it has been studied and it has found to be feasible, and it may be associated with longer term survival in these patients. So temporary mechanical circulatory support. Some of the other presenters will be discussing these devices later today, and they, I'm sure, know much more about them than I do. But I won't say a lot, but essentially mechanical circulatory support is used for patients in cardiogenic shock to maintain adequate tissue perfusion until there's patient recovery or until transplant. Oh, yeah, okay. So depending on the acuity of the patient in acute heart failure, there are a huge number of people that these patients see during their stay within hospital. And I'm sure I have missed people, and I'm so sorry if I did. And I can't begin to discuss each specialty, but I included everyone that I could think of so that you can get an idea of how many people are involved in taking care of one of these patients. Essentially, as a group, we are working to prevent the progression of disease and prolong patients' survival while maintaining quality of life, addressing underlying causes. And remember, that doesn't have to be just medical problems. Like Carolyn said, there can be a lot of social problems that these patients face, contributing to their illness as well. We also want to prevent readmissions. And I would also like to emphasize that the patient is a part of the circle of care, and in making the decisions, the trauma that people go through, especially in the ICCU, to get better is not something that everybody is interested in pursuing. So keeping in mind our patients' goals of care is very, very important. Okay, thank you for listening to my presentation. Does anybody have any questions? Okay.
Thank you so much, Laura. I just want to shout out to Laura. She's new to our team for about a couple weeks, so for her to come up and do that, that's pretty impressive. Well done. Our next presenter is going to touch on a topic that we've already sort of touched on a little bit, but now we're really going to delve into it. I'd like to invite Jossline up to talk about cardiac rehab.
I'm glad I'm not the only one that was nervous. So good morning, everyone. Thank you for joining us today and joining me for this session on heart failure and exercise. My name is Jossline Jeha. I'm a physiotherapist here at the Heart Institute in the cardiac rehab program. So today I'll be giving you an overview of our cardiac rehab program, a quick overview of the programs we have to offer. And I will kind of talk about where cardiac rehab starts, and I'll be reviewing some of the exercise guidelines. Oh, there's the mouse. There we go. Is there a paper? Oh, there we go. The mouse is not moving very well. There we go. So when does cardiac rehab start? I think that question was asked earlier. Often I would say cardiac rehab starts in acute care. patients with heart failure that are admitted to the Heart Institute are encouraged by our staff. So whether it's nursing staff or allied health staff, such as physiotherapists or occupational therapists, to participate in daily physical activity. We need to keep them active. We need to keep them moving in order to preserve their baseline function. So by doing so, it helps them stay strong for return to home. And at times, they also improve their baseline function because they're walking more than they would if they were at home alone, for instance. They're encouraged to go for walks several times a day or do chair exercises. So again, during their stay, patients who are seen by physiotherapists at the Heart Institute are given an individualized walking program, and when appropriate, are given exercises as well to do. They're provided with the heart failure guide and the stoplight tool. So the education starts at the bedside. These two tools allow the patients to get the knowledge they need to manage their disease, because a lot of the times it's a new diagnosis. They're overwhelmed with the information. They hear the word heart failure and then everything just stops, as Carolyn said. Nothing else goes in after that. Once it's time for discharge, they're invited to attend a virtual heart failure discharge class. Again, where more information is provided. So again, you see that we keep repeating, we keep educating and showing them that we're there to help. And if eligible, they're invited to join our cardiac rehab program, our outpatient program here. So a referral is put in if they meet the criterias. Now, once they've been invited to our program, they can also join a webinar that we have that's called While You Wait for Cardiac Rehab. So again, we're bridging that gap between the cardiac rehab referral and when they actually start cardiac rehab or have their first intake. That webinar provides them with more information about what they can do while they're waiting for cardiac rehab. If they have any questions, we review important information regarding symptom management and general post-discharge information. Attendance in cardiac rehab can reduce the chances of being readmitted to hospital by 31%. It also helps lower mortality rates by 25%. That's according to the cardiac rehab and CVD prevention. There's strong evidence that outpatient cardiac rehab or even secondary prevention is a useful, effective treatment for individuals with a HFrEF, and moderate evidence with those with stable systolic, with moderate stable systolic heart function. So cardiac rehab is an important part of the patient's journey. This slide shows you some of the programs that we offer here at the Heart Institute for our heart failure patients or our cardiac patients. So cardiac rehab is part of the continuum of care we provide here at the Heart Institute. It assists the patients in acquiring the skills and knowledge they need to live a heart-healthy life and return to their everyday activities and get back to, living, I don't want to use the word normal, but their regular life, what they're used to, their routine, and that's what they want and that's what they need. It's tailored to the patient. Again, it's patient-centered. We try to tailor it as much as we can to the patient and provide them with what they need. Examples of what we offer are, we teach patients risk factors, so heart failure risk factors. We do medical assessments. They can be seen by our cardiac rehab doctors. We do exercise training, so help them return to exercise, guide them, create new habits. Some of them have never exercised, so we need to teach them how to start, what they can do. Nutritional counseling, quitting the smoking cessation program. Also, we can refer them. So there's many things that we can do here that to help the patient, part of our cardiac rehab program. So we offer on-site classes. We offer virtual exercise classes, which is fairly new. We have case managed home program and the Francophone program. So the Francophone program is for Franco-Ontarians. So for those who speak French and live in Ontario, we have a program just for them. We have the brief program and we have the virtual care platform. The 4 last ones are all done virtually or over the phone. Actually, the virtual exercise classes need to be done virtually because you need to see the exercises. Within our program, as Carolyn said earlier, we have what we call the Cardiac Rehab Virtual Education Series. This is dedicated to our heart failure patients. We have one for our CAD patients, and this one was created just for our heart failure patients. So there's 8 sessions, and they're constantly rotated. So every week is a different topic, and it's given by different healthcare professionals. Patients can jump in at any time. They don't need to start at the first one or wait until that first session starts again. So they're given on Wednesdays, I think at 10:30 a.m. virtually. They log in, and if they feel they need that session again on meal planning, well, they'll just have to wait, count how many sessions, and come right back to that. We also have it on our UOHI website, on our YouTube channel. So there's a link as well. If they want to listen again to those sessions, they can. So newly added is our virtual chair exercise class. It started as a class that we introduced and I started doing is for heart failure patients. I wanted to create an exercise program that heart failure patients can do. So I figured chair exercises would be the best way. And I created a program that would suit people that are just starting out, that are sedentary, they're not used to exercising, don't think they can, and that they can use to also gradually increase their activity level. So all the exercises done in this class can be done either in sitting or standing, and the patient chooses what they want to do. So every exercise is done for about 30 seconds, 30 to 40 seconds. So it gives them the time to do a little. If they need to take a little break, they can. Then we move on to the next exercise and we repeat them. So it's not complicated. They don't feel overwhelmed and they know they can make it work for them. And I encourage them to listen to their body and do what they can. It's also, there's a link that we provide them with so they can do it on the days where they're not doing it with me. They attend the class with me virtually once a week, but I also encourage them to try to do physical activity or any kind of activity during the week. So I provide them with the video. The next slide gives you an example of, I apologize for the misspelling there, gives you an idea of the guidelines we provide our patients. So when patients are in our program, we provide them with exercise guidelines. We base our recommendations on the American College of Sports Medicine heart failure guidelines. They're also very similar to the Canadian Cardiovascular Society guidelines that are in the Heart Failure Pocket Guide. So there's a table and it gives some of the recommendations. They're very similar to that. I'll be going through here and explaining what our recommendations are, but it's very important to remember that any exercise guideline we give is made for every patient. I'm not going to give the same guideline to 3 patients. Everyone will have an individualized guideline. I will take the information they give me about them, about what they're capable of doing, and I work with them to create this exercise guideline to help them increase their activity level. So the first thing we teach, it's important to do a warm up and cool down. We want to let our patients know that you don't want to jump into an activity right away. We want to warm up the body. We want to allow the body to gradually increase that heart rate, gradually increase the blood pressure. Usually we recommend a warm up of about 5 to 10 minutes. For some patients, it's just walking around their kitchen a little bit, moving around, or it could be just some, moving their arms around, their legs, moving their body a little bit, because that's all they can give me. For others, it's going to be, starting their walk, walking at a slow pace before they increase their pace. Same for the cool down. Once we're done, we want to make sure that we slow down that activity to allow that blood pressure and heart rate to come down nicely. This helps avoid any unwanted symptoms as well, especially with patients with AFib. It could decrease their symptoms. Now, when it comes to giving exercise guidelines, we follow the FIT principles. So you'll see we have frequency, intensity, time, and type. And again, these are just the guidelines according to the ACSM. We make sure we adapt this program to every patient's needs. The recommendations are to do exercise 3 to 5 times per week. And this is for heart failure at a light to moderate intensity for 20 to 60 minutes. Now, that 20 to 60 minutes can be a lot for a heart failure patient. So when I initially teach them the guidelines, I tell them, don't worry about that 20 and 60 minutes. Let's see what you can do. Any activity you can give me is better than none. So we always try to encourage them and give them the confidence to do what they can, because sometimes the numbers that we give and show them can be overwhelming. And that's not what I want to do. I want to encourage them to show them that you can. You try, we'll find something that works for you, and we can get there. So if it's accumulating those minutes throughout the day, so if we want, they can't give me more than 5-minute walk, perfect. Let's start with that. Then let's try to increase to 2 5-minute walks. Again, anything is better than nothing. And we start small with our goal to increase gradually their endurance. So we teach them various ways to determine the intensity of their exercise, because we want them to understand what intensity we want them to work at and what's going to be beneficial for them. So in our cardiac rehab program, we use 3 different ways to do it. We have the heart rate. So with patients, usually we're looking for 20 to 30 beats per minute above the resting heart rate is a light to moderate intensity exercise. Again, that's just a guideline. It's just an idea to teach you what a light to moderate exercise is. But a lot of these patients are not going to get their heart rates to 20 to 30. They're on beta blockers. They're on medications that won't allow that heart rate to go up. So I may not get that number. So what I do use is the RPE scale. It's the Borg scale, rating of perceived exertion scale. It's a subjective scale that rates your level, your overall level of exertion and fatigue. This one I use in my heart failure chair exercise class. I don't get patients to take their heart rate virtually. A lot of them are overwhelmed. They're older. It's hard to get a heart rate. It's just too complicated. So I let go of the heart rate and I teach them the Borg scale, where we want patients to exercise, or their goal is to eventually exercise from 11 to 14. So those are the recommendations for heart failure patients. Now, if the patient stays at 11, I'm great with that. If that's all they can give me, but I can get them to exercise 3 times a week at 11, I'm very, very happy. We don't have to get to that 14. It's patient-based. You have to take every patient and work with what they can give you. We also use the walk-talk test. So you want to be able to walk and talk. Now, if you can sing a song while you're walking, I'm going to tell you to speed it up a little bit. That means it's a little too slow. But if you can walk and hold a conversation, but every once in a while you're giving me that breath, that, okay, this is a little bit, but that's a moderate, light to moderate intensity, okay? So we teach them that as well. With all of this, I always refer back to the stoplight tool. That is a very important tool for our heart failure patients. If they are in the green zone, then you're okay to exercise. If you are in the yellow zone, that means you're starting to have symptoms, you've gained a bit of fluid weight, you're not feeling the hottest, I need you to call to get some of those meds changed and looked at. I don't want you exercising, okay? Again, we're trying to avoid to go to the red zone. So if we can catch our patients in the yellow zone, we're very happy. The red zone usually means they're being readmitted and you're not exercising in those red zones either. It's very important to teach patients to listen to their symptoms and exercise or do activity within their symptoms. A lot of them come with a lot of comorbidities, so we have to keep that in mind as well. Some need knee replacements, some have back issues. There's a lot more involved there, so we have to be mindful and try to help them find something that they can do and stay active. In our heart failure guide, we give options of what the patient can do for exercise. Like if they want an example of a walking program. Usually if they're seen by physio inpatient, they have provided them already with an exercise program to keep them going until they get into a cardiac rehab. And the program that they provide them with is based on these two options. So the physiotherapist that sees the patient will come up with a walking program for them. The first one here, it kind of gives you an idea of how you can progress your walking. Again, if 5 minutes is all you can give me in a day, maybe try giving me 5 minutes in the morning and 5 minutes later in the afternoon, and that's okay. You don't have to try to do the 10 minutes all at once. So this one just gives you an example of how we can progress their walking. There's also the interval training, and that's a very popular one with our heart failure patients. So if they can only give us 2 minutes of walking and 1 minute of resting, then we're going to take that and say, okay, perfect. Walk 2 minutes, rest for a minute or two even. And then if you can walk another minute or two and rest to accumulate that 5 minutes. And we keep doing that until we can progress the walking time and reduce the sitting time. And these are, again, just examples, and they're given in the heart failure guide. Once they're in cardiac rehab, then we really individualize that walking program or that exercise program for them. Strength training is very important as well. And that's part of the guidelines. It's recommended 1 to twice a week, non-consecutive days. A well-rounded exercise program will include aerobic exercise, will include strength training and stretching. So remember, it doesn't have to be heavy weights for it to be beneficial. I'm not here to bulk my patients up, and I always remind them, you're coming to the cardiac rehab program, especially my heart failure patients. We're not going to run a marathon. That's not my expectation. We're just going to do some activity, and we're going to keep you strong, just so that you can feel confident to do your everyday activities, to feel strong, maybe allow you to sleep better. So strength training is important. It helps increase the patient's metabolism, right? Muscle increases metabolism. So in return, that may help the patient as well. Allow them to do their everyday activities. When we have muscles that are atrophied because we're deconditioned from being in the hospital, from not feeling well, we have a hard time getting up and moving, going up those stairs. We have a hard time just getting up from a chair. We need to build those muscles, keep them toned in order to do those activities. And when they're feeling strong, they feel confident. Again, so when we're looking at how heavy we should lift, we're not looking for anything heavy. It's light to somewhat hard, enough to be able to do 1 to 2 reps. With our heart failure patients, come guidelines. A lot of times doctors will recommend no more than 10 pounds overhead, because we want to avoid that Valsalva maneuver. We don't want them to be holding and bearing down and grunting when they're doing exercises, especially overhead. With some patients, the younger patients, some of the athletes, I will work with the doctors to see what we can do to help progress their exercise as well, their strength training programs. As long as they're doing it properly and not holding their breath in and grunting, we can progress their strength training program. So we can use resistance bands, light weights, household objects. In my class, I've had people use books. They don't have weights hanging around the house, so they'll go grab books, a soup can, cans of soup, the water bottles. We'll use anything as weights, and sometimes it's enough for them, and it works well. Stretching is also important. So we teach them stretching. It's very beneficial for the joints. It gives you better posture, reduces your risk of injury. We do the stretching during the cool down. So we recommend that stretching is done during the cool down. It's a great way of cooling down as long as you don't hold your breath in. So we teach them the right ways of doing it. Also part of all the education on exercise. We teach them the signs of overexertion, which is very important to listen through their bodies. Seasonal considerations, because that can affect where they do exercise. Energy conservation is very important. We don't want to deplete their, oh my goodness, I forgot the word. I'll get back to it. Air quality considerations as well are very important with our heart failure patients. So they need to look at that air quality index. Exercising outdoors, like for instance, last year with the smoke, the humidity, that is a no. We want them to move everything indoors. Compliance with medication is very important as well when it comes to exercise. So all of these teachings are done in our cardiac rehab program, and it's about repeating all the time so that eventually, you know, it takes time for them. It's overwhelming. It's a lot of information being thrown at them. So we want to take our time at teaching them. And for them to make the changes, they may not change everything at once. They may not give me 3 days a week right off the bat. They may start with 1 day a week, right? Because that's all they can give me right now because they've got to do other stuff. So I work with them. We work with that and to help them feel better. These are the guides that we give. So our recommendations, the heart failure guide has a lot of information. Our cardiac rehab physical activity guide has a lot of information as well. It's not geared towards our heart failure patients, so I'm always letting them know what to take from that booklet because some of the guidelines might be a little different, but it's great information. And at graduation, we give them a lot of resources. There are a lot of programs in the community that offer free virtual classes to our patients within the LIN. So the LIN has virtual classes, and they can find a class that's done virtually, and these patients can attend once they're, or even during, or once they're done in the cardiac rehab program. We have the HeartWise program. There is our support groups. We have a heart failure support group. There's a lot of things for our patients, our heart failure patients. All of these can be found on our Heart Institute website under patients and visitors and tools and resources. So all the guides can be found there and the videos. So the videos that I was talking about are all there as well. Remember, exercise does not have to be done at a high intensity for it to be beneficial. It could be done in a very relaxed manner for these patients. We always want to remind them that some is better than none. Whatever they can give us, we'll start with that, create some confidence for them to be able to do more. I have an example. One of my patients was doing the virtual class, and one day, you know, I started class and he's like, "Stop, I need to tell you something." And I said, "What?" He goes, "I put my pants on today without sitting down." So for him, that was a huge improvement. And I was so happy, and I applauded his efforts because he was really trying. He had goals. And by the time he graduated, he felt better. His endurance had increased. He was trying to find, he was walking indoors in the parking garage in his apartment building. I had another lady that was so happy because she was able to go back outdoors and do a little bit of gardening. Maybe it wasn't at the level that she used to do, but she was able to get outside on that back deck, down the stairs to get into her garden beds to work a little bit. So those little milestones, or, you know, I say they've attained great goals, are something to commend, because it takes a lot of work for a lot of these patients. And this is why we created that virtual exercise program, because sometimes coming on site was just too much. It depleted their energy reserve. That was the word I'm looking for. And that's why we teach energy conservation, is to not deplete their energy reserves. Thank you. Is there any questions? Am I allowed questions? Yeah, okay. Oh, there's questions.
Who can be referred to the program?
So patients that are there is a criteria. So when they're in inpatient, we do have criterias for them to be referred. But I mean, a lot of people you mean within hospital or outside hospital? So outside hospital, they can be referred from their doctors as well, from their cardiologists that are outside of the Heart Institute as well. And then we receive the referral. We have people that look over those referrals and send the invite out. Yes, Quebec patients are allowed. We do have therapists. So in my virtual class, unfortunately, I can't have Quebec patients. I have to be licensed, although it is Quebec, I have to be licensed for Quebec patients. They are allowed on our on-site. We do have programs where we have physiotherapists that are licensed for Quebec, and they can attend, they can be in that program with them. Yeah.
Have to be a physician, or would you accept like a community paramedic, or
That's a good question. I can find that question. I can find that answer out for you. By the end of the day, I promise I'll have the answer for you. Yeah.
I think along the same lines, can nurses refer patients?
Yes, they can. Oh. So I think nurses can refer to cardiac rehab. Yes. So whether they're seen by a physio or not in the Heart Institute, they can be referred by a nurse. It doesn't necessarily have to be the physio. Yeah.
And Nadine online just wanted to clarify, French or the only option for Franco-Ontarians is virtually, or is there?
No, on site.
Okay.
Yeah, they can come on site. If they're doing it virtually, then we make sure we connect them with a physio that has their Quebec license as well, and then they can do a virtual program. Yep. Yep. So a lot of our heart failure patients have the special parking pass, the disability parking pass. They can park at the meters for up to 4 hours free or in the no parking zones. So we always remind them of that. They don't have to pay for the parking. Yeah. Yeah, so we need to remind them of that, and it's less stressful and it provides them that chance to come in. So heart failure patients don't necessarily just have to do the virtual classes. They can come in. We have low intensity classes. We have great classes for them on site. As for parking, if they can't afford, we can always go to our social worker, see if there's anything they can do to help. But again, you can buy parking passes if you buy them in bulk. They're cheaper as well. We provide them with different information for that. Thank you.
Thank you so much, Jossline. That was great. Cardiac rehab is so important for our heart failure patients, and it was excellent to learn how it can be individualized to their care. Next, I would like to bring up Kathleen Turner to talk about nutrition for these heart failure patients.
Hello, everyone. It's nice to see you. I feel like it's been a while since I've spoken to this group, so I'm happy to be back. My name is Kathleen. I work in cardiac rehab. I'm one of the dietitians in that program, and we're talking about nutrition and heart failure today. And I feel like I have some new stuff to tell you this time, which I'm excited to share. Maybe it's not new, maybe you all know, but anyways, here we go. So I do always like to start this talk, or any talk to be fair, just reminding people that this is hard for our patients to make changes to their diet. It is hard in every aspect. It affects their life in terms of day to day, the food choices they make, they get overwhelmed. It affects them in terms of how do they go to dinner with their family and friends to celebrate an event, right? And so I always try to acknowledge this with patients too. I do a talk to patients about heart failure, and it's the first slide I show because I think we sometimes forget when we talk to patients every day, all day, oh, just limit your sodium, no big deal. But it is kind of a big deal. So we just always want to remember how hard these changes are to make for your patients. So if I were to say heart failure to you, how many of you, your first thought is sodium? Oh, not that many. I'm kind of shocked. All right, well, that didn't go the way I thought it would. But anyways, that's fine. It's keeping me on my toes. So I think for a lot of us, when we think about heart failure, the first things we think about are sodium and fluid, except for you folks, but that's fine. So traditionally, we have really restricted patients' sodium intake. We've told them sort of 1.5 to 2 grams of sodium per day. And this is changing. So in 2017, the Canadian, the CCS guidelines came out and they recommended 2 to 3 grams of sodium. And just, 2 years ago now in 2022, the AHA also was recommending 2 to 3 grams of sodium per day. At the Heart Institute, we just updated our heart failure guide and it's out now and it says 2,500 milligrams of sodium per day. So this is really exciting. The reason for this is that the evidence didn't necessarily support that going below 2 grams per day had benefits for patients. It didn't show decreased mortality. It didn't show reduced hospitalizations. It didn't necessarily show improvements in terms of quality of life. And in fact, the unintended consequence of limiting people's sodium to 2,000 milligrams per day is that we had increased undernutrition, so malnutrition, because people were so afraid to eat sodium that they were limiting all kinds of other foods that they were eating. So when we gave these patients this really strict number, it ended up kind of backfiring on us and not necessarily giving us the improvements that we thought. So this is actually a pretty dramatic change in terms of nutrition and heart failure. It's been around for a few years, but it takes time for us all to wrap our heads around this message. So bottom line for your patients is that they probably do not need to be as strict as we have traditionally been when it comes to sodium intake. This is a quick reminder. I know you all know this, but a teaspoon of salt has 2,300 milligrams of sodium. But be careful how you tell this to your patients, because patients will measure a teaspoon of salt and they'll put it in a little container in their kitchen and they'll use it all day long. So they forget that there are other sources of sodium in the food we eat. So the average Canadian eats about 3,700 milligrams of sodium in a day. And the vast majority of that, 75% of it, is coming from prepared foods. So it doesn't actually, if you tell a patient they get a teaspoon of salt, it's not actually a teaspoon of salt. It's that sort of cumulative addition of sodium. So what this really means is you probably need to talk a little bit about food label reading with your patients. We ask them to look at sodium, and for heart failure patients, it's really what we want them to focus on is that sodium intake. And so we ask them to look at the percent daily value or milligrams, depending on your patient. Some people like to look at milligrams, some people like to look at sodium. They're aiming for most things they buy to be less than 10% daily value. So if that's the target they can hit most of the time, they're probably doing pretty well. And the other thing I tell patients is they don't have to add up every milligram of sodium they eat in a day, or they will very quickly become frustrated because it's hard to do and it's annoying. So if they are at the grocery store, most things are less than 10%. Once they bring it home and start preparing and cooking foods, then they're in a pretty good spot that they're very likely going to be doing okay in terms of sodium. And of course, recommending they use less salt at the table and in their cooking. Okay. How many of you think that the chips have more salt than a Tim Hortons muffin? Amazing, you all got it right. Or maybe you just didn't want to participate. I don't know. Right? See? Thank you for admitting it. So I think a lot of us have preconceived notions about where the salt in what we're eating comes from. This is a perfect example. A bag of Lay's potato chips. I'm talking about the like regular standard corner store small bag, not a family pack, small bag, has about 440 milligrams of sodium in it. A blueberry muffin from Tim Hortons has 590 milligrams of sodium. So, and I am not talking about the muffins you might make at home or your patients might make at home, but we have these assumptions about where this sodium comes from, which is why it's really important for your patients to actually look at the food labels of the things that they're eating. And just an FYI, if you buy those little Halloween packets of chips, you know, they sell them in like bags all the time now. One small bag of Lay's chips only has 120 milligrams of sodium. So that's a great way for your patients who like chips to still continue to have those chips. I think it's also fair to say that there's a ton of lower sodium options coming out now. There are more options for patients than there were 5 or 10 years ago. Okay, fluids is the other place we saw big changes. So both 2017 guidelines and the 2020 AHA or 2022 AHA guidelines have recommended that not all patients need a fluid restriction. So this is also a very big change. Again, it's usually the doctors who set a fluid restriction, not the dietitian or the nurses or whatever discipline. I didn't ask what discipline was in here, but wherever you might be. But that is also a big change. So the recommendation is that not all patients benefit. The only patients who might benefit are patients who are very congested or have a lot of fluid retention. They also recommended in the 2022 AHA guidelines that going below 1.5 or 1.5 below may have unintended consequences around things like dehydration, quality of life, and kidney impacts. So again, these are really big changes in the heart failure world away from this incredibly strict 1.5 to 2 grams of sodium and our 1.5 to 2 liters of fluid. And in our new heart failure guidebook, the fluid restriction actually says as prescribed by your doctor. So we've removed the standard fluid restriction recommendation. All right, I also want to talk a little bit about alcohol. I don't have exciting news here about alcohol, to be fair. We do recommend that patients who have heart failure do not drink. This is not that different now from the more recent Canadian guidelines, right? So the new Canadian guidelines that came out last January, well, actually, no, January 2023, recommended that all Canadians limit their alcohol intake to less than 0 to 2 drinks per day. If you have that, you have no to low risk of any chronic disease. 2 to 6 drinks per day, you have an increased risk of some types of cancer. What? Per week. Oh my God, per week. Please do not say per day, per week. Thank you, Joss. I was like, something is wrong, the look on her face. Per week. If you are drinking more than 7 drinks, increased risk of chronic disease. But for heart failure patients specifically, we do recommend that they don't drink. If they are drinking, try to limit it to, 0 to 2 per week, not per day. The other thing I want to touch on here is malnutrition. We see malnutrition a lot in our heart failure patients. We don't have good data on the prevalence of malnutrition in heart failure specifically, but we do have good data on the prevalence of hospital patients. So the prevalence of malnutrition in patients admitted to hospital is 48%. That's a lot. And so even if you think specifically about our heart failure population, it's at least 48%, if not higher. Again, no good concrete data on the prevalence in heart failure patients. Anecdotally, I see it a lot. For many reasons, patients who have heart failure often struggle with poor appetite. They get full quickly. They might have impacts on their metabolism, how they're able to absorb the foods that they're actually eating. So malnutrition in this population is a big issue. We certainly know that cancer cachexia is present, or sorry, cardiac cachexia is present. The data says anywhere from 6 to 48%. So that's a big range, but certainly we do see it. Treating nutrition is not going to cure cachexia, but it can certainly help manage some of those symptoms and things that are happening. So you should probably be screening for malnutrition in your programs. This is a very quick 2-question screening tool. It comes from the Canadian Malnutrition Task Force. It is designed for hospital settings. It is 2 questions. Have you lost weight in the past 6 months without trying to lose this weight? And have you been eating less than usual for more than a week? If the patient answers yes to both of these, they should really be referred to a dietitian to be assessed for malnutrition. I do want to acknowledge that this is a little bit trickier in our heart failure population because weight is not consistent for these folks, right? However, most patients are able to tell you if they feel like they have lost muscle mass, or their family members will say, you know what, they look, gaunt, or you can see they've lost muscle mass. It is not validated in an outpatient setting. We do use it in an outpatient setting because it is very quick. Patients can answer it very easily. So if you are not doing this, it's certainly something to consider in your program, because we do know that malnutrition is an issue. I want to touch on this idea of cook at home more often. So any of you have heard me speak before know that I talk about this all the time. And it is absolutely, in an ideal world, what we want our patients to do. We want them to cook at home more often because they have so much more control over food, right? They know what ingredients are being added. They can control the amount of salt. It's perfect. However, we do not live in an ideal world. We live in a world where people with heart failure often have very low energy. It's hard for them to cook, or perhaps there's not somebody at home who can do that cooking for them. So if they're able to, of course, we want them to cook at home, or they've got somebody to cook at home. But for lots of people, they are going to choose prepared foods. And so how can we help them make the best choice when it comes to prepared foods, acknowledging that that is their reality? So usually what we have them do is, on the food label, look for less than 30% daily value in a prepared meal. So if they're buying, frozen lasagna, frozen, microwave dinner, try to aim for things that have less than 30%, because if you think about that over your day, you sort of get 30% for each meal. It is the reality for lots of patients, so we need to meet them where they're at. And then I talk a lot about having easy meal and snack ideas. I think particularly for our older patients, there's this feeling that a meal is exciting and complicated, and it involves multiple dishes, and maybe it's, meat and potatoes and vegetables, or something else that's got a lot of effort in. It doesn't have to be. It can be poached eggs and a piece of toast. It can be a tuna sandwich. It can be peanut butter and banana sandwich. We want to give our patients really straightforward, easy ideas, so that if their energy is low, they've got things that they can eat, okay? A lot of our heart failure patients too may need to eat often and eat regularly. So if they're struggling with early satiety, so they get full very quickly, they often do better if they have smaller meals more often, having snacks available. I messed up the order of my slides, so I'm just going to keep talking now. So the other option we give them is nutrition supplements. So things like Ensure, Boost. Sometimes I will hear from staff that they're like, but it has sodium in it. But it's got sodium in it, but it's also often replacing a meal or a snack, which would have sodium in it anyways. Patients will often do better with things that are easy to eat and drink, like a Boost or Ensure. If you have patients who feel like they'll tell you it's too sweet, cut it with regular milk, decreases the sodium. High fat regular milk, because we want to maximize their calorie intake. So, having those kind of things, puddings, yogurts, things that are easy to eat, eggs. I also just want to mention food insecurity. Food insecurity in Canada is rising. 18% of Canadian families have experienced food insecurity in 2022. We see this, I'm sure you all see this in your practice all the time. Sometimes patients cannot afford to do what we are asking them. That is not their fault. It is a systemic issue. Please do not make them feel worse than they already do about not being able to afford the things we recommend. I always tell patients something to eat is better than nothing. And sometimes it may not fit those recommendations. If you have patients who are struggling with food insecurity, they may be able to access food banks or other resources in your community. Just keep in mind that they don't get choices about what they get at the food bank. And so, again, they get what's provided for them. There's my out of order slide. And the last thing I want to leave you with is that you can refer to dietitians. If you've got dietitians in your programs or in your hospitals, you can refer directly to them. If they're part of cardiac rehab, they have access to dietitians. If they are not, if you don't have access in your program, you can refer them to home care as well. There'll be a bit of a wait, but there are services there. And that's it. So thank you. Questions? Oh, and these are my references. Does anyone have any questions? None? You're all thinking about lunch, aren't you? I get it. I was glad to see I wasn't the last person before lunch. Thanks, everyone. Yeah, sorry. Oh, no.
Thank you so much, Kathleen. That was great. I especially enjoyed the part about the chips. So now it's my turn, and we're gonna have a little bit of fun before lunch. I'll get you all, if possible, to take out your phones. We're gonna do something interactive. Those who are watching online can also play along. We're gonna do a case study. So now we're gonna sort of put everything that we've seen so far together. So we're going to talk about Mr. Forrest Gump today. He's 67 years old. He has known heart failure with reduced ejection fraction, HFrEF. His last echo showed that he had an ejection fraction of about 35 to 40% with moderate RV dysfunction, severe TR, and moderate to severe MR. In terms of previous medical history, he has had a VF arrest where he ended up getting a CRTD implanted. Unfortunately, Mr. Gump continues to smoke about a half pack per day. In addition, he has atrial fibrillation. So Mr. Gump hasn't been feeling well lately, and he's gone to the emergency department. He's been assessed by cardiology. Mr. Gump tells the resident that he has had worsening shortness of breath on exertion. He's had a hard time doing simple chores around his small apartment. And he's also been unable to lay flat to sleep for about the last 2 weeks. And he uses about 3 to 4 pillows to help him sleep at night. He wakes up in the middle of the night feeling shortness of breath as well. During his assessment, it's noted that he's got abdominal distension and also 2+ edema from the feet up to his thigh. I don't know why that's cut off. So now, bear with me here. I'm just going to switch over to our interactive game. Okay, and there should be, bear with me here. I'm just going to pull up my QR code so that you can all join if I can figure out how. Apologies. Having a hard time seeing. Does anybody see where to grab the QR code? I know there's a button somewhere. That's okay because we have Trusty Faye coming to the rescue. My mouse just isn't
Yeah, it's mouse still here, so keep rolling this way. Yeah. Now it's yeah.
It's fun if I can get it to work. Put it on the paper. Let it slide on the paper.
Yeah.
I'm on paper. It kind of like on that screen over there. Oh yeah, I'm trying to get the QR so it's good. Thanks, everybody. That was painful. Okay, I'll give you a few seconds there to join on in. Awesome. Okay, I'll just give it maybe 20 more seconds here. Still see some people joining. All right. Oh, 1 sec, sorry. Okay, I think we're hovering around 92 there, so that's pretty good. Let's get this show on the road. So I'll join there. All right, so we're going to go to our first question. You'll want to watch your screens. And our first question is, what medications might we expect Mr. Gump to be on coming in from home? 3, 2. Oh, that's my fault. That's okay. Well, we'll go over it. So given his heart failure history and presentation in the merge, we can expect him to probably be on bisoprolol, perindopril, and likely increasing dose of Lasix, and as well as Coumadin for his AFib. So honestly, pretty good, especially with all the technical difficulties. So good job, everybody. No. Good question. Okay, so moving back now, we're going to go back to my slideshow here. Okay, so a little bit more now. On admission, we're admitting him. We assess his vitals. They aren't too bad. BP 109 on 64, O2 sats 95% on room air. We weigh him. His weight is 95.6 kilos, which is about 5 kilos up from his baseline weight of 90.5. Our physical assessment findings are the same as an emerge, 2+ edema up to his thighs and abdominal distension. When we ask him about his meds, we find out that additionally he is on spironolactone as well as a potassium supplement. Go to our next question. Everybody's ready? Here's your leaderboard if KP, well done. Okay, question 2. What might we expect in terms of admission orders for Mr. Gump? There will be. We're gonna do the prizes after. No, it's good. It's a pretty long timer. I don't know why it's so long. Has everybody responded? Hopefully. Okay. We're gonna go ahead to the answers. Where are the answers? Oh no. I don't think there's a way for me to skip to the answers, so that's unfortunate. Okay, well, the answers were chest x-ray, ECG, and blood work and biomarkers, as it suggests in the algorithm to confirm his state of heart failure. Not initially. Okay. So Mr. Gump has undergone a few diagnostic tests. We can see that there are some concerning results, as you can see on the slide. His BNP is elevated and his chest x-ray shows mild pulmonary edema. His creatinine is also elevated and there is a very small bump in his tropes, probably due to everything going on with his heart failure. Which brings us to our next question. So given these results, what might we expect for inpatient care for Mr. Gump? Okay, so smoking cessation referral, bed rest, strict ins and outs, fluid restriction of 4 liters a day, daily weights, or low sodium diet. I think I'll have to wait out the 2 minutes for this one. I'm hearing some good discussion out there. People asking their buddies. I don't think I can do it, Jossline. Don't make me do that. I appreciate that. There's just one question left after this, so hopefully the 2 minutes won't be too long. Lessons learned for next time. Make it shorter. All right, some good answers there. So there was a trick question in here. So we would expect smoking cessation referral. We know that he continues to smoke. Daily weights, low salt diet, and strict ins and outs. We would not necessarily expect Mr. Gump to be on bed rest, especially if he can mobilize and if his symptoms are improving. We would want to do fluid restriction, but it would certainly be less than 4 liters per day. So that was kind of a trick question. I think I got a few of you. And as Kathleen just mentioned, now it's individualized to the patient, the guidelines. Okay. Okay, so our key for Mr. Gump is diuresis. We want to try to get some fluid off of him, as we've learned this morning. The reason we want to do fluid restriction, as I'm sure you all know by now, in the acute phase of heart failure, the key is diuresis. We want to target 0.5 to 1 kilogram of weight loss per day. We can do that with IV Lasix and additionally PO metallazone. So that's what we ended up doing for Mr. Gump. And as a result, things are turning around for him. After a few days of monitoring creatinine labs and symptoms, Mr. Gump achieved diuresis and lost 5 kilograms. His creatinine did peak up to about 200, but then returned back to baseline around 135. He was also less symptomatic, able to ambulate around the unit. Abdominal distension was decreased and edema improved. So overall, it's looking good for Mr. Gump leading up to discharge. At this point, we start to think, is Mr. Gump really ready for discharge? And this is where we can reference our heart failure guidelines and ask ourselves if he is on optimal therapy. As nurses, we have to ask, is his heart rate elevated? What's his blood pressure doing? Are his daily weights stable? And in answering these questions together with the medical team, we can consider if his medications can be titrated up or if other therapies should be added. Along with planning his discharge, and Kristy's going to talk about this later on today, we want to provide him with the appropriate education. This includes adding the heart failure gap tool into his chart and teaching to the applicable points within the tool. So last question, and it's about food because then we're going to go to lunch. What foods can Mr. Gump consume at home? Leaderboard. KP, killing it. All right, last question. And your options are eggs, dried beans, pickles, olives, canned soups, fresh fish, seafood, bacon, or bread. And then for those of you who are here in person, if you don't want to wait out the 2 minutes, that's fine. You can get up and grab some lunch. 2 minutes is long. And I will just put a plug in here to thank our sponsors, Boehringer Ingelheim and Cloud DX, who we have some representatives over in the corner there. Please feel free to go and talk to them on the lunch break. They have lots of good information. I'm just going to go over these and then yeah, thanks, babe. All right, so the answers are up there. Eggs, dried beans, fresh fish, seafood, and bread. So mostly low sodium items. For those of you following on online, we'll reconvene at 12:45. Thank you. Just kidding, because of the timer. Anyway, it's my pleasure to introduce Tara, who is going to come up here and speak about device re-synchronization therapies for our heart failure patients.
So hello, everybody. My name is Tara. I'm a nurse and I'm the care facilitator at the device clinic here at the Heart Institute. I always like to start my presentations with this slide because I don't know that everybody knows who we are or where we are. So the device clinic is on the first floor of the Heart Institute, just at the top of the escalators. We're open Monday to Friday, 8 to 4. And if you walk by during those hours, you will see probably a lot of patients sitting out there. We serve over 8,000 clients every year. There's about 7 nurses in the clinic working on any given day, as well as our electrophysiology fellow and a staff that comes in and out. All this to say, if you have a patient with a device and you have any questions, we're the people to call. Our clerks are very knowledgeable. They can often answer your questions or they'll pass it on to me. So don't be shy. So today I'm going to focus on cardiac resynchronization therapy. I'll talk a little bit about indications, interrogation considerations, and then I'll get into a little bit more sort of basic device information, magnet function, MRIs, remote monitoring, and touch on ICD deactivation if time allows. So in our clinic, we see all kinds of implantable devices, pacemakers, ICDs, CRTs, loop recorders, and subcutaneous ICDs. But today I'm really going to focus on the CRT and a little bit on ICDs because a large percentage of our heart failure patients end up requiring some of these devices over the duration of their illness due to their propensity for electrical dysfunction. So cardiac resynchronization therapy, or BiV pacing, has the addition of a third wire in the left ventricle, and this is often in addition to the right ventricular wire as well as the right atrial wire. It may or may not have that atrial wire, but it's the two in the ventricles. And the purpose of it is to coordinate the right and the left ventricles for those patients who are having ventricular dysynchrony. And this can improve heart failure symptoms such as shortness of breath and fatigue for our heart failure patients and improve their exercise capacity. This can also decrease the number of hospitalizations due to heart failure symptoms, as well as the mortality when it's added to optimal medical management. And CRT comes in, you can have a CRT pacemaker or a CRT defibrillator. So when deciding whether we're going to put in a defibrillator or not, these patients kind of fall into two categories. The first is our primary prevention patients. So these are patients who have a left ventricular ejection fraction of equal to or less than 30%. They have had at least 3 months of optimal medical therapy. There's 3 months post vascularization or 40 days after an MI. And essentially we're putting this in prophylactically because we know that these patients are at higher risk for these electrical disturbances. Our second group of patients are our secondary prevention patients. So they're patients who have known ventricular arrhythmias. So this is either post cardiac arrest, VT or VF cardiac arrest, or VT in the presence of structural heart issues, or a sustained VT after 48 hours after MI or revascularization. So in deciding whether to put a CRT in, a patient is a candidate if they are a New York Heart Association class 2, 3, or an ambulatory 4, which I think got cut off up there. So these are patients that have symptoms that range from mild with slight limitations during ordinary activity to those with severe limitations even while at rest. These patients have an ejection fraction of less than 35 and a QRS greater than 130 due to a left bundle branch block. Now, this left bundle branch block is the strongest predictor of benefit from CRT. Our patients with a classic left bundle branch block presentation are 2 times more likely to derive clinical benefit from the CRT than those with other conduction arrhythmias. Ideally, these patients are in sinus rhythm. It's not a make or break, but the sinus rhythm helps in that the device can kind of overcome the underlying rhythm. They'll consider putting it in for those patients with the ejection fraction less than 45 or a QRS greater than 150 for a conduction issue other than that left bundle branch, and for those with chronic pacing percentages, as well as if patients are complaining of poor or worsening heart failure symptoms. So in the clinic, our CRT patients come to us kind of in 2 ways. Either they've been identified by their cardiologist or their heart failure specialist as somebody who would benefit from this therapy. They've been referred to our electrophysiologist, and it's been determined that they would be a candidate for this therapy, so they come to us for their follow-up. The other way we see these patients is our ICD and pacemaker patients who are being followed regularly in the clinic. As we're coming down on their battery life, we start seeing them more frequently. It usually ends up being 2 to 3 months during the last year as we're following that battery. And this cues the nurses in the clinic to start looking to see if there's a recent echo, so we can look at that ejection fraction, a recent ECG, looking at the QRS complex, seeing if they have an increase in those heart failure symptoms, and then looking for those high RV pacing percentages. And that high RV pacing burden, we consider these patients because we know that it promotes left ventricular systolic dysfunction, and that's due to the electrical and mechanical dyssynchrony that causes. So unfortunately, not everybody responds to CRT therapy. About 30% of our patients do not have a positive clinical response. So that means their ejection fraction remains unchanged, or it continues to kind of decrease. There's no change in the width of their QRS complex, and they have subjectively little or no change in their heart failure symptoms. Now, within this group are our non-responders. So these are patients who, well, they're not seeing a difference in their heart failure symptoms, you know, there's not a big jump in their ejection fraction. We have perhaps stabilized it in that it's not continuing to go down on the trajectory it originally was. So, well, unfortunately, these patients don't have sort of quantifiable proof that this is working for them. Perhaps we've prevented a hospitalization or two, and perhaps we've extended their lifetime in a way that's where they have a reasonable quality of life. Now, we have on the flip side of that our responders and our super responders. So super responders are essentially those whose ejection fraction returns to normal, so 50% and above. And then we see that normalized QRS, and they're reporting that they have those improved heart failure symptoms, and that's really what we hope for most of our patients. So we see our CRTs and our ICD patients every 6 months in some combination of in-clinic or home transmission follow-up. We do for them as we do for all our standard devices. We are looking at the basic things we look at for interrogations, you know, presenting rhythm, arrhythmia count. We're looking at the lead. We're making sure everything's testing well. One point to note here is that our standard devices, we usually tell our patients they'll last approximately 10 years is the average battery life for these devices, but our CRTs do tend to not last quite as long. We'll tell them about 5 to 7 years, and this is due to the high pacing percentages, as well as that left ventricular lead tends to have higher thresholds just because of where it is placed. So there are some considerations that are specific to these devices. So our standard devices kind of have two polarities. So ways in which the energy can move. So I'm sure people have heard before, either bipolar, where it's moving between the tip and the ring at the bottom, or between the tip and the can. So those are our standard leads. The left ventricular leads, by contrast, are quadrupolar leads. So they have sort of 4 electrodes, and you can see in the picture up here, that longer one is the left ventricular lead. And so it can be paced in a number of ways, or what we call vectors. So the energy can move in a lot of different ways. So we do our vector testing initially when the patient comes in. We're looking for a vector that has a low threshold, so it's not going to drain the battery very quickly. And we often do it in conjunction with ECGs because we're looking for a vector that also gives us that narrower QRS complex. So we'll try different vectors along with the ECG to see which one's going to give us the best results for this patient with their CRT. We also do it when people report that they're having phrenic nerve stimulation. So phrenic nerve stimulation is relatively common with these patients. So it occurs in about 1 out of every 4 CRT patients. And it's essentially a tapping or thumping sensation in their left upper abdomen. And this is due to the proximity of the phrenic nerve to the lateral wall of the left ventricle, essentially where the lead lies. And you can see in the picture how close it is. Now, phrenic nerve stimulation is not typically painful, but it can cause dyspnea, uncomfortable muscle twitching, hiccups, and general malaise. So it can be quite debilitating for these patients and affect their quality of life. It can make it difficult to sleep and just generally be very uncomfortable. There are a couple things we can do for these patients. Sometimes it's a matter of just changing that vector. Sometimes we can find another vector that doesn't give them that stimulation. Sometimes it's a matter of decreasing the amount of energy we're putting towards that wire. So while our standard wires require a significant safety margin, like an RV lead, if you had a threshold of 1 volt, you'd want to double that. That's a safety feature, right? Our left ventricular wires don't require that because we have the right ventricular wire to keep the patient safe and pacing. And while we want the left ventricular wire working ideally, so they have their CRT benefits, it's not a safety feature, so we can certainly lower that threshold. We can also turn off capture management, which is where the device tests itself periodically, so they can get more sort of thumping with that. Unfortunately, there are cases where we cannot get rid of that phrenic nerve stimulation, so we do have to turn off that lead, and it renders the device essentially like a straight ICD or pacemaker. So they do lose the benefits of cardiac resynchronization therapy. And the last interrogation point for these patients is their total ventricular pacing. So with our standard devices, we're trying to encourage intrinsic heart rate. So we want to get that right ventricular pacing as low as we can when possible, because we know that a higher RV pacing burden can induce conduction delays. And this is due to the electrical and mechanical dysynchrony when you're just pacing in that right ventricle. So with our CRTs, we'd like to get that percentage as high as we can, so as close to 100% as we can. Things that affect this, typically any arrhythmia that makes the device compete will decrease that number. So atrial fibrillation, probably our most common, a high PVC, PAC burden, any kind of tachyarrhythmias that are taking away from the device functioning. And you can see here, I've given an example. So this patient, unfortunately, is only pacing 78% of the time. So that's well below what we'd like to see. And if you look at the EGM, this patient's in atrial fibrillation, and I've circled in red where the device is trying to compete with that intrinsic rate. So it's not getting that good resynchronization that we hope to get. Now, there are a couple things we can do for this. One is rate control medications. Usually that's the beta blocker that we're starting, though usually people are already on that or increasing. Sometimes it's an AV node ablation, so we just cut off communication between the atrium and the ventricles and let the device take over in those bottom chambers. And sometimes it's just simply a matter of increasing the lower Brady rate. So where our typical devices, you might see lower rates of 40 or 50 or 60. It's not uncommon with a CRT to see lower rates of 70 or 80 as we try to overcome the patient's intrinsic heart rate. So I'll talk a little bit about magnet function or magnet response. Our CRTs, just like our traditional devices, the pacemaker CRT, if you put a magnet on it, it will just pace asynchronously. Whereas if you put the magnet on a CRT defibrillator, it will turn off the tachytherapies and it'll leave the pacemaking portion untouched. The devices that are implanted at the Heart Institute, Boston Scientific and Medtronic are pacemakers. I'll just mention the alerts here. Pacemakers don't vibrate or make a tone, not the ones we implant here, but our defibrillators will. So you should hear a tone when you put the magnet on them, though some of them are quite soft. We get a lot of questions about MRIs. Our CRTs, just like all our other devices, most of the devices being implanted these days are MRI compatible. So typically if a doctor wants wants to have an MRI for their patient, I would recommend that they put in the request, make it very clear on the request in Epic that they have a cardiac device. The MRI team flags it to our office, and we look at whether the patient has any abandoned leads, because that will preclude them from having an MRI. We're looking to see if that device is compatible, MRI compatible, and we're just making sure that the leads have been testing well. Ultimately, it's our staff electrophysiologist who determines whether it's safe to proceed. And if it is, the patient is seen in the clinic before and after their MRI. The ICDs, we travel to them so that they don't walk around the hospital without their therapies on. Yeah. I'll just talk briefly about remote monitoring. So we do have remote monitoring available for our Boston Scientific and Medtronic patients. It's not continuous monitoring. It just replaces an in-clinic visit. But this can be quite helpful for especially those patients who have so many appointments and have to deal with the Heart Institute parking lot a lot. This cuts down, so they only have to then come in once a year, and at that 6-month interval they send us a transmission, so we're able to get a good idea of how the device is functioning. Right, and the last thing I just wanted to touch on is ICD deactivation, and I think it's important as we're implanting these devices before and during the course of them having these ICDs, that we're discussing the possibilities of ICD deactivation. It's surprising how many patients don't know that this is a possibility, especially, in the trajectory of their illness. It's likely that at some point we'll need to deactivate them. And it is quite a simple thing, quite a simple procedure. Unfortunately, at this point in Ottawa, it can only be done in the clinic. But it's good to be having these conversations ongoing so that patients can make informed decisions, so that when the time comes for them to decide whether to turn it off, they have all the information that they need. And it does not hasten death. It just obviously turns off the tachy therapy, so that if they were to go into that VT or VF rhythm, they go peacefully. And I think that's it for me. Any questions? Ooh.
So one of our online watchers is wondering who is allowed to install a magnet.
That would be like the doctor. If a doctor recommends it, then yeah. Yeah. Just
Awesome. Thank you so much, Tara. That was wonderful. Our next speaker comes from a place near and dear to my heart, and she's here to talk to us about Impella support in the cath lab. This is Kristin Pritchard.
Hi, everybody. There it is. Oh, that's really loud. Hi. I just have to take a minute and look at all of you because you're not scary. Nobody's scary, right? Anyways, my name is Kristin Pritchard, as Tori just let you all know. And I am the clinical nurse educator for the cath lab, EP lab, and the cardiac day unit. And I'm going to talk to you a little bit today about what I know of mechanical circulatory support. And I'm going to focus a little bit more on high-risk PCI patients that come into us. They can be in cardiogenic shock. We can be putting Impellas in to support them during high-risk procedures or longer PCI procedures. So we'll talk just a little bit about all of those kind of things. Our learning objectives for today, I'm going to go through what Impella is, indications for use and contraindications for use, which is a really important topic. And then also just go through how it helps us and our patients during high-risk PCI. Does anybody know what Impella is? Yes. You don't have to tell me, but I'll tell you about it. So basically, hold on. What Impella is, it's a catheter-based ventricular assist device. So if you think of it in terms of, it's like your typical LVAD that a patient would have when they're waiting for heart transplant, but it's a much smaller version of that. So we insert the Impella percutaneously in the cath lab, and we basically go up the femoral artery. It goes up around the aorta and is inserted into the left ventricle. And so the purpose of the Impella is to basically pump blood from the left ventricle into the aorta and into the periphery of the body to perfuse organs and tissues. So the goal at the end of the day is to basically have these patients have an increase in their cardiac output. We want to maintain stable hemodynamics for these patients in the cath lab and out of the cath lab, and to also decrease symptoms associated with heart failure and angina during their procedures. So this is just a little slide. I'm kind of reviewing like the timeline of Impella and how we've kind of moved from not using it to using it and having different versions of it. So I'm just gonna, oh, we have a pointer. Oh, look at that. I've never really used a pointer before. I like it. So the first Impella was FDA approved in 2008. And that is the Impella 2.5 version. So there's a few different versions of Impella, and basically the difference between those versions is the amount of flow that they're outputting. So there's, I believe, 3 different types that we use here. The Impella 2.5, the Impella CP, and then the Impella 5.0. So the 2.5 and the CP are what we would see in the cath lab, no? Yes? Oh, yes. And the 5.0 is more of a high flow version that is more of an auxiliary approach that would get put in the operating room. There's also an Impella RP, which is specifically for right-sided heart failure, that I don't believe that we have here, but don't quote me on that. We do have it here. We do have it here. I have never put one in nor seen one put in, but it exists. Anyways, moving along. So FDA first approved Impella use in 2008 for circulatory support for up to 6 hours. And then basically I'm just going to jump over to where it's important for our discussion. In 2015, it was then approved for use in high-risk PCI. And then in 2018, we see that its use expanded to cover patients with or without left-sided heart failure. So when it was first introduced, it was really just for patients with a low EF. Now we can use it for both. So this is just a little video of how the Impella gets inserted in the cath lab. So it's very different from the operating room, but it's just a really short video. And then I'll talk a little bit after the video of kind of like more specific things that we look for in the lab. Oh, do I have to go over to this? Tori, is that right? Oh, geez. Okay, here we go.
The Impella is the world's smallest heart pump. The cardiologist places the Impella heart pump into position using standard cardiac catheterization techniques, inserting the catheter into the leg artery and guiding it into the heart. Once in place, the Impella pump is turned on, providing support to the heart while monitoring the pumping activity. The Impella pump mimics the natural pathway of blood flow from the heart to the ascending aorta, increasing blood pressure while unloading the heart and providing more blood supply to vital organs such as the brain and kidneys. A protected PCI procedure with Impella could lead to less days in the hospital, fewer repeat procedures, and an improved quality of life for the patient.
It gives them more time to perform procedures that they need to perform. And it also makes the procedure a lot more tolerable for patients in heart failure, patients that are in cardiogenic shock, just by taking away their symptoms. When we do put in Impellas in the cath lab, there's a lot of components that kind of come into play. So we usually have perfusion involved. We have reps that come in. The patients are, we do the procedure under conscious sedation. So a lot of the times they are awake if we're just doing things for high-risk PCI. It's a very, very large bore sheath that we use for the insertion of this device. So our typical, sheaths that we use for PCI are like a 6 to 7 French. Impellas are 14. So really important that before we get going with insertion of the actual device, that the patient is anticoagulated beforehand. We don't want any clots forming in that big sheath because there's lots of opportunity for that to happen if their activated clotting time isn't within a therapeutic range. So once we reach that ACT level of usually above 250, we carry on, Impella gets put in. We use a D5W purge solution for the motor, and it's we mix it with heparin as well. And so basically it's to help the blood to not backflow into the motor. So like the D5 is very viscous, it's more viscous than the blood is. So as the motor is going, the purge solution is going, the blood isn't going to back up into the motor and cause it to clog. The devices are very, very expensive. So an Impella, I think 2.5 is upwards of $25,000 a pop. So we just want to make sure that we don't screw it up. For that reason and for the patient's reason too. And then once the Impella is in place, we do all of our procedures under fluoroscopy so we can pretty much see when it's in the ventricle. As long as the patient's anticoagulated, we start it up and we can offload the ventricle and then start our procedure. So indications for use. So there's 3 main indications that we see in the cath lab and here at UHI. So the first is cardiogenic shock, and I'm glad Laura pointed out a lot about cardiogenic shock in her presentation. So cardiogenic shock with or without the presence of a decreased ejection fraction. So that's a big one. High-risk PCI in the cath lab is typically what we use the Impellas for, especially for our patients in shock, heart failure, or patients that are at a higher risk of hemodynamic collapse pre and post procedure. So basically, the physician's able to insert the device, and the offloading of the ventricle allows for hemodynamic stability that's required when we're treating complex anatomy. There are a lot of tools that we use in the cath lab that can decrease perfusion to the vessels. High calcified lesions that require rotablation. So it's basically like a little tool that we put down the vessel. It can cause us to obstruct our flow. So Impellas, balloon pumps are things that we can use to basically help to perfuse the patients while we're kind of blocking the vessel. So yeah, and bridging to other therapies is another reason why we can use Impella for these patients. So in other presentations, we've kind of talked about bridging to heart transplant. So if they're kind of waiting for an LVAD, if they're waiting for transplant, Impella can be a very short-term option for them. So typically the Impella CP can stay in for up to 4 days. The 5.0 can stay up for around 10 days. I think like the max is around 30. So it depends on the patient and the situation. Contraindications are super important as well. So if a patient has an existing LV thrombus, a thrombus in the left ventricle, that's like a big no-no. So we don't want to dislodge that thrombus and have it going and causing our patients to stroke. We also don't want the thrombus to get caught up in the motor and then basically your Impella is gone. You've got to open a new one. So we kind of want to avoid that from happening because it's not a very nice thing to cause your patients to have a stroke. Mechanical valves are another issue. So basically crossing that mechanical valve can cause damage to it. So we don't want to do that. For cath lab access, we only use peripheral access. So we don't use the auxiliary approach in the lab. They would in the operating room. So for us, we really have to know if their femoral arteries are basically good candidates for that device to go in. So if they have a lot of peripheral vascular disease and their femorals are super calcified, they're not going to necessarily be a very good option for this. And then also moderate to severe aortic regurgitation. So we're not going to be putting Impellas in these patients. They need to be avoided just because the Impella is going to increase the aortic pressures and will actually worsen the regurg for these patients. So why use Impella for PCI? So for some patients, it might be determined by their healthcare team that their heart disease and their heart function is too severe for stenting by us and also too high risk for surgery. And this is obviously going to be a problem for these patients. So Impella can help to remedy this issue. So basically it's non-surgical, it's minimally invasive, it's performed in the cath lab by an interventional cardiologist under conscious sedation, and it's basically going to be inserted to temporarily assist the heart by offloading the ventricle to ensure that that blood is delivered to the coronaries and to the periphery and the organs. The afterload's being managed by the assist device, and the heart doesn't have to work so hard. So basically it decreases the demand on the heart and increases the oxygen supply to the outer body. Who says that? I mixed up my words. Outer body, the periphery, you know, your brain, your legs. And so when the team is looking to kind of figure out who is a candidate for Impella supported devices, there's a few factors that they're going to have to sit down and review and go over to kind of determine who is deemed high risk. So Dr. So was kind enough to share this slide with me just to kind of give you guys an idea of how they make those decisions. So there's basically 3 categories that are looked at when they're making these decisions from a team perspective. So they want to look at patient factors, hemodynamic criteria, and anatomical factors as well. So your patient factors, ejection fraction, like we've talked about today, is a huge one. So anything under 20% is like we're doing it. Advanced age, pulmonary disease, previous surgery, if they're a non-surgical candidate, your hemodynamic criteria, so your low cardiac indexes, your high wedge and pulmonary artery pressures. And then from an anatomical standpoint, if the patient has had a previous angiogram and they kind of know what they're going into, if it's like a triple vessel PCI that we're going to be doing, or, you know, a really, really difficult left main procedure, we're going to kind of look at Impella for those as an option for those. Road ablation I mentioned, basically any kind of lesion that's going to be supplying a large amount of blood to the myocardium. And so once the patients have been deemed, okay, we're going to fix this patient with Impella, the team is going to basically review the case, and they are going to use this algorithm to kind of make the decision of which way to go. So here they're reviewing, they have all of these options. So you have CABG, you have hybrid, PCI, medical management, and then basically Impella supported PCI. So once they decide that, yes, we're going to go ahead with this, they basically consult what kind of device type they're going to use, where they're going to recover. They're going to look, like I talked a little bit about before, their femoral angiograms to make sure that there's no tortuosity, to make sure that the calcium is not too much in those vessels, and to make sure that there's no contraindications. If they're not if they're not a candidate for femoral approach, they're going to go ahead and look at the axillary approach in the OR. And if they are a candidate, then we'll go ahead and we'll put the Impella CP in the cath lab. And then this is just kind of like the post stuff. So I'm just briefly going to go through, it's not like a really great case, it's a good case study. I just feel like I'm just going to tell you a story instead of like presenting things. Anyways, it's a super interesting case. Basically, it starts out with a 39-year-old woman that had no major comorbidities. She was healthy, mom of 2, was admitted to or presented to an emergency department, not here, but at an outlying hospital with a 3-day history of fever, cough, and dyspnea. She was admitted to that hospital with a diagnosis of an infection secondary to influenza. And she had an initial echo done, and it basically showed that she had normal EF, so above 60%. The next day, she was transferred to us here at UHI with progressive deterioration, worsening dyspnea. She had an echo when she arrived here, and her EF had dropped in that 24 hours to 10 to 15%. So, and again, like it's crazy to think of somebody that is completely healthy walking around, normal heart function, and then all of a sudden, just like that, like within 24 hours, it's just bad. So they altered her diagnosis to acute myocarditis with biventricular dysfunction, secondary to influenza. So when they did her outputs and indexes and her right heart cath, her index was 1.9, her CVP was 12, and her wedge pressure was 11. They started her on LVAD at 0.15 mics per kilo per minute. She continued to deteriorate in the ICCU, and required escalating doses of inotropes and vasopressors, and she had a significant tachycardia, which we've talked a lot about today, and how it's not great for people with heart failure. Because of all of this change in her hemodynamics, the team decided to call a code shock to discuss management of this patient with mechanical circulatory support. So given her profoundly altered hemodynamics limiting the medical management of this case, the decision was made to insert an Impella CP, and the patient was shortly then thereafter transferred to the OR. So her Impella was inserted transfemorally. There were no issues during the case. She was transferred back to CSICU and started on milrinone to assist with her RV function. Over the course of the next 3 days, she basically gradually improved with the Impella in supporting her ventricle. And sorry, I'm reading through my notes and I'm trying to like keep up with my clicker. So over the course of the 3 days, she improved, index improved, output improved. And on day 3, the Impella was weaned and removed. Post TEE on day 4, her EF returned to 59%, which is crazy, from like 5 to 10 and then going to 59%. So just, it's more just an example of showing that how important rest is for the heart. Your heart is a muscle. You know, sometimes we have to rest our muscles if they're under stress. And so this is just a good example of that. Like, again, she had no comorbidities. So like, I don't think that I would expect somebody with end stage heart failure to respond like this, but you know, just from a virus, it's just absolutely crazy. She was transferred back to her sending hospital, and she, I think, was with us for a total of 13 days. I only have 2 minutes left. Holy smokes. Okay. So these are my children. I add them in at the end of all of my presentations. I was going to talk about something else, but I guess that maybe I won't now because I'm almost done. Are there any questions? Yes. Yeah. So they could potentially put another Impella in, or they could potentially bridge that patient, depending on the patient needs. They could bridge them to like a left ventricular assist device, like an actual LVAD, if they're waiting for transplant. So it all depends on the patient. Like if they're going to require it for longer than 30 days, I would kind of imagine that they would probably be bridging to something bigger. But for like the cases in the cath lab, like right now we're just bordering on starting a study called door to unloading with anterior STEMIs, and using Impella to basically offload the ventricle for patients that are having a STEMI. And so those patients, I think the Impella is only expected to stay in for like 4 hours to overnight, and then we're going to take them out and see how they do. It's removed, yeah. Yeah. You're welcome. Anybody else? No? Oh, yep. Yeah.
One's done in the cath lab, how long do they stay in for?
So we just put them in the cath lab. Again, like it all depends on the patient. So I know like for DTU, the plan is to, sorry, my nose is like kind of stuffy. I've got this chronic cough. It's driving me mental. So the patients will leave cath lab, go to CCU, and potentially stay in for like 4 hours.
Oh,
yeah.
that makes sense because I've never seen.
And then they would come back to the cath lab to have it taken out. Yeah. It's pretty cool, and I apologize. I usually bring like cool toys like to show everybody, and I didn't have any cool Impella toys. Anyways, that's that. Thank you guys for listening. Okay, I'm done. It's over.
That was great, KP. And speaking as someone who is in on that case, it was remarkable to see the immediate effect that that Impella had for that patient. We're just going to make sure that our audio is going to work for our next videos here. Yeah. Okay, thanks, Faye. So our next two presenters are going to be speaking about heart transplant. I'd like to welcome up Kyla and Taylor.
So hi, everyone. My name is Kyla Brown. I'm the heart transplant coordinator here at the Heart Institute. And I'm going to talk to you a little bit about today about who gets a transplant, how we make that decision, a bit about the wait time and waiting process, a little bit about the surgery, although Taylor will tell you a lot more about that after I speak. And we'll talk a little bit about some of the complications our patients can face in living with a transplant. So this is actually the 40th anniversary of heart transplants at the Heart Institute this month. And the picture up there is the first patient who received a heart transplant here. Dr. Keon was the surgeon in 1984. Since then, we've done 738 transplants, and we follow just under 300 patients in the community who have had transplant. We're one of 3 adult heart centers in Ontario. So patients are referred to us for end-stage heart disease, obviously, and mostly that's for heart failure. We do transplants for local patients, so that's in Ottawa and Gatineau. We receive referrals as far as east as Kingston, some patients from Northern Ontario. We do follow patients from Nunavut. We do the majority of the heart transplants for patients in Newfoundland and sometimes for patients from Winnipeg. Referrals are usually taken from cardiologists, although sometimes from internal medicine, and sometimes those referrals are from our internal cardiologists, so patients that are already followed in the heart failure clinic here, but also from external cardiologists. And when we get a referral, it's reviewed by one of our transplant cardiologists and then accepted or declined. So if a patient's accepted for transplant, they go on into the evaluation phase. This can take sometimes just a couple days for an emergent patient, for instance, someone on ECMO in the ICU, or for an outpatient can take usually a couple months. And we're doing testing and referrals to other professionals to determine if they need a transplant, if they'll succeed well with the surgery, and if they'll succeed well with living as the transplant. I've listed up here the bare minimum in terms of what testing and referrals we do. You'll see some cardiac tests there. So they get a cardiopulmonary exercise test, a right heart cath, an echo, and an ECG, really looking at the heart function. Do they need a transplant? We'll then look at some of the other body parts. So we do CT scans of chest, abdomen, and pelvis. We're looking to make sure there's no malignancies there. Also looking at landmarks for surgery. We're doing carotid and arterial leg Dopplers. Also doing blood tests. So we need to know their blood group, and we're screening for infectious diseases. So they get tested for hepatitis and HIV. And then we make sure patients are up to date on their age and sex-specific cancer screening. In terms of referrals, all the patients will see a surgeon. They undergo referrals to psychology and social work. So we're looking at, do they have coping mechanisms in place to be able to cope with undergoing a big surgery and coping with a big chronic illness? Do they have someone at home who can take them to their appointments? Can they afford their medications? They'll see a physiotherapist for a frailty assessment. We make sure all their vaccines are up to date, so they usually see infectious diseases for that. And then we may ask them to see other specialists if they have other underlying illnesses. Many patients with heart failure may also have a bit of kidney dysfunction. So for instance, we would want to understand their risk for dialysis afterwards, the risk for potentially needing a kidney transplant afterwards, and we would want to make sure the patient understands and accepts that risk as well. So once the evaluation is complete, the patients are presented at our transplant committee. This is a multidisciplinary committee that meets once a week. And really, we're trying to figure out, does the patient need the transplant and will they do well with them? And I like this quote that I heard at another conference, is the heart sick enough and is the rest of the body well enough? So patients will either be then accepted or declined. So why might we decline someone for transplant? So it could be psychosocial concerns. So it may be active substance use, could be a history of noncompliance, could be that they just in general have a high comorbid burden. So, while we could replace their heart and improve their heart function, they may not feel better if they also have lung disease, liver disease, kidney disease. Could be pulmonary hypertension. So if we transplant their heart and they have pulmonary hypertension, that right side of the heart is going to fail against the resistance. Cancer, so for most cancers, we want them to be cancer-free in the last 5 years, and that's because the medications we have to give them after transplant increase the risk of cancer. Sometimes, and this is always a good thing, we will decline them because they're just too well. They don't need a transplant, or at least not yet. And if we decline them, there's some options. So they may continue with medical therapy. We may offer to refer them to palliative care, and there is a palliative care clinic here, and some of these patients will go on to have palliative home milrinone. We may offer them an LVAD, so this could be either as a bridge to candidacy or destination therapy. So some of the reasons I listed above could improve with an LVAD. So we may offer them an LVAD as bridge to candidacy to see if their pulmonary pressures come down enough with an LVAD that they could then be considered a transplant candidate. Similarly, if they've been using substances, we may say, okay, you can have an LVAD. If you then can be substance-free for 6 months, then you may be a transplant candidate. And for any patient that wants it, we'll offer them a second opinion at another transplant center. So for patients that we do accept for transplant, they go on the heart transplant waitlist, which is managed by Trillium Gift of Life Network in Ontario. Prior to going onto the waitlist, they receive quite a bit of education from our pre-transplant coordinator, just so they understand sort of what they're up against and a little bit about the waiting process. They're followed very closely by our team. So for any concerns, they call our pre-transplant coordinator. They're seen in clinic every 1 to 3 months. And how long they're going to wait obviously depends on the availability of donors, but the factors that sort of can influence how long they wait are blood type. So we have to find an ABO compatible heart. That means someone who's in blood group O, for instance, may wait quite a long time. Someone with a blood group A will wait a shorter amount of time. HLA antibodies, which I'm going to explain on the next slide. Body size, so we have to find a donor that has a similar size body to the recipient. We can do sometimes female to male or male to female, but more likely we're going to accept same sex. Time on the transplant wait list, so the longer you wait, the higher up you move in priority. And then status listing. So these are preset rules that everyone in Canada follows in terms of listing their patients. Because the higher status you're listed at, you're going to get offers first because you need the offer first. So a status 4, which is the highest status, is someone, for instance, on ECMO in the ICU. You can't wait very long. You're going to get first priority for hearts. Someone who's waiting at home and is otherwise relatively stable is considered status 1. HLA antibodies. So HLA stands for human leukocyte antigen, which is part of your immune system. Everybody has HLA, and that's, you know, normal. They're inherited. You create antibodies to HLA if you're exposed to someone else's HLA antigens. So you could make HLA antibodies if you've had blood transfusions from pregnancies and from prior transplants. The HLA antibodies will just stay in your body and generally won't cause a problem. However, if we give you a transplanted heart, we have to find one that you do not have HLA antibodies against. If we give you one that you have HLA antibodies against, that will cause a rejection. So we measure these HLA antibodies as a percentage. It's called a PRA, or percent of reactive antibody. The higher the percent, the harder it is to find a match for you. Many people are at 0, but the higher you go, the longer it is that you wait for a transplant. Our donors, so here we transplant only from brain dead donors. So that can be from stroke, trauma, overdose, suicide. Approximately 80% of our donors are considered exceptional distributions. So this is when the heart muscle is a very good muscle, a good organ, but there's something in the donor history that conveys a higher risk of catching an infectious disease. The list for this is very long, but it could range from, you know, they might be using drugs, or it could just be that there's something unknown in their medical social history, so we can't exclude them from this. We do have a policy to accept donors from hearts from donors with active Hep C infection. In terms of donor age, we prefer younger donors, so it's usually under 50. Shorter ischemic times are preferred. That's the amount of time that the heart is out of a body, which really kind of limits our geographical location of donors. And then in Canada, it's important to know that organ donation is confidential. So when it comes time for the surgery, so again, patients are on the Trillium Gift of Life Network wait list. They allocate the hearts. So they call us if they have a heart that is matched to one of our donors and they're next in line for this heart. And then we decide with the surgeon and the heart transplant cardiologist, we think this is a good heart for our patient. So if we accept the heart, we call the patient in from home, get them admitted. And then a surgeon retrieves the heart and transports it here in a cooler on ice. Again, the ischemic time, so the amount of time that the heart is out of a body, is we try to keep it to a maximum of about 4 hours. Surgery takes about 4 to 6 hours, and on average, patients will spend a week in the ICU and then a total of 3 weeks in hospital. Living with a transplant, so I think it's really important to note that a transplant really isn't a cure. So these patients are exchanging one chronic condition, heart failure, for another. And the first year in particular is very challenging for these patients. It's a big surgery to recover from. They're on quite a lot of immunosuppression medication in the early years, so they have quite a lot of side effects. And there's a lot of follow-up appointments with our team. We usually tell patients to remain off work or out of school for the first year. Usually by the first year, though, they're ready to go back. And we do follow our patients lifelong. So if you've had a transplant, you get followed by a transplant team for life. Survival, median survival, and this is from the International Society of Heart and Lung Transplant data, is 12.5 years. However, if you just count the patients that have survived that very difficult first year, the median survival is closer to 15 years. Some of the complications and challenges our patients face are listed up here. The ones we'll talk about today are going to be rejection, which can cause graft failure, and infection and cancer. To understand some of these challenges, it's important to understand the role of the immune system. So a healthy immune system will protect your body from foreign substances, which is great. However, after transplant, the big problem is that the immune system recognizes the heart as foreign and will reject the heart unless we intervene. So we give immunosuppression or anti-rejection medications to stop this from happening. That's great to protect the heart, but in lowering the immune system, we then put our patients at higher risk of infection and cancer. And then on top of that, some of the added side effects from medications, again, I listed on the slide before, but we can see renal dysfunction, osteoporosis, diabetes, some of the other side effects from taking these medications. So for us, it's always a balance, giving patients the right amount of medication without compromising their health with all the side effects. The risk of rejection will lower over time, but never goes away. So these are medications that patients take for life. When we talk about rejection, there's 3 types of rejection, and I'll go over them all briefly. But the big problem with rejection is that if the heart starts, or the body starts to reject the heart, it's going to stop working well, and patients really ultimately will end up with heart failure, which is what landed them here in the first place. The first type of rejection is called acute cellular rejection, and this is what we see most often in the first few years post-transplant. And what happens with acute cellular rejection is the myocardium, so the heart muscle, stops working properly. From ISHLT data, this will affect up to 13% of patients in the first year post-transplant. And in severe cases, again, it'll look like heart failure. Patients will start putting on weight quickly, have edema, have shortness of breath. So to prevent this, we give immunosuppression, we do surveillance testing, and we teach patients to report symptoms early of heart failure, but also the importance of compliance with their medications. In terms of surveillance testing, patients have very frequent echoes, particularly in the first year. And then we do endomyocardial biopsies. So they go into the cath lab, they go into the right side of the heart, and they'll actually take small samples of myocardium, which is sent to a pathologist. These biopsies are graded in terms of severity. 0 means no rejection, up to 3, which is severe. And we treat grade 2 or 3 rejection, so moderate or severe. Mild rejection is actually fairly acceptable. So again, we know the immune system's trying to reject the heart. We want to give enough medication that, they don't have that, but if we give them so much medication to prevent all the rejection, they may end up with a lot of side effects. So for some patients, we will accept some mild rejection. For treatment, so how much we treat depends really on severity and if their graft function is affected. So do we see any new dysfunction on an echo? Usually it'll involve admission for at least 3 days of IV steroids, but we may end up giving more medication if we think the heart is compromised. Antibody-mediated rejection is caused by those HLA antibodies that I talked about. So I told you we wouldn't give someone a heart if we knew that they had HLA antibodies against it. So how does this happen? What can happen is over time, you can create new HLA antibodies. So even though we may have given you a heart that you had a negative cross-match with a transplant, you can make new antibodies over time. And so this could happen in the future. Fortunately, it's not very common. We don't see it very often. But again, if we do, it looks like heart failure. So again, for prevention, we do the same immunosuppression, we do surveillance testing. We see this as well on biopsy, but we're also doing HLA antibody testing, which is the blood test, and education. For patients that we know to be, we say sensitized, so that we know have some HLA antibodies, we consider them at higher risk for creating new antibodies. And so we do tend to keep these patients on a higher baseline immunosuppression to help manage this risk. And then for treatment, again, it's going to depend on the severity and whether or not their heart function is compromised, but usually involves admission to hospital for the same medications we talked about before. But we can also do something called plasmapheresis, which sort of looks a bit like dialysis, but involves cleaning some of these antibodies out of the blood. Chronic rejection, which is called cardiac allograft vasculopathy, or CAV, is the third type of rejection that we can see. And I like this picture. I think it illustrates it well. On the top, you can see what looks like more typical coronary artery disease, and occurs more as sort of small focal lesions. The bottom is what CAV looks like. And this is where the coronary artery, the lumen of the blood vessel thickens. And so if it gets too thick, you're not going to have good blood flow through that blood vessel. And unfortunately, this tends to affect the full lumen of the vessel, so not just discrete lesions. Incidence from ISHLT data, so 29% will have CAV at 5 years, and almost half of our patients will have this at 10 years. Presentation is difficult. So when they do the transplant surgery, they've cut all the nerves from the body to the heart. And so we say this is a denervated heart. So patients may not feel chest pain in the same way that non-transplant patients would feel chest pain. So presentation is sometimes silent, and we know this, so we do surveillance for this pretty frequently. That being said, you can form new nerve pathways, so we always teach our patients to report any chest pain and take it seriously. In terms of prevention, so they're taking immunosuppression. Statin medications, so these cholesterol medications, have also been shown to help delay progression of CAV. We do surveillance testing and, again, education. Our surveillance testing here is yearly, and we do either PET scan or angiogram. And again, they're having frequent echo. So if we see graft dysfunction on an echo, that would prompt us to do testing for CAV. In terms of treatment, so there is an additional immunosuppression drug we can add sometimes if we detect CAV early on in the first 5 years. Sometimes they can deploy stents, but again, because it tends to affect the full blood vessels, sometimes stents aren't possible. And this is sometimes one of the indications that we may consider retransplant for. So again, by lowering the immune system, we've put patients at risk for infection. Really, they can get any infection, and they may recover just fine, but again, they may not because they just don't have the reserve to do so. I've listed some infections of concern here that can cause quite a lot of problems for our patients. PJP pneumonia, aspergillosis, and cytomegalovirus. I've also listed those because there's some medications we actually give patients to help prevent these infections. COVID-19, I list there, obviously anyone can get COVID-19, but we do actually give all our patients antivirals if they do have symptomatic COVID-19. In terms of prevention, so we do education before the patient leaves hospital after transplant. We do quite a bit of education with them about minimizing exposure to infection, when to report symptoms. We make sure their vaccines are up to date pre-transplant, but then we also encourage them to stay up to date with vaccines after transplant. Again, we prophylax for some of these medications that we know can cause serious problems. And then we're always looking at taking a balanced approach to immunosuppression. Cancer is another problem that our patients may face more than the general public. So 16% at 5 years and 28% at 10 years will have had some form of cancer. Skin cancer is the type that is most commonly seen, then followed by prostate and lung. There is a type of cancer specific to post-transplant patients called PTLD. This is a type of lymphoma that can sometimes be seen after transplant. Again, we prevent this. We're looking at balanced immunosuppression. We do patient education in terms of sun safety, but also making sure they stay up to date on their cancer screening. And then in terms of treatment, it would be standard for whatever type of cancer that they have. But anytime our patient has a new cancer, we always review with the transplant cardiologist to say, can we reduce their immunosuppression a little bit further to help them be able to fight this off? The medications that we give for immunosuppression, so patients will receive a big dose of steroid right before surgery, and then when they take the cross clamp off in the OR, and then they receive what we call induction medication in the CSICU, so it's either Stimulect or ATG. Their maintenance of immunosuppression is started pretty early post-transplant, and this is medication they stay on for life. So they take usually a steroid, prednisone. They get mycophenolate, so that could be in the form of Cellcept or Myfortic. And then they usually get tacrolimus. Some of our older patients, if you ever see a patient readmitted to hospital, may be on something called cyclosporin. It's a similar drug to tacrolimus. And again, for patients that have CAV, we may be looking at adding sirolimus. Immunosuppression, so over the first few years post-transplant, that's when we're weaning their immunosuppression. We give them the highest dose right in the beginning, right after transplant, when the immune system is trying the hardest to reject the heart. And as they have biopsies done over the first few years, that's when we're lowering down our immunosuppression. Most patients will reach what we call stable immunosuppression by year 2, sometimes year 3. And when we get to that stable level, we usually stop doing biopsies because we think that their immune system will behave similarly. So they can stay on the same dose of immunosuppression without any added risk of rejection. But they do take these medications lifelong, some form of these medications. How we decide which ones they take is obviously tailored to the individual. So what type of heart failure they had, how much they've had rejection, time post-transplant, and then whether or not they're having any of these side effects. I talked about the medications that we give for infection prevention. So most of our patients will get Septra, an antibiotic, and that started right after transplant. For some patients, we keep them on this lifelong, but for others, we just keep them on it till they're off their steroid, if they can come off their steroid. And this is to help prevent PJP pneumonia and also toxoplasmosis. We give patients itraconazole, which is an antifungal, usually for the first 3 months post-transplant. Not to say you can't get a fungal infection after that, but again, your risk is highest when you're on the most immunosuppression. And then we give patients an antiviral, usually valganciclovir or acyclovir, and that's for the first 3 to 6 months post-transplant. The other medications our patients mostly will all take, they'll get a PPI. So most of our patients will take Pantaloc to protect against the high dose steroids. They'll take a statin, so we want to manage their cholesterol, but again, to help prevent CAV. And then calcium and vitamin D to help prevent osteoporosis on the high dose steroids. Important things to take home: if you have an admitted transplant patient in your center, make sure they're getting their immunosuppression. We never want anyone to be stopping this without consulting our team. Take added steps to prevent infection. Obviously, you're going to be doing that in your practice anyways, but if you can keep patients in a private room, that's helpful. Consider transferring us for cardiac issues. So we don't admit our patients here automatically because they've had a transplant, but we certainly would if we think their issue is cardiac. And then give us a call. We're always happy to consult and be involved in the care. If you're interested in knowing more, we do have a website which has some of our clinic and referral information. We have a patient guide which has a lot of this information in it. And I'm always happy to be contacted with any questions. Speaking of which, does anyone have any questions? Yeah, so we don't have necessarily a firm cutoff, but we don't usually transplant over 70. It's hard to say that based on age alone, but you typically find more comorbidities, frailties, these things after that. In terms of how long, I've seen patients live into their 90s with a transplant. Yeah. So, the reason for that is that they have to be here if there's a hard offer. And sometimes when we get a hard offer, we have a couple days, and sometimes we just have 6 hours, depending on what's going on, where the other organs are going. So we want patients to be able to get here within 3 to 4 hours at a maximum. If a patient, for instance, lives in Sudbury or Thunder Bay, that's likely too far or maybe too far. Trillium Gift of Life Network has a program where they reimburse patients for their expenses if they have to relocate here. Now that's only for Ontario patients. We do transplants for Newfoundland patients. Obviously that's going to be too far to come here in time for a transplant. So for those patients, they relocate here. And again, the Newfoundland government does reimburse them for some of that money. Most patients will choose to stay at the intern's residence here on the campus, but really they could stay anywhere in town. It's just as long as they can get here on time. If they live a couple hours away and they have a reliable person who can drive them at a moment's notice, then we allow them to stay at home. They know that they need to get here when we call them. Okay, thanks.
Load automatic.
This is Taylor. She's going to have a little chat with us now. Sorry, I'm taking over.
How do I get to my presentation? Oh, okay. Oh, perfect. Hi, my name's Taylor. I'm a nurse here in the operating room, and I'm going to talk about the surgical portion of heart transplants here at the Heart Institute. So, yeah. Oh, someone's doing this. I do have a couple of videos in my presentation, so hopefully those work. Perfect. Here we go. So, first thing to think about when we're thinking about heart transplant surgery is sort of seeing the whole process. So there are two key sites when we're thinking about heart transplant. We have the donor site and the recipient site. So on this slide, you can see each point kind of coincides with what's happening at the same time. So on the donor side of things, they notify us that they have a potential donor. We accept it on our side here at the receiving hospital. So around that time, that's when we will call the patient, notify them that there's been a heart offer for them, and admit them to hospital here. On the donor side of things, when the surgical time is being arranged for the organ retrieval, that's around the time that we will plan to bring the patient into ROR here. So surgery will start on their end for organ harvest around the same time that we bring the patient into the OR here. At the time that the heart is explanted at the retrieval site, that's when we will put the patient to sleep in ROR here. And then when the heart arrives in Ottawa, that's when we will place the patient on cardiopulmonary bypass, those sorts of things. And up to this point, everything that we've done can be reversible if there's any issue with transportation for the heart, any concerns like that. And it's not until the donor heart has been received in ROR and verified for compatibility again with the recipient that we then start to explant the recipient's heart and begin the transplantation process. So this slide here just kind of shows an overview of the two types of surgical techniques that we have for heart transplantation. There's a biatrial approach and a bicaval approach. The bulk of the transplants that we do here use a bicaval approach. And some of the benefits of this approach is that it preserves the sinus node. So this can help with a reduction or reduced chance for atrial arrhythmias. And it also can help reduce the risk of RA dilation. One of the risks associated with this technique is that it can result in a longer ischemic time, or a time that the donor heart is outside of a body, just as a result of that extra anastomosis. And that extra anastomosis also presents an extra risk for bleeding because of extra suturing involved. And this diagram just kind of shows in purple the structures that are left behind in the recipient after we've explanted their heart. In pink, you can see the donor heart that's brought in. And then on the far right side of the images, you can see the completed transplantation with the suture lines for each respective technique. And the next slide, I have the video, so hopefully it works. Let me see the mouse. Oh, there it is. Bear with me, sorry. Can anyone see it on the screen? Oh, okay. Well, oh, there we go. I think it's starting to play. So this video actually has no audio, but what it's showing is the first anastomosis that we do, which is the left atrial cuff anastomosis. So we're connecting the left atrial cusp of the recipient to the left atrial cusp of the donor.
So in this video, we're looking down as if we were the primary surgeon doing the operation. You can see at the top of the video and the bottom, that's the sternal retractor in place, holding the chest open. If you can imagine the patient's head, it would be to the left outside of the frame of the video. On the patient's abdomen, we have the donor heart. And we're starting to suture the two structures together with a long proline suture. So as they put more sutures in and begin connecting those tissues, you'll see here, I think they parachute the heart down into the chest. So now it's sitting in the recipient's chest, and they'll close that suture line circumferentially until it's fully intact. So I think it'll zoom in here, but you can appreciate that they want to try and get those bites of tissue to really align well without any puckering, because that can be an additional risk for bleeding, or if there are any gaps or anything like that. This anastomosis also sets the foundation for subsequent anastomoses, and it really aligns the donor heart in the recipient's chest so that the other anastomoses can be performed. So once all the sutures are placed, you'll see the surgeon will tie down the knots so that everything's secure, and then cut the suture. There we go. So for the rest of the anastomoses, there's an IVC, the inferior vena cava suture, or anastomosis, sorry, the superior vena cava, anastomosis, pulmonary artery, and aortic anastomoses. So you can see in the video or in the diagram there that the recipient structures will match up to the donor heart structures, and everything is sutured together in the same fashion that was shown in the video there. As Kyla mentioned, we give a large dose of IV steroids as soon as the aortic cross clamp is removed, and that's to immediately help with to prevent rejection. You can see here, this is just kind of showing the other technique by atrial. So in blue, we have the remaining recipient structures. In pink, we have the donor heart, and then the completed heart transplant there on the right side of the slide. After all the anastomoses have been completed, we have a period of reperfusion, and that's approximately 15 minutes per hour of ischemic time, or the time that the donor heart was outside of a body. So for a 3-hour ischemic time, that might be about 45 minutes. So during this time, the cross clamp has been removed, the donor heart has been filled with the recipient's blood for the first time and starts to contract again. During this process, the patient's still on the heart-lung machine or the bypass machine, and we de-air the heart thoroughly through vents that bring air back to the machine. When we're trying to come off bypass, we want to monitor for RV dysfunction, try and optimize cardiac output. If we need to pace using temporary epicardial leads, we will do that. Support with inotropes, help reduce PA pressures and use nitric, and manage volume status of the patient. And the next slide, I have a video with audio that just kind of provides an overview of the whole process that I just outlined, and you can kind of appreciate how busy the operating room can be when we're receiving a heart due to additional personnel.
Once the heart is arrested and taken out, the clock is ticking off.
Okay.
So time is very
I can
crucial.
kind of
The
maybe
shorter the
speak to
time,
some of
the
the
better it is
portions
for
in
the
it.
organ.
Right now, it's the surgeon that's just kind of explaining the process. I need some stats about audio or about heart transplant surgery. So this is the recipient OR. You can see the heart's being delivered. It's actually in a cooler there. It's either transported by a surgeon, sometimes someone from our team will go retrieve the heart, or Trillium Gift of Life actually has retrieval surgeons that will deliver the heart to us.
Once we double and triple check the blood type,
and
then we're sure that everything matches, we start
it's just sort of talking about the process of the surgery. You can see the sterile field set up here.
So
on the top right corner, you can catch a glimpse of the cardiopulmonary bypass machine or the heart-lung machine. And sort of just what they're speaking about is the process for excising the patient's native heart.
Maneuvers that we call
And
dissection.
we'll get to it in a second, but there's also some prep work that goes on for the donor heart once it arrives in our operating room. So I think that's mentioned here with the donor heart. They'll check to see if it has a PFO. If they have a PFO, they will just close it with a suture on the back table there before they bring it up to the sterile field.
And once
Also, when the heart comes in the room, again, we confirm compatibility between the recipient and the donor. And then here they kind of just, as I mentioned before, they'll rest the heart on the abdomen to begin that suturing. And then once enough of that suture line has been put in, they'll lower the heart into the chest and complete it.
Basically, is an instrument
If
that
people at home can hear,
stops the
there might
blood
not
flow
be
going into the
much
new
else.
heart. And once we take that out for
video.
the first time, the blood from the recipient is actually mixing up with the organ donor.
Let it play out if it's
And
interesting. You
that's
can
when
see some of the
usually after
cannulas
like
that
2
are in place
seconds, the
there,
heart
and
starts
now
to
the
beat,
cross clamp has been
that's
removed and the
probably
heart
most
is
important
contracting
and most
again
rewarding part of the
for the
operation.
first time since it's been reimplanted.
While it's exciting to see that first heartbeat again from the donor heart after we remove the cross clamp, ultimately the heart has to be able to support the blood flow to the body, and we can't really assess that until we are fully off the heart-lung machine.
So this could be during the reperfusion
so
period.
Once we achieve that, that's when we know
as
the
we mentioned
transplant has been
before, it
successful.
can be
Once the patient has separated
45
from the
minutes
heart-lung
to an
machine,
hour
the real work
of
begins.
reperfusion time, just really
There's a lot
giving
of
that
postoperative care
heart
that goes into
the
the
chance
management of
to
the
start
patients
beating
after
again and
transplant.
recover
Many
from
people
that
think
ischemic
that the
time.
transplant, the surgery itself is the most critical
And then
portion,
we close
but
up post-transplant. So there's usually drains that are left in situ to drain any fluid from
just a number
the
of our
thoracic
other
cavity.
team members
We close with
to ensure a
surgical
successful
steel
outcome. Because ultimately the
wires.
goal is not to come out
Close
of the
the
operating room with a
subcutaneous
beating
layer
heart.
and then the
The
skin.
goal is to have a
And then
return
we
to a
transfer to
normal life a
CSICU
few
for
months down
further
the road.
care. So, thank you.
Okay, that was great. Shout out to Taylor and KP who didn't flinch when no audio worked. That was pretty impressive. We are going to work on that for a couple seconds here to make sure it's a go for the next ones. Okay. Taylor, get back up.
Do their technique. Also, there is the ability to sort of cheat those anastomoses as well. If there is like a size mismatch, they can take bigger bites where they have more tissue, potentially for the donor heart, and then smaller bites on the recipient heart to kind of compensate for that. So, but I think usually they'll know, and the heart that comes to us, they can use either technique with the heart. The heart that comes is the same regardless of if they do by atrial or by cable. So if they have to decide once they've opened the recipient based on their anatomy, then they can make that decision then.
Someone who has a VAD for the removal of the VAD.
They're almost like two completely different surgeries when you're doing a fresh chest versus an LVAD explant, because as you can imagine, all the scar tissue that adheres to that LVAD, it's, I've seen it almost double surgery length of time in some cases. And so there's a lot more dissection involved. So in that timeline that I had mentioned, that's in a perfect world with a fresh chest, with an LVAD explantation, you're starting to chip away at that and do that dissection before the heart's in the room, because that can significantly reduce or prolong the ischemic time. Yeah, so you start peeling away. We won't remove any part of the heart or the LVAD until we have the heart in the room, but certainly beginning to expose, because you have to have access to the IVC, the SVC, and the other structures where we have to anastomose. So, oh, in the cooler, I think, what did you say? You want to keep the ischemic time 4 hours or 6 minutes? Yeah. Any other questions?
Okay, that was great. Thanks, Taylor. And honestly, a good segue into our next talk, which will be about LVADs. And Taylor will be making another appearance for this. But I'd like to introduce Carita to start us off with that.
Everybody hear me? Perfect. Okay. Again, my name is Carita Kerola. I am the pre-transplant and LVAD coordinator, but I'm going to be just speaking about LVADs today. And again, this is just a basic knowledge. It is a quite complex, as you can imagine. So this is just baseline information. So what is an LVAD? So it's a left ventricular assist device. They are surgically implanted pumps that are designed to support the left ventricle by augmenting systemic blood flow in patients with end-stage heart disease. They are implanted in the apex of the left ventricle, and then the blood enters the pump via an inflow cannula and is directed to an outflow graft, which is directed to the ascending aorta. So 3 main reasons for why patients need an LVAD implanted. There is bridge to candidacy. Basically, we want to get the patient strong enough to go for a transplant. Bridge to transplant are patients who are actively on the wait list with an LVAD, and then destination therapy would be a patient who is actually not a candidate for transplant due to comorbidities, cancer, like Kyla mentioned. And they'll actually live with the VAD for the rest of their life and hope with the goal of improving their quality of life. So how does it work? So it's actually a centrifugal flow pump. It pushes blood from the left ventricle to the ascending aorta. Their heart is still in situ, and it still pumps. It has a beat. They have an ECG. The goal is to have their aortic valve opening intermittently so we don't get the leaflets of the aortic valve fusing together, which can cause issues further down the road. And basically the goal is to improve their cardiac output from the left side of the heart, hence the LVAD. So what does this mean for patients? They should be less short of breath, improve kidney function, and with the goal of better quality of life. So this is the implanted components. So on this side, you can see the ICD. You can't see the outflow graft, but you can see the pump itself. So really only a small portion of the pump, the inflow cannula, is actually in their left ventricle. So you can see the outflow graft here to the ascending aorta, and then with the percutaneous cable, which we call the drive line, coming out of the patient's abdomen, that then connects to their controller and then their power source. Their external components, so this is what you'll see on the outside of a patient. You'll see their controller, which they're connected to at all times, their lithium-ion batteries and battery clips, and then the bigger structures on the bottom, their battery charger, and as well, they can actually plug into wall power overnight and when they're having naps, and that is the power module. So we talked a little bit about why not heart transplant. So if they've had recent cancer in the last 5 years, if they've had irreversible end organ damage, kidney disease, liver disease, lung disease, psychosocial concerns, that can be many different reasons. It could be non-compliance, substance use, are really the big ones for my group of folks. And then also obviously the pulmonary hypertension. So that's why we put the VAD in to give the heart time to recover so we can hopefully get them to transplant, and that time can range. Usually we leave a patient on a VAD for about 6 months to get the pulmonary pressures down so that they're acceptable for transplant. So prior to VAD insertion, we treat these patients like a transplant evaluation until proven otherwise. So they go through the patient selection process, they get discussed at our transplant rounds, we ensure compliance, stable housing because we need a power source, presence of a caregiver, adequate cognition to safely look after the VAD. So we do consults with social work and psychology, and a MOCA cognitive screen is required for each patient. We also provide the patients with the Ontario Decision Aid tool for patients and families. Do they want a VAD? There's been some circumstances where it's not in keeping with their goals of care, whereas other patients are like, absolutely, I want to improve my quality of life. So, and then also we do patient and family teaching as well prior to surgery, and then extensive teaching after the surgery. They actually have to write a test before they leave the hospital. Medical concerns with these patients. They are on blood thinners, so warfarin and aspirin. So they're always at a higher risk of bleeding. Gastrointestinal is most common, or any other type of bleeding. Stroke, both ischemic or hemorrhagic, again being on anticoagulation. The number one risk with LVAD is device infection. It's like 20 to 30% of my patients do have a driveline infection. Some of them do need IV antibiotics, and some of them are able to be treated at home. They do also struggle sometimes with right-sided heart failure. They may already have right-sided heart failure before their device is put in, and sometimes the LVAD can, or even the surgery itself can actually make RV failure worse. Clot formation in the VAD is rare due to the newer technology pumps that we now have that are magnetically levitated, but it is still a concern. Trauma and accidents, be it car accidents, hitting your head, that sort of thing. My patients always need to call me because they're on anticoagulants, and arrhythmias. They will still occur because that diseased heart is still there. So patient management. The target is that these patients should be pulseless. We actually teach our patients to do mean arterial pressures at home. We give them a Doppler and we teach them how to use their own blood pressure machines at home. And they actually do log these numbers to me every day. So like I said, obtained with manual automatic cuff and a Doppler. If they do have a pulse, check for a systolic. A pulse or a systolic BP may mean that the VAD isn't optimized. So just let the VAD team know. Currently, all of our patients are on aspirin and warfarin. That will possibly change. The ARIES trial just came out last year, and we're potentially looking at actually stopping aspirin on all of our patients and lowering our warfarin targets. So that might be something that's new. There are some programs, some patients across the world who are actually not anticoagulated at all due to they've had significant bleeding or neurological events. So what do the numbers mean? So again, very basic knowledge. These are all parameters that we get from the pump when the patient has an LVAD. So they get a flow, liters per minute. It's estimated. So it is calculated by hematocrit power and speed. As the power goes up and down, the flow will go up and down. Speed, it is actually set by our heart failure cardiologists. You may say fluctuations, but it should always come back to baseline. And how do we choose the speed? Everybody's different. There isn't like a gold standard what speed they have to be. Depends on echo guidance. So we want to make sure their intraventricular septum is midline. They don't have any RV failure, and they don't have any regurgitation of any of their valves, which can cause problems. Power, the amount of power required to achieve a set speed, it should be stable. Power going up or down is a sign of clot or obstruction. PI is only with the HeartMate 3. It just gives us an idea of native heart contribution. Again, really the most important thing is these patients know their devices and they know their normal values, so the patient trends are the most important. And then keeping their blood pressure well controlled. So how do we take care of these patients? They come to clinic every 1 to 3 months. They come and do blood work usually every 2 weeks. So that's usually CBC-INR lights, creatinine and glucose, liver function testing. They do patient home records. So this is actually a screenshot of one of my patients. They all get set up on my chart and they put in all their parameters and it gets sent to my inbox every day. So it's really helpful that I can see the trends and I can see if they're starting to trend up and they'll call me, but I'm already seeing the trends. So helps us to adjust their medications quickly. They have preventative equipment maintenance. Biomedical engineering is my best friend, and they actually will switch out all their equipment regularly, usually every 6 months. And then if there's any issues with something not working properly, something cracked, a battery not working, they usually just call me regularly and I just switch out their equipment. Lots of phone calls. So my patients usually call me, nursing coordinator off hours, and then perfusion. Sorry, is that okay? Okay. Perfusion is works in the OR and actually assists and does training with my patients if I'm not available, and then they do the call on nights, evenings, weekends, and holidays. And then if there's a specific heart failure problem with my patients, the coordinator contacts heart failure. And they all go to rehab. Very important. I think I have like 6 patients in rehab right now. Yikes. How does my patient look like? So this is an actual ECG from one of my patients. He's been transplanted since then. He was fine. He was talking in clinic and he's like, I feel a little off, but not that bad. Like, I'm okay. And he was about to go home because we couldn't figure out what was wrong until we saw his ECG. Okay, so VADs and CPR. So these patients are always pulseless. You want to look for other indicators of life. Are they breathing? Are they perfused? And do they have a map? Is the VAD working? You want to look for lights on their VAD equipment. You want to auscultate their chest. Their VAD hum is very, very distinct and very different from a normal person's heartbeat. It almost kind of sounds like bagpipes, for lack of better words. Like you'll hear it ramp down, ramp up, ramp down, ramp up. So if it's not working, you listen to the chest. The first action should be to get the VAD working, make sure they're connected to power, make sure their drivelines connected, and a controller exchange if needed. If a VAD is working, do not do CPR unless advised by the VAD team. So page heart failure stat or myself. If you can't get the VAD to working and the patient VAD to work and the patient's condition indicates it, absolutely. But we do know that there is a risk of the VAD getting dislodged or shifted. So we do have to do imaging on these patients. Defib is totally fine. Actually, most of my patients have a defibrillator, but not all. So just something to keep in mind. And there's no change or restriction to your defib protocol for these patients. So here's the driveline. This is a picture of what you would see on a patient with a LVAD. So it's the external line connecting the pump to the controller. Be aware of where this line exits. It is covered by a sterile dressing. Home care does it in the patient's home twice a week. Do not damage or cut, and there's always a high risk of infection. So just to keep that in mind and always know where it is. LVAD power always has to be connected to some sort of power source, either batteries or wall power. If it's not connected to power, the pump will stop. So there is AC power batteries, 2 batteries at a time, and they're actually trained to always bring emergency equipment whenever they leave the home. So that would be a backup controller, 2 spare batteries, and 2 spare clips. So you'll often see them with their backup bags or with their caregiver, and I call their caregivers a Sherpa. Important information in the field. Like I said, these patients are anticoagulated. Their current target INR is 2 to 3. And we do not administer vitamin K unless discussed with the heart failure staff at the Heart Institute. For obvious reasons, they are not allowed to have MRIs. They are not allowed to immerse themselves in water. So that means a bath, swim, or hot tub, but they can shower. And we do train them to keep their dressings clean and covered with either saran wrap or whatever works for them. And they're not taking like a 30-minute soak. They're taking a quick 5-minute in and out shower. So how do you assess these patients? You want to assess their environment, you want to assess their immediate patient needs, and you want to assess their pump function. So you want to listen, look, and ask. So you want to listen. Alarms. These alarms are very loud for a reason, because we want you to be aware and the patient to be aware that there is an alarm. Auscultating over the pump, humming sound equals pump working. You want to look on the patient's controller where it gives them the patients their regular information. If there's a pump running symbol right here, it's always green when the pump is running for our HeartMate 3 patients. For my 3 Heartware patients I still have in the community, their controller screen, if it's working properly, will just show their parameters. The controller will always display an active alarm and will always give you the solution. 99% of the time it'll say, call, as in call the Heart Institute. It'll give the pump parameters, speed, flow, power, pulsatility index, and it'll actually tell you if any of your connections are disconnected. On the HeartMate 3 controller, there's a little scroll display button where you can actually scroll through and see all their parameters. You want to ask. We've trained the patient and their caregiver to be the experts. So we always ask that the patients come with their caregiver to emergency departments or whenever they're coming in for appointments, just because they know how to manage the patient, and they know the patient's best, and they know how to manage the VAD best. And then they can give you the patient diary and compare current pump parameters with their previous values. Like I said, we always ask the caregiver to accompany the patient with EMS to hospital, not just here, but everywhere, just because they're the experts. These are just some of the alarms. I won't go too much into detail. So what do we do with these new patients? Prior to the patient being discharged from the Heart Institute, I usually will contact Ottawa Paramedic Service or their closest paramedic service with a patient address and tentative discharge date. So then their address is flagged if a 911 call is made. If the patient lives outside of Ottawa, I contact their closest emergency department and then train their EMS there with perfusion prior to the patient being discharged. And they also get a biomedical engineering check of their house. The main reason is we don't want them to be in a house where they're plugging in their equipment to something that can be turned off with a light switch. So that's in some older homes. There are some reasons I tell the patients to call 911 directly and then contact me after. Main reasons: they can't get the VAD to work. If they think they've had a sign of, if they think they've had a stroke, significant bleeding, if they suspect they've had a heart attack, if they've lost consciousness, or they've had a seizure. So in those instances, I tell them to call 911 first and then call me. Again, any questions or concerns, that's my contact information, as well as the nursing coordinator off hours if there's any questions or concerned. And then also I have, if unable to reach the nursing coordinator, you can contact the heart failure cardiology team on call. So this is what the patient's backup equipment bag looks like. They have a spare controller and everything goes into a bag. And then I do ask the patients to bring all their equipment when they come in to emerge, because we don't always have a floating stock available if they come in. These are some really good additional resources I found really helpful to explain the VAD to my patients. MyLVAD.com is a website that actually is for patients who have VADs as well as medical professionals. And then Action is the Advanced Cardiac Therapies Improving Outcomes Network. It's actually more catered to children, but it is very helpful, and like lots of pictures to explain everything about not just LVADs, but other cardiac devices. Thank you so much. Any questions? Yes. Oh. They're not happy about it. No, unfortunately, the reality is, even if it's a non-cardiac issue, they have to come here. That's just the reality. Right now we have 21 patients currently implanted, and I've had to get patients transferred from Ottawa, Brockville, Belleville, and it's not necessarily a cardiac problem, but because they have the VAD, they have to come here. Yes. I remember we've had a consult for somebody for potential VAD, and I know, I'm sure social work could probably more give you more information about this, but basically we've been able to find resources through their families. I did actually have a patient who was living in a shed, and power was obviously a problem, but we were able to have multiple family meetings and get some extra support, and now the patient has stable housing, stable finances. So our social workers are amazing, and I love them. I can't do my job without them. So yep. Oh, that is a very good question. Actually, no, we don't want them to use backup generators or extension cords for any of their equipment. The problem is that there's so many generators on the market, we can't test them all. And the company that creates the LVAD can't say that each one would be safe. So we actually tell patients to avoid backup generators. In the case of a power outage, which they obviously do happen a lot here in Ottawa, They have multiple sets of batteries, which should, if they're fully charged, last for about 36 to 40 hours of just battery power. So what I usually ask my patients to go to their nearest emergency department or fire department and find the red plugs, because those ones are attached to very special generators, or I usually ask them to stay with a friend or family member who has power until the power outage is done. Yes. Yes. Yeah, one for sure. No, we actually like explanted it, removed it. It was before I was in this job, but it was because of like life-threatening non-compliance. So yes, no, it has, we have. I went to a conference about a year ago, and there was actually an interesting conversation about cardiac recovery in patients who have like viral myocarditis, and they put in a VAD for like just to give the heart a rest. They do them in other centers in Canada, but we haven't done it because most of our patients have long-standing heart failure, so it's not something that's reversible. Good question. Yeah. I think one for sure, but before I was in this job. But like we often will, sometimes these patients are really sick when they come out of the operating room and they have a temporary RVAD put in on the other side just to let their heart recover. Any other questions? Oh, yes. Oh, okay. So basically, we're getting the patient to use a blood pressure machine and a Doppler. So we're getting them to first auscultate with the Doppler, and to find to find their pulse, and then we get them to inflate the cuff, and then the first sound when it starts releasing, we assume is their MAP. Yeah, and then some patients do have a systolic and diastolic, but there's certain reasons why we can't optimize their VAD. So the patients are aware of, do they have a MAP or do they have a blood pressure, and they record both if they do have both. Any other questions? $150,000 just for the equipment, not including nursing care and the surgeon's time. So I tell my patients they're worth every penny. Thanks.
Okay, and just for time's sake, we are going to have Taylor come up and chat, but if you need to get up, we're going to work through the break. If you need to get up for a refreshment, feel free. Taylor.
You pull the slide up for me? Yeah. So it's weird because the
next one for me doesn't have audio. So check.
Oh, okay. Just
Your HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta. Your HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium, a small electric motor inside.
Enable this, enable this.
Okay, now Taylor's going to talk. Sorry for the technical difficulties. Just while you're enjoying your coffee, I'll talk about the surgery for LVAD. So this first slide. Sorry. Louder? Okay. This slide actually has the video that we've been working on. So hopefully I can get it to play here. And it kind of just echoes what Carita had mentioned and shows where the LVAD pump sits in the heart and how it sits in the body. You know what? I think we've seen enough images of where the pump sits. Maybe just keep rolling. Did I hit the wrong thing? Oh no. I don't even know if this video is worth it, to be honest.
Your HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium. A small electric motor inside the HeartMate 3 drives the pump, providing blood flow similar to a healthy heart. Although the HeartMate 3 LVAD is virtually silent, it is normal to sometimes feel the pump working. To power the pump, a tube called the driveline passes from the LVAD through the skin in your abdomen. The driveline consists of two cables, the pump cable and the modular cable. One end of the pump cable is connected to the pump, the other end exits your body. The modular cable connects to the pump cable at the modular inline connector, and the other end connects to the system controller.
Okay, so that just kind of shows the components of the VAD and where that driveline site exits the body. So these are some of the instruments that are useful to us in the operating room. Specifically, that long instrument there gets loaded on the handle at the top of the picture, and that is the tunneling device that we use to
pull the drive line out through the abdomen that connects to the system controller. So here we can see on the left side of the screen, that's the actual HeartMate 3 pump itself that sits in the left ventricle. And then on the right side, we have in that dish the apical cuff, or the sewing ring that sits in the LV, and some of the coring devices that are used to take out a portion of the left ventricle so that the pump can sit inside. This is just a better look at the pump. We can see sticking up, that is the inflow cannula that sits in the left ventricle, and that pump gets attached to the left apical cuff that we'll see in a minute. This is another process that happens in the operating room. It happens on the scrub nurse's sterile back table. We submerge the pump in normal saline and prime it and flush it for about 5 minutes just to make sure it's really thoroughly primed. There's no air in the device to make sure it's functioning properly before we implant it into the patient. This is a picture of the outflow graft that's been mentioned. So the blue piece will sit in the pump itself, and then the graft will curve up and get sewn onto the ascending aorta, which is the end that's on the right side of the picture. So it will distribute the blood from the left ventricle and bring it up to the aorta. This is a picture just creating that drive line exit site that comes out of the abdomen. This picture we can see on the top left of the screen, that's the tunneling device that is connected to the drive line and is being pulled through the skin. And on the bottom part of the picture, we can see the LVAD pump itself that hasn't yet been implanted in the left ventricle. This is a picture looking at the left ventricle. We can see that apical sewing cuff has been sewn to the left ventricle, but we haven't yet cored out that piece of ventricle in the middle there. So now we've used a coring device, so you can see there's a hole in the ventricle where the inflow cannula will sit. There's another picture that shows it a little bit clearer. So we're looking into the left ventricle there through the sewing cuff. At this point, we're going to connect the pump to the apical cuff where it'll be securely attached. Oops. This picture's a little bit zoomed, but you can kind of appreciate the inflow cannula, how it's being moved to sit directly inside the apical cuff there, the hole that's been made in the left ventricle. This is sort of a picture where we can see the outflow graft. Is that my pointer wore? But the sort of floppy graft on the left side there is coming out of the pump itself. And on the right-hand side of the screen, we can see an instrument, and that's actually clamping the aorta, where the tube graft will be sewn to the aorta to connect that circuit of blood flow. This is just a close-up picture of the graft. It's made of Dacron. And here we can see the completed procedure. So the pump's not in view, but it's sitting in the left ventricle, and the outflow graft is now connected to the aorta. We thoroughly de-air the heart after having opened it and put a hole in it and put the pump in. We wean off cardiopulmonary bypass, and then we achieve hemostasis, close the sternum, again with sternal wires, close the subcuticular layer and close the skin, and then transfer to CSICU for further monitoring. So, any questions? Thank you. All
right, thank you, Taylor. Glad we got the audio working at the end of the day. Just a quick note before I introduce our next speaker. We did do a draw for the people who participated in the pre-quiz. Thank you very much. We have 2 winners. If they're in the room, feel free to meet us in the back. Otherwise, we'll reach out to you. Amaninder and Jenny Lavoie. If you're here, you want a prize. We'll reach out to you if you're online. Okay, so I'd like to invite Freya up next to talk a little bit about how we take care of our heart failure patients with regards to palliative and end-of-life care.
So thank you guys so much for asking me to speak to you today. My name's Freya Kelly, and I'm an advanced practice nurse here at the Heart Institute. I am going to go pretty quickly because I have a lot of information I want to cover for you guys. Oops. So my hope today is to review the role of palliative care within cardiology, the palliative care approach to care, advanced care planning, symptom management, and transfer from hospital to home. So first we'll touch on palliative care and its role within cardiology. So the World Health Organization defines palliative care as an approach to care that improves the quality of life of patients and their caregivers facing the problems associated with a life-threatening illness. Palliative care intends neither to hasten or postpone death. It integrates the psychological and spiritual aspects of patient care and is applicable early in the course of illness and in conjunction with other therapies that are intended to prolong life. So my hope is that if you take away nothing else from this presentation, it's that palliative care is like having an umbrella when it's raining. So no one likes the rain, but if you have an umbrella, it makes the rain certainly more tolerable. So the same is true in that really no one wants to die, but if you have had good goals of care discussions, your power of attorney is well informed, and your symptoms are being well managed, it makes the process much more tolerable. So historically, the prevailing approach to palliative care has been one where palliative and curative therapies have been erroneously regarded as contradictory options. So it's no longer appropriate to assume that palliative care should be initiated only as a treatment of last resort when traditional heart failure management fails to fulfill patient goals. So an integrative model, like you see here, in which palliation occurs while life-prolonging therapies are administered, is really more appropriate. Palliative therapies gradually expands as illness progresses. So I really don't want to spend too much time on this slide, all to say that many barriers do exist to specialist palliative care, especially within non-malignant illnesses such as heart failure. So barriers come from the disease of heart failure itself, clinical factors, policy factors, and others, including patient misunderstanding and a lack of research within heart failure. So heart failure lacks a clear transition point and has a very different illness trajectory than cancer, therefore making it difficult to base a referral to palliative care on prognosis alone. So this is a common diagram that illustrates the clinical course of heart failure. So if I can bring your attention to the top, you can follow the clinical course. So as you may know, heart failure typically is characterized by these acute exacerbations and deteriorations in overall health, typically leading to hospitalization. So unfortunately, exacerbations become increasingly common, hospitalizations increase in frequency, and ultimately the patients will continue to deteriorate. And so what's important is that palliative care should intensify over the course of illness, but more importantly, start earlier on in the disease. So although early is not clearly defined, palliative care should be integrated into the care of these patients, ideally before they reach end of life. And so of course, towards the end of life, palliative care should intensify. So another challenge with patients with heart failure is prognostication. So prognostication really determines the infrastructure and resource allocation in palliative care. So unfortunately in heart failure in particular, prognostication really does defy us. For example, there's a poor correlation between the New York Heart Association classification tool, which is a tool used to classify the extent of heart failure, and a patient's palliative performance scale. So a tool used to assess a patient's functional performance and used towards progression towards the end of life. So I know Dr. Mielniczuk spoke to this at the start of today, but we do know that there are over 100 variables associated with mortality and rehospitalizations. So an easy mnemonic for markers of advanced heart failure is I need help. So some of the ones that are easily recognized are hospitalizations, as I just mentioned, but also the use of inotropes, patients who have an advanced NYHA class, so 3 or 4, patients who are very symptomatic, elevated NT-proBNPs, evidence of organ dysfunction, a very low ejection fraction, defibrillator shocks, worsening edema and escalating diuretics, having low blood pressure, and in particular, the inability to uptitrate medications or even a need to withdraw therapies. So we know that integrating palliative care and heart failure care improves quality of life for the patient, decreases their symptom burden, improves their experience of care, increases documentation of care preferences, and improves health service utilization. This means reduced hospitalizations, especially at the end of life, fewer days in hospital, reduced ICU use in the last weeks of life, and reduced emergency department visits. So palliative care is really everyone's business. So the American Heart Association, the American Stroke Association, and Canadian Cardiovascular Society have all identified the importance of the integration of the palliative care approach in their position statements. So all clinicians, regardless of your specialization, should be competent in fundamental palliative skills, and these include identifying patients early who could benefit from a palliative care approach alongside disease-modifying treatments, essential conversations such as goals of care, discussions and advanced care planning, identifying and addressing physical, emotional, social, and spiritual needs, ensuring patients are well connected to resources and other providers such as primary care, and referring patients promptly to specialty palliative care when needed. So in order to change the culture surrounding palliative care, we need to be mindful of the language we use. So language that should be avoided, and I heard it just earlier today, is this patient palliative, or the patient is not palliative yet. And there's nothing else you can do, we are now palliative. So instead, I would encourage you to try saying things like, would the patient benefit from a palliative care approach? And would the patient benefit from being seen from a palliative care team? So I think it's also important to remember that palliative care is actually quite active care, especially as you can imagine on the floor. So in order to ensure patients are comfortable, especially as they are near the end of life, it is not uncommon that we see very active medication and dosing changes daily. So although not meant to be prognostic, the surprise question is really a great and simple tool to cue you to, at a minimum, start addressing some advanced care planning with your patient. So would I be surprised if this patient died in the next year? So they say regardless if the answer is yes or no, if you're even asking this question, you should probably start reviewing some advanced care planning discussions. So again, some triggers that are handy to think of for integrating a palliative approach to care include a change in the patient's clinical status. So new heart failure with severe symptoms, acute decompensated heart failure, signs and symptoms of advanced heart failure, such that we reviewed earlier, after a CPR event, before the implantation or replacement of an ICD, when considering heart transplant or an LVAD, or with a new serious comorbidity such as kidney dysfunction or cancer. So triggers can also include patient or family-related factors, such as a desire for more information about future end-of-life discussions, the declining ability to do their ADLs, and a burden on caregivers. So again, important to know that a palliative approach should be integrated based on needs and of patients and their families, regardless of prognosis or disease stage. So because of the uncertain trajectory in heart failure, a focus on identification of palliative care is really based on needs rather than on prognosis. So I touched on this earlier, but this is the Palliative Performance Scale, or PPS. So it's a tool commonly used within palliative care. It's a very basic tool in that, in that you go across each column and mark where you think the patient is along the percentage point. So I always just start at the left and work my way across. So whichever column has the lowest percentage point is that patient's PPS. So if you look, if you start even with a patient who is mainly in bed, but even if they have normal activity, full self-care, normal intake, and full conscious level, because they're mainly in bed, if you look, oh, it's a little blurry maybe, but it's 40%. And it really gives you a very quick snapshot of how well or unwell that patient is. So next I want to review some practical aspects of the palliative care, approach to care that you can really start using in your own practice. So the first, of course, is advanced care planning. So this is the process of thinking about and planning for future medical care. So early advanced care planning reduces hospitalizations and visits to the emergency room and improves quality of life and decision making at the end of life. So advanced care planning is not a single conversation, goals of care conversation, or a consent to treatment. It is also not about establishing a DNR. So there are 6 steps to advanced care planning. So while you are healthy and well, think about what you might want if you were to become unwell. Learn about your health, including heart failure, and consider your preferences regarding major decisions such as ICU admission or CPR. Identify a power of attorney and involve this person early and often throughout the advanced care planning process. Talk about your goals of care with your power of attorney, substitute decision maker, and healthcare team, and document your advanced care plan either using the Speak Up campaign or the Plan Well guide. Both are available online. And then lastly, review your decisions routinely and ensure they continue to align with your goals of care. So goals of advanced care planning include that it is voluntary and that the patient does not feel pushed into doing it. So these conversations are certainly tough ones, and patients may need time to absorb and digest medical information first before they can think about the future. So advanced care planning discussions help with decisional readiness, meaning helping people and their loved ones be more prepared for the future when decisions might be needed, thereby decreasing the surprise and distress at the time of the decision making. Lastly, goal of advanced care planning is to explore value, wishes, and priorities. It's not a about making decisions without the clinical context so that the substitute decision maker or power of attorney feels more prepared in the future. So the basic structure includes exploring the illness understanding. So tell me what you know about your heart failure, provide information as needed. So for example, about their ejection fraction, blood work results. I also use patient decision aids to help with information sharing, as it allows patients to read through at their own leisure. Explore the values, fears, worries, and wishes of the patient. Lastly, share these with the person's substitute decision maker or power of attorney. The most challenging is often simply introducing the conversation, but we know that both the patient and the healthcare provider feel it is the other's responsibility to start the conversation. So the more often you engage in these types of conversations, the easier they do become. And please don't be afraid to make mistakes. You will make them, but you will learn from them. So 2 terms I do want to clarify for you is substitute decision maker and power of attorney. So substitute decision maker is someone who is entitled by law to make healthcare decisions on behalf of a patient when that patient lacks the capacity to make the decision for him or herself. Section 20 of the Healthcare Consent Act sets out this hierarchy, which I'll show you in the next slide, of individuals that may receive decision-making power when a person is incapable. It's important to note that the Act will govern to determine which family member will take on this role without input from the incapable person. A power of attorney for personal care is a document that gives another person the authority to make decisions about personal care and healthcare decisions if you're to become mentally incapable of doing so for yourself. So importantly to note, both a POA and an SDM only come into effect if the patient is not mentally capable of making decisions for themselves. Both are able to make similar decisions for the incapable person. Both are able to provide consent for treatment, admission into a healthcare facility, and personal assistance service. The SDM system is certainly important, as not all individuals will have a formally appointed legal POA. However, if the person wants to choose the individual who will make health decisions on their behalf, it's recommended that he or she create a power of attorney. Another benefit of having a POA arises when there are multiple people who equally qualify as the SDM. So the Act dictates that multiple equally ranked individuals can be SDMs, and if they do not agree, the public guardian and trustee will step in to make a decision instead. So having your power of attorney in place will avoid situations such as this from occurring. So please note that each province does have their own hierarchy as substitute decision makers, but this is the one specific to Ontario. So I heard you guys talking a bit about this, and I'll go into this a little bit more, but a piece of advanced care planning can be the deactivation of an ICD. So ICD deactivation should be discussed prior to implantation with any significant deterioration, but while they are still able to communicate their preferences and at the end of life. So planned deactivation should really be the aim in the majority of patients who require ICD deactivation, as leaving an ICD active can lead to unwanted pain and suffering. The process itself of deactivation is non-invasive, it's painless and reversible, but it does require the availability of a trained healthcare professional and an ICD program or device. So this therefore means practically, for Ottawa region at least, that the patient must be well enough to come to the Heart Institute to have their device deactivated. So if program deactivation is unavailable, a device magnet, such as the one that you see there, can be used to prevent shock therapy, but really should not be the mainstay of care. So lastly, important to note that deactivation of an ICD is not withdrawal of therapy, is withdrawal of therapy and not assisted dying. So again, practically, ICD deactivation does require physician order. The use of a magnet requires ongoing monitoring of skin integrity, Q4 hours. It's recommended that the nurse use paper tape, which is gentler on the skin. We do recommend no longer than 3 days, just because it is heavy and can start to break down the skin. When you initially place the magnet, you may hear a beeping sound coming from the device. So simply remove the magnet, count to 10, and then reapply. Please also be mindful, again, that the magnet is heavy. So planned deactivation, again, really should be pursued if at all possible. So next, I do want to touch on some symptoms and their management. So as always, we do begin with an assessment. So one tool that's commonly used is the ESAS, or the Edmonton Symptom Assessment Scale. So most hospitals should have this integrated either into their electronic medical record or as a paper copy, and it's under flow sheets. It's always used for cancer symptom screening and is actually reportable to the province. So essentially, you ask the patient or their caregiver to go through each symptom and rate them on a scale from 0 to 10. And basically, the higher the score, the worse the symptom. So some of the top 3 symptoms that I see in my clinic anyways, the first is dyspnea or shortness of breath. So as you know, dyspnea is the subjective experience of breathing discomfort or difficulty breathing. So common causes are pulmonary congestion, pulmonary hypertension, but can be due to COPD and anxiety or fear, certainly among our patient population. Given it's a subjective experience, although you should certainly use clinical signs such as appearance, respiratory rate, and use of accessory muscles, you should also just be asking your patient if they're feeling short of breath. So the mainstay of treatment should be the optimization of a patient's GDMT, which I know you went over earlier with Carolyn. So that's your MRAs, ARBs, ARNIs, or ACE inhibitors, beta blockers, and SGLT2 inhibitors. Next, ensure the diuretics are adjusted for symptom management, so your Lasix or metolazone. Typically, patients present quite fluid overloaded to our clinic and do improve with the escalation of diuretics, which can be managed at home. So this is where another discussion is always had about the frequency of blood draws as well as kidney dysfunction. So our clinic supports the patient, and however often or not they want to have their blood work checked. We do have a discussion about their kidney function, and that escalation of diuretics typically harms the kidneys. However, kidneys are also unhappy if they've got too much fluid in them. So we also have discussions about the patient's values of kidney dysfunction versus symptom management, but we do always leave that door open in that if you want to be able to breathe, you'll have to get rid of that fluid. This conversation is had around the time of their consult when reviewing the natural trajectory of the patient's disease, but in a way that is, of course, sensitive to where the patient is at in their disease understanding. So make sure you're also being mindful in addressing potential reversible aggravating factors such as anemia or infection. So I've left up there as well non-pharmacological therapy, such as moving air with an oscillating fan, avoiding exacerbating activities, and breathing control techniques, such as pursed lip breathing. Oxygen should really only be used for the very end of life, and if they have found it helpful in the past. So if the patient's at home, the government does pay for it, but only in the last 3 months of life. So the mainstay of pharmacological symptom treatment is actually opioids, so low-dose morphine or Dilaudid. So fatigue is another symptom we commonly see in our patients. It can be due to volume overload, cachexia, anemia, pain, depression, or other comorbidities. So depending on the patient's goals of care, you may want to address any reversible cause, such as anemia or infection. Otherwise, it's mostly screening for and really just acknowledging the symptom itself. So trying to normalize it for patients and offering non-pharmacological tactics, such as maximizing energy conservation, ensuring good sleep hygiene, and offering supporting counseling and validating their concerns. Then lastly, we have psychosocial distress with depression and anxiety. So depression is actually more common than anxiety among patients with heart failure, but both can really be addressed by supportive counseling. So attentive listening, acknowledging the patient's feelings, empathy, providing ongoing support to the patient and their family, and of course, pharmacological when needed. So we're fortunate here at the Heart Institute, and these are available online. The Cardiac Rehab have put together 2 really great resources that I hand out all the time. So the depression and anxiety resource, as well as the mental health resources. So I know Kristy's going to talk about this next, about preparing for an inpatient discharge, but I just wanted to review the importance of good discharge planning, especially when we're working with someone who's nearing the end of life. So the primary care provider or community palliative physician must be notified of the discharge and ready to accept the patient. Home care staff must be ready to take the patient with nursing and PSW support in place as needed. If your community has a paramedicine program like ours does, having your patient registered with them is super helpful to better round out the support at home. The patient and their family must be educated on the illness, available treatments that are available to them, what to expect in the coming hours to days to weeks, and really who to call. So also unique to the patient with heart failure, they must know what their baseline weight is, as weight gain is the first indication of fluid retention. Their care team must know their current medications and the importance of maintaining the patient on their heart medications as appropriate, the diuretic that was used in hospital, the overall plan, and that the patient has a PICC line in situ should the patient have IV Lasix at home ongoing. So essentially the home does need to become almost like a step down from a hospital. And if it's not 100% ready to go, the discharge will unfortunately fail and you'll see the patient re-present to the emergency department. So palliative care really does involve bereavement for loved ones after a patient passes. So being aware of what is available in your community is important. And at least in the Ottawa region, we have this webpage that is updated quarterly. So we also have sympathy cards and inserts here at the Heart Institute that I find helps with closure for both the loved ones and the healthcare providers. And I would really encourage you to have something similar in your own practice if you don't already. So this does bring me to your own well-being as well when caring for someone with end-of-life care needs, whether as a healthcare provider or as a loved one. So although palliative is very rewarding, it can also be quite demanding and difficult part of nursing. So it's important to take care of yourself, to rely on your colleagues, friends, family, and psychological professionals as well to help offload some of the weight that caring for those with end-stage palliative care needs does require. So I wanted to thank you guys, and if you have any questions.
Thanks, Freya. That was a wonderful talk about a very important topic. We're just going to have Faye come in here and update our presentations, and then I'll be happy to introduce our next speaker. Perfect. Thank you, Faye. So up next, we're going to have Kristy come up and talk to us about what discharging our heart failure patients looks like.
Okay, we'll test the pointer. Hi, I'm Kristy Strecko. I am the clinical nurse educator for cardiology at the general campus. I'm going to talk a little bit about how we help patients get home and specifically what kind of education we can do and how we can kind of facilitate that. So we'll talk a little bit about patient education throughout the admission. We'll talk about how nurses can help with identifying barriers to discharge. We've heard from many other great specialties. So although we don't always have expertise in all of these areas, we can do a really good job of identifying when patients need these other experts and referring them. And lastly, I'll talk a little bit about specific discharge teaching resources available, specifically gap and stoplight tools. So why is it important that we educate our heart failure patients? We have studies that tell us that patients who are educated about their disease feel empowered to manage it. And, you know, heart failure is really complex and does require a lot of management. So it's very important that they receive education about their disease. And specifically, we have Canadian Cardiovascular Society, as well as American Heart Association guidelines that point us in the right direction. So your patient gets admitted for heart failure, and I think I kind of assumed that this was a new admission when making these slides. So when they first come in, and this starts in Emerge or on the medicine unit when they're admitted or in CCU, kind of just helping them understand, why are you here? What is wrong? What is heart failure? I remember honestly being a new nurse and not really understanding what heart failure was. I didn't get that the heart is a pump and that your heart is not pumping effectively. So think about all the things that you've learned today. You know, our heart failure patients have to learn most of this in order to move on. So a lot of teaching about what is wrong, what is specifically happening in their situation. in the admission period, they're probably going to be on a lot of new medications. So talking about what those medications are, why are you getting this? What do you need to look out for? Specifically for heart failure patients, this fluid reviewing and reinforcing fluid restrictions and tracking. So this is a big change for a lot of patients. I know I personally would have a really hard time with a fluid restriction. So helping those patients understand what their fluid restriction is, ways to manage it, should you use, I had a patient asking the other day how they could, like they were having a really hard time with their fluid restrictions. So we talked about, frozen grapes and things that kind of feel the same as drinking, but don't count towards that fluid restriction. And then any special tests that are ordered. So this is a new world for patients. So, oh, hey, you're going to get an echo. Like that means nothing to people. So it's an ultrasound of your heart. It's going to tell us how your heart is working, how it's functioning, or, you need this CT scan because we need to know why your heart has failed. All of these are really beneficial for patients. It's really scary, and we want to try and help them understand what's going on as much as possible. So your patient's admitted, it's been a few days, they know they have heart failure. We're getting along in their admission, they're doing a bit better. We're going to start talking about some other things, okay? So we're going to start talking about what medications might they go home on discharge. And I have a few slides later specifically about that. But just continuing to talk about what's going to happen, this daily weight tracking. And again, we have tools for that that I'll go over a little bit later. The heart failure diet, which for a lot of people might be a really big change. And again, we have our wonderful dietitians and we have great resources for that. And one that we're, at least in my unit, we've been focusing on lately is mobilizing. So, the importance of keeping moving and, going to cardiac rehab when you're done, but even in hospital, getting up, moving around. Just because you're sick and you're admitted to hospital doesn't mean that you might not be able to, get up to the chair for meals or get up and walk around the unit. These make a big difference for patients. So we want to focus on that. So another thing, we are, as nurses, are in a really unique position to help identify these barriers to discharge. And it's certainly not only on us, the physicians and all the other allied health will help with this, but we have these questions built into a lot of our tools in Epic, especially for admission, that are going to help guide us and see what programs or what services do our patients need. So some questions we'll ask, does the patient have drug coverage? How are we going to cover these medications when you go home? Because if we make you better in hospital and then we discharge you and you can't afford your medications, then you're not going to take them. And that's not, we won't get anywhere like that. Do you live alone? Do you have any support in the community? Is there anyone we should, any programs we should try and refer you to? Are you already receiving community supports and we can just increase that a little bit? Or do we need to start from the beginning and get CCAC involved and the LIN and get all of that set up for you? And then also, how were you doing prior to admission? Were you able to get up and walk around and you were really fit? Or has being admitted with heart failure, has it really changed that for you? Do you need to see physio? Do you need a referral to cardiac rehab, which most of the heart failure patients will get? But how can we help you with that? So, like I mentioned, we have some specific tools developed in the Heart Institute, but available to our regional partners as well. So GAP tools specifically are one of the really great tools we have. We have them for heart failure and we have them for acute coronary syndrome. GAP stands for Guidelines Applied to Practice. So what this does, it helps us guide the delivery of best practice medications, standardize education, and follow up with the doctor after the patient is discharged from hospital. Like I mentioned, these are available to all hospitals in the Champlain region, and for our Epic partners, they're built into Epic for us to use. So it's a two-part system. Sorry, my notes are all messed up. So it's two parts. So the first part is essentially documentation of education that we've provided to the patient. So there's kind of two broad categories. There's medications up here, and then there's some education topics. So this is not to say that every patient needs education on every single one of these topics. We give them a lot of information. So if your patient's not going home on digoxin, don't document that you educated them on digoxin. It's a lot already. This just kind of guides and gives us an opportunity to document about these things. So if you are using Epic in the education tab of the patient's chart, if the patient is put on a heart failure pathway by a physician, then this will appear automatically. If not, it can be added by the nurse by going to the Add Title section and adding the heart failure gap tool. So for each of these drugs, the gap tool will prompt the nurse to discuss the purpose and side effects associated. So you see, there's a lot of drugs on here. I know we talked about the 4 pillars of GDMT, and there's way more than that up here. So we have the 4 pillars. We have those extra medications like the ivabradine and SGLT2 inhibitors, as well as some medications that, are often associated with the heart failure medications, like this potassium supplement. And I've just included there what they are in case you're not familiar with them. So what I love about the gap tool is, say you go to do teaching about one of these medications. In the gap tool, it does provide kind of a brief overview of what you should review with the patient. So, if you're a cardiac nurse, you probably know all this. This is not new information to you, but you can imagine if you're a nurse on an inpatient medicine unit and you're new and you haven't had very many heart failure patients, although it is a large portion of their population. It's nice to have this information available if they need to reference it. So it'll kind of mention like the important points. So for, beta blockers, watch out for your blood pressure and make sure your heart rate doesn't get too low, things like that. So again, we do not need to teach to all of these. I know personally as a nurse, you want to get all your green check marks in Epic, but you do not need to teach to every one of these topics. That's a lot. Most patients are not going to go home on all of these medications, so it's absolutely appropriate to select it and mark it as not applicable. You still, did your job and you did your due diligence, but it just does not apply to this patient. So we talked about the kind of medication part of the gap tool. These are the other topics that the gap tool focuses on. And you've kind of heard a bit about a few of these topics from the other speakers, but these are the main education topics that we really need our heart failure patients to go home with. I don't have the breakdown of these topics in Epic. But again, just like for the medication, the Epic gap tool does have a little overview of each point. But you can see we've picked 6 points or topics that we think are crucial for our heart failure patients to learn about. So nutrition, fluid management, smoking cessation. Again, this might not be applicable to every patient. Exercise, learning about heart failure, learning about what they have, and when to contact your physician. This is super important, and I think that it's good that the gap tool and all of the tools that we've developed here, they all touch on this point, because I know that we tell patients and we try to coach them, and it's hard to remember. It's a lot to remember. So it has all of these teaching points. So I said that the education piece was the first part of the gap tool. The second part is this after visit summary. So all patients that are discharged from an Epic Alliance hospital have an after visit summary. And the gap tool smart phrase allows us to quickly add a lot of really important information to their discharge paperwork. So this will be sent home with them as a paper copy, and obviously they can see it on my chart. I didn't scroll through the whole thing, but you can see at the top, like it has the webinar about heart failure. So the discharge class years ago before COVID, we had it in person, but we've done a good job of making everything available virtually, which is great. So, even patients at different sites can view these discharge classes and again, have this information reiterated to them because it is a lot of information. Oops. Broke it. So the stoplight tool, I think a few people have shown this in their presentations, so I won't go too deeply into it, but this is another discharge resource that we provide to patients. As you can see, it's like a big double-sided paper. On the left, it has the calendar, so prompting patients to weigh themselves, and then it has the right side, this really clearly broken down levels. So how are you doing? What are the specific symptoms you should be looking for? And at what point should you call your doctor? So, you know, you've spent a long time teaching your patient and you send them home, and it's overwhelming and a lot of them forget exactly what we said. So this is a concrete tool that they have. We encourage them to leave it on their fridge or somewhere available that has that kind of highlights what to do when. So it might be a little small, but it just talks about like the weight, if they have weight gain, what should they do about that? Who should they call? And at what point should they go to the emergency room? Like we've talked about, heart failure patients are at very high risk for readmission. And I've had a lot of patients say like, oh, I didn't want to go to emerge. I didn't want to bother anybody. So I think it's good that it's clearly laid out, like, no, I'm doing what the doctors and the nurses told me to do. I have these symptoms. I need to go and be seen. I can't put this off. Oh, have it bigger. And lastly, we have, I think you've seen quite a few of these brought up, but the Heart Institute has developed a lot of really great patient guides. So we have heart failure, obviously, transplant, cardiac cath, heart healthy living. And for patients that are tech savvy, they're available on the website. I've had lots of patients say that they download them to their iPad and they really like that. And I want to say, when I started nursing, I started in a different specialty, and we would, you know, diagnose patients with a different organ failure. I worked in a different area, and it was kind of like, oh, you have this problem. Okay, bye. Go home, like, see you later. And I hated that. I hated feeling like we left, you know, that there were no resources for them, or I didn't have anything concrete to give them to say, this is what's wrong, this is what you can do. So I really love that for cardiology, we have all of these resources, and we have rehab, and we have, you know, a wealth of information to give our patients to try and help them manage their condition, because it is, you know, we help, but they are managing their condition. I think I might have spoken too fast, but does anyone have questions? Oh, Tara.
There's a question online.
Yeah.
So are these gap tools available outside of Epic?
We used to have paper copies, but you know what? I don't know the answer to that, but I can put my email in the chat and they can email me and I can try and find the answer later.
And then there's one other one.
Okay.
It says, thanks a lot for the great presentation. They were wondering if teaching patients regarding their dry weight is part of the practice at UOHI.
I don't think so. Someone else correct me if I'm wrong, but I don't think that we specifically teach patients about dry weight. From all of the discharge teaching that I've done personally and all the resources we have available, it's more about a change in their weight from day to day or like throughout the week, and focusing more on that. Yeah. Any other questions? Awesome. Thank you.
All right, so we are back, and I'm happy to introduce now Amy is here to speak to us a little bit about telehome monitoring for our heart failure patients.
Thank you. Oh, perfect. You set it all up for me and everything. Woo! Great. Awesome. Thank you so much, Tori, for that introduction. And I just want to say thank you so much for having me today. Such a pleasure. So yeah, I'm just going to do really kind of a high level presentation, brief overview of our virtual care program here at the Heart Institute. So I'm going to talk about telehome monitoring as well as our interactive voice response programs. So virtual care telehome monitoring. So some of you might have had the pleasure of meeting our Cloud DX team over here in the corner. A really amazing team to work with. So they're our platform that we do use for our telehome monitoring. This is kind of an idea of our staffing model. So our RN staff and our admin staff do work Monday to Friday, 5:30 to 3:30, give or take. So at the moment, we have 3 full-time RNs and 1 part-time RN. We also do have a casual. And we also are very excited because we're going to have an additional full-time RN starting soon in July. So right now, we do have kind of 1 RN that focuses on the heart failure program and 1 RN that focuses mostly on surgery and 1 that kind of does both. And our additional full-time RN is going to be really working on our regional role. So we're really excited to kind of reach out again to the region. I know pre-COVID, we really had done that really well. So we're trying to kind of revamp that again coming up post-COVID and reach out to see how we can support our heart failure patients in the community and surgery as well. I mean, it's not very often that you guys, like, we're the only ones that do the cardiac surgery here kind of in our region. But if you have any of our patients that might be repatriated, for example, to like Renfrew or something like that, and you think they would benefit from telehome monitoring when they're ready for discharge or after their rehab there, we're happy to follow those patients as well. So here's a quick pic of kind of what our program devices look like. So it's pretty nifty. Like, our patients can go home with a tablet. So that's really cool. It is really easy, pretty easy for our patients to use. And we actually have an amazing, like I said, Cloud DX. They're really amazing in helping our patients get set up at home as well. So our awesome nurses will set the patients up, usually if they're inpatient, for example, while they're here before they go home. And then the Cloud DX team actually call the patient the next day after discharge and just walk them through how to use the device and do kind of a welcome call. So that's really awesome support. Our patients can also go home with a blood pressure cuff. And we also have a pulse oximeter that also measures heart rate. And we have a weight scale. So these are all Bluetooth enabled. So again, pretty cool because those numbers actually go directly to our platform. So the nurse can monitor those numbers. And it also has kind of preset parameters. So if something's out of a parameter, it'll automatically kind of triage it, you know, red alert. So the nurse knows to kind of look at those patients first. So it's pretty cool. Not all of our patients need everything, right? So they don't, maybe it's not for heart failure and we're just following them for their incision post-surgery, or maybe it is heart failure and they just need the weight scale and the blood pressure cuff. So we can actually tailor it to the patient, which is really fantastic. So we do have some inclusion criteria. So again, cardiac surgery, I'm not going to spend too much time because a lot of your patients won't be these patients unless they're repatriated, or maybe you will see them in like the community and they're not followed yet, but they're part of our, they've just recently had cardiac surgery. You can absolutely reach out to us. So generally our patients are returning home from hospital after having heart surgery. So really the inclusion criteria is kind of our reasons for readmission. So these are kind of the main reasons here on the clinical side of the table here. Those are really the big reasons that we want to follow patients after heart surgery. So the other part of this is the nurses are amazing. So usually you kind of get that gut feeling, like when you know, hey, this patient might be a high risk for readmission. So we'll follow those patients for sure. Anybody who has a risk for heart failure, arrhythmia, wound problems, etc. So it's actually really cool because with the tablet, the patient can actually take pictures of their incisions and send it to the nurses. They can even take pictures of their feet to see if there's increasing pedal edema, all that sort of thing. Heart failure. So this is really a little bit more intricate for who should be referred. Definitely with our heart failure patient population, we need to have an MRP or a doctor to be able to reach out to help follow the patient. So people who should be referred are really patients who are deemed high risk for acute heart failure exacerbation. We also have some patients who are on the program for guideline-directed medication therapy. So they might require titration, optimization of their heart failure therapies. So the other part of that is IV milrinone. That's again only for our inpatient population here. But when it comes to these patients, it's really awesome because our nurses have actually directives. So they can make sure that we follow the patient's blood work, make sure that their blood pressure is okay, their heart rate's okay, look at their symptoms, actually talk to the patient and help up-titrate them and optimize them to help decrease readmissions and help optimize their heart failure. So we have general inclusion criteria for our program. So you can just kind of take a look up there. But again, kind of the main part that we need for patients to be part of the program. We need them to consent to be part of the program. So they need to want to be a part of the program. They need to be able to use the equipment. We need to be able to reach them. And again, we need that, that MRP for sure. So big thing is how to refer. So internal, so people who are actually in the hospital or within TOH with a cardiologist, they can call the telehealth office. They can submit EPIC orders. So we use an EMR called EPIC at the Heart Institute and at the TOH. If it's a consult over the weekend, the staff can follow up on Monday. Absolutely. We just remind everybody if someone's going to be going home before the weekend to let us know so we can set them up with the equipment. And external, so that's a big thing. We do have a fax, so you can refer to us through our fax and fax it to 696-7150. This is also on our website, and you can also always call our office and speak with the staff if you have any questions. So we organize all the equipment setup and the returns with our patients. So we don't expect anyone else to do that. Our staff are really great to manage that for our patients. One of the big questions we always get is, you know, we have a lot of patients between 60 and 90 years old, right? So a lot of people say, well, can they even use it? Like, how do they find using technology at home? And I find personally it's one of the biggest questions. Even when we go to meet a patient, they're like, like I don't even have a computer at home. Like I'm not tech savvy, like, you know, and really we just remind them it's pretty easy to use. Don't stress. It's just meant to help you. You're going to get a call tomorrow. They're going to kind of go through it and it's just meant to help you. It's not the end of the world if you feel like you can't use it. And interestingly, this is our satisfaction. I should have changed the colors, right? Oh, oopsies. So it's satisfied and very satisfied, okay? Those are what the colors are. So that's okay. So on that note, we have 100% patients being satisfied and caregivers. So sometimes it's the caregivers that are actually using. A lot of times whoever's living with the patient will help with these surveys as well. So just to give that answer, because a lot of patients and staff members actually asked that question. So just a quick little brief on IVR. I don't know if you guys know what that is, but that's our interactive voice response system. So what is it? It's kind of like a self-education platform. So it automatically calls patients and screens them based on questions. And if they answer like yes or no to a question, it flags a nurse to call them back. Okay. So we have many different IVR programs at the Heart Institute. We've got ACS, AFib, heart failure, TAVI, surgical prehab. You might have heard about that today. And our post-op program as well. So it's pretty nifty. For example, like patients that come into the Heart Institute for a cath and then they're stented and then they go back to maybe a regional hospital, they will be put into our IVR system at some point. Example, if they're at the general hospital, like when they're discharged home. So these are kind of the callback intervals that we call patients, and then we have specialized nurses that monitor these this platform and will call the patient back if there's a red flag to any of these questions. So that's kind of all I have for today. I wanted to leave some time for questions or if there was any comments or anything like that as well. Yes? Yes. Mm-hmm. So that's a good question. So with cardiac surgery, because all of our patients do have an MRP no matter what, it's a little bit, and it's such a small group, it's a little bit more simple, right? So a nurse can refer if it's for cardiac surgery. If it's for heart failure, we do want the physician because we need that MRP, and we're really titrating medications, and we're doing all of these things like that. So we need an MRP to be able to go to. So yeah, that's, but absolutely the nurses can recommend it to the staff, and usually they're 100% on board. Sometimes we have to figure out, like, if they don't have a cardiologist, who is that cardiologist going to be? But sometimes it just expedites their cardiology referral, which decreases the risk for readmission. But very good question. Yes. Yeah, so I think it's telehome monitoring or ambulatory referral if you're in the outpatient setting. Yeah, and we can send that out to you as well. So that's a good question. Does it have to be an internal cardiologist or can it be an external? So it does have to be so when it comes to our heart failure program, it should be a cardiologist within TOH. So we do follow patients from the general as well right now, but we are re-rolling out our regional program. So we're actually going to be meeting with, you know, hospitals within our region to see how we can meet with your docs and your nurses and your healthcare teams and see how we can support again and set those patients up for heart failure, you know, optimization. So if anybody's interested in that sooner rather than later, please reach out and we can absolutely start with those programs. Awesome. Well, thank you so much, everybody. Thank you, Tori. Awesome day.
Thank you, Amy. That was great. And now we're going to liven up the room a little bit, and we're going to introduce our very own Alex Trebek. Just kidding. Lindsay MacArthur, who's going to come in. We're going to get a little Jeopardy underway.
All right, hi everybody. For those of you who don't know me, my name is Lindsay and I'm the advanced practice nurse for cardiology. So we're gonna play Jeopardy. So everyone kind of knows the rules a little bit. Okay, well I'll say them then. So last time we divided everybody into teams, but we're not gonna do that this time. So basically just shoot your hand up if you think you know the answer. You'll say, you know, what is, who is, etc., etc. If you get the answer correct, you'll get a little treat. So it's organized by the price points on the screen there. So I'll chuck those at you, or maybe one of my colleagues can politely hand it to you. So yeah, we'll get started. So who wants to go first? No? Wait, you don't have to answer the question. You just have to say. Yeah. Okay.
All right, let me come.
Hold on, I have to start from the beginning. I'm getting too ahead of myself. And if I have technical difficulties, like, it's gonna happen. Hello? Okay, well, I'm gonna go through the categories, and then once we get onto the main screen, then we'll go from there. I just don't want you guys to see the answers. Okay, so you don't need to read that. So here are, you guys can't even see the screen. Okay. Okay. Every time. For me, not me. I'm the problem. Sorry. Yeah.
That problem.
Okay, you. So. Absolutely not. Yeah. Not prepared.
We can do it, like just manual if we have to.
Yeah.
I don't know.
Well, I'll go over the categories then, just to kind of get it started. So the categories are heart failure, lifestyle, medication, mind the gap, trivia, and more trivia. You will see one of the numbers is blocked out. It's because I had a technical error and you just can't pick that one because it gives you an answer to another one. Anyway, it's very complicated, so just ignore that one question. Okay. Okay, so I already did that.
Perfect.
So heart failure, lifestyle, medication, mind the gap, trivia, and more trivia. All right.
Heart failure for 500.
Oh.
That's a hot right off the bat. So let's hope I remember the answers, okay? Blank is a rare disease in which clusters of white blood cells called granulomas form in the tissues of the heart.
What is amyloid? No, that's not the answer.
That is incorrect. Well, pardon.
Pardon me? Did someone raise their hand?
We need a hand up because online counts too. No, that was just said.
Oh, what is sarcoidosis?
There you go. Oh.
All right, who wants to go next? Or
You
actually,
gave her a 500 one, right? Can't perfect. Yeah, so sorry.
Are these low salt options?
No. But my husband did say anybody who got the same of 2 candies in the bag, he did not do those. He said he put time into it, whereas I was like jamming them in the bag. So I had to make that very clear. Okay, go ahead.
Okay, I'm gonna go middle. Lifestyle for 300.
All right. True or false? All patients who have been diagnosed with heart failure should stop working.
The answer is false.
Well, ding ding. Woo. I feel like you three are heart failure experts right now. Let's go.
Meds for 300.
No, feeling it. This medication is known to cause gynecomastia in men. Don't. Oh, ding, ding.
That is correct.
Oh, so
You get to choose the next.
More trivia for 400.
okay. I think this is a hard one, to be honest. Within the supportive care program, this scale is used to measure day-to-day functioning of a patient.
Yes.
Yes, that is correct. Hooray. Okay, hold on, sorry, I have to go to the response. There you go. So the palliative performance scale. Thank you, Freya, for just walking over. That was great. Go ahead.
Medications for 500.
Okay. Woo. These are 3 contraindications for a patient being prescribed ivabradine or Lancora. Oh, sorry. I see a hand up over here. Smith had a hand up.
Bradycardia.
Okay. Do you have a like specific maybe? Heart rate has to be greater than
70.
Ding ding. Okay, that's 1. There's 3.
Low blood pressure.
one is pretty good.
What?
They have allergic reactions or
Allergic reaction, perfect, perfect. And then last one.
post-op habit. Post-ops.
There you go. Ding, ding. Oh, sorry.
Weird.
Somebody look, block answers there. All right. Okay, thank you. Not that it's like a really competitive game, it's over candy. Okay. So yeah, so patient's heart rate is less than 70, patient has an allergy, and patient is not in sinus rhythm. All right. Who's picking next?
Heart failure for 400.
Okay. Sorry, I don't even need the mic, sorry. So blank are proteins that your heart makes when it works harder than normal. That's okay. Go ahead. Exactly. Very good. So the answer is, what is BMP or NT-proBNP? So you get to pick the next one.
Mind the gap for 500, please.
All right. You guys are really challenging yourselves here. So the heart failure discharge class is held weekly on
Wednesday.
No. So close. So close.
Thursdays.
Oh.
Friday.
Yes. Favorite day. Perfect. That was a 500 one. Okay.
Trivia for 400.
Okay. None of patients living with heart failure in Canada is A, 500,000, B, 750,000, C, 1 million. I don't know.
750.
Oh, someone online?
Oh, me. B, 750.
That is correct. That is correct again, sorry. Okay, keep it on the back. Tara, yell at me like really loud. Okay, thank you. All right.
Heart failure for 100.
Okay. Blank is an ultrasound of the heart that looks at the pumping strength of the heart and how the valves work.
What is an echocardiogram?
Oh, good. Yeah. All right, what are you thinking?
Let's do, what's that? Do you have a request? Okay, trivia for 500.
Name 5 common symptoms of heart failure.
Shortness of breath, edema, ascites possibly, crackles in the lungs, some cyanosis sometimes.
Okay. Well, you're going really good here.
Yeah.
Yeah, that was definitely 5. So I didn't pick the same ones, but those were right. Okay, so just so you know. So shortness of breath, fatigue, swelling in your feet, ankles, and stomach, persistent cough, as well as weight gain. But that was a wonderful answer, so thank you. All right.
Okay, more trivia for 500, please.
Within the palliative and supportive care program, this scale is used to assess the severity of symptoms. Oh.
ESAS?
Woo! Someone paid attention. Woo!
Yeah.
It's great. Oh, I have to put the answer up, sorry. Yes. Okay.
Let's do mind the gap for 400.
Okay. I feel like this is your answer over there. She had the answer right the first time. What The Waiting for Cardiac Rehab webinar is held weekly on
Online.
No job.
Wednesday.
Yeah, we have an online answer Wednesday.
So the candy. Perfect. Okay. Person, what would you like?
I'll get back to you.
Yeah. Okay. Thank you. No, okay. Okay. Who wants to pick next? All right. Thank you. Oh, you guys are front for real. No. Yeah. Go ahead, Tara.
Oh, me. Okay. So the person online asked for meds 400.
Perfect. Blank, 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 and blank are the 4 pillar medications for HFrEF management.
ARB and beta block and MRA and SGT2.
Yeah. Perfect. Great job. Okay, you're up next to choose.
Mass 200. Thank you.
Blank is the watch-up period required when transitioning a patient from an ACE to an ARNI no-donna.
So Kendra McWilliams says 36 hours.
And Kendra McWilliams is right. Perfect. It's great. So the candy, come see me one time. Okay. It's okay. We got a couple of minutes. We were early. So.
Is this where we do the do do do?
Yeah. I just stand here awkwardly.
She's asking for Mind the Gap for 300.
Okay. After discharge, patients should make an appointment to see their family doctor within blank weeks.
2 weeks.
Perfect. Ding, ding, ding. So it's 1 to 2 weeks, so that was great.
Mind the Gap for 200.
All right. True or false? The Quit Smoking program is open to everyone, including patients' families. I wasn't paying attention to who shot their arm up first, so. Yeah. True. That is correct. Yes, we should start clapping when people get it, right? We got the room going here. Come on. Okay. Your lifestyle for
200.
Okay, lifestyle for 200. The recommended fluid intake for patients with heart failure is blank liters per day, and it's now a range, FYI. It's changed. Okay.
I have a 2 liters.
That's a range.
Oh, I have like 10 answers.
Okay.
1.5 to 2 liters now is the next one.
Nope. Online, keep going.
Yeah. So from BH, 1 liter to 2 liters.
Nope. A range though. What's the bottom? No. Close though. No, I don't. Yeah, I know. Yeah.
2.5 to 3.
No. Yeah, she's been jamming her hand up. Okay.
The new guidelines state it's 1.5 to 2.5.
That is correct. So the answer is 1.5 to 2.5, and that deserves applause. Perfect. Okay.
Lifestyle for 500.
True. A patient with heart failure should work up to 10 to 20 minutes of exercise per day as able. What do you think I would say?
I think it's false.
It is false.
Well done.
So that deserves a round of applause as well. So patients with heart failure are actually recommended to work up to 20 to 30 minutes as able. So thank you guys for not answering because we do the class together. So yeah. Okay.
Lifestyle for 100.
Okay. This is also new guidelines. Is the maximum amount of sodium recommended for a patient with heart failure?
Got one over here.
I had a few there, and then I can't pay attention. I'm like, ah! It's not a range. No. That is correct. So the new recommended, yeah, sorry, keep forgetting the round of applause. So the recommended is 2,500 milligrams or 2.5 grams. All right, what are you feeling? I was like, that's gone. Yeah. Oh, okay. Blank, blank, blank are examples of the SGLT2 inhibitors. I got to pull on my sheet. Oh. Nah, for sure. Okay, wait, Smith is up. Oh, okay, online. Oh, so it needs to be through.
Empagliflozin and Invokana. No.
Yeah, exactly. Yeah, that's perfect. Woo, good job.
Thank you. Dapagliflozin.
So canagliflozin or Invokana, dapagliflozin or Forxiga, empagliflozin or Jardiance. All right, what are you feeling?
Trivia for 300.
Okay. The number of wires implanted to the heart with a cardiac resynchronization therapy or CRT device online.
We have Kendra McWilliams again for 3.
Kendra McWilliams, you go, girl. You're correct. All right, perfect. Okay, so what's Kendra feeling now?
She would like more trivia, please, for 300.
All right. The blank is used to classify the extent of heart failure. I saw that hand first.
Yeah, NYHA.
Yeah,
scale.
that's correct. So the New York Heart Association or NYHA functional class. What are you feeling?
Heart failure for 3.
Okay. Blank is a condition where abnormal proteins are deposited into the heart muscle.
Is it amyloidosis?
Yes, that is correct. Okay, what do you feel?
I'll pick more trivia for 100, please.
Okay. The number of years that heart transplants have been performed at UOHI. I saw, oh, yeah, it was quick. That was a lot.
40?
Yeah. I feel like the harder questions are down at the 100s. Sorry. Yeah. Whoopsie. Okay, what are you feeling? Okay. Blank occurs when the heart ventricle becomes thick and stiff and the ejection fraction is greater than 50%. So it's like the definition of this. Yeah.
HFpEF?
Exactly. Perfect. Great job. So heart failure with preserved ejection fraction or HFpEF. So perfect. All right. Here.
More trivia for 2.
Okay. The name of shortness of breath when lying down. Pink blazer was up first.
Orthopnea.
Yes, perfect. Great job. So it's orthopnea. or orthopenia. I don't know. You said it differently than me. I don't know who's right, to be honest.
Trivia 200.
Okay, perfect. Following a hospitalization for heart failure, blank people will be readmitted within a month. 1 in 5, 1 in 10, 1 in 15, or 1 in 20. I got an online.
So online we have Stephanie Peterson who said A.
That is correct, Stephanie Peterson. Way to go. So it's 1 in 5. Okay, 2 more. Stephanie, what do you think? We'll just give her a minute. Oh, Stephanie, you live in Osgood. Freya has your candy.
She's laughing and she says, mind the gap, please, for 100.
So patients with heart failure should weigh themselves blank. What was a unison answer?
Daily.
That's correct. Good job. 100 still get an applause, okay? Yeah. Okay. And last question. Blank is the most common cause of heart failure. Ooh, jeepers. Yes?
I have an answer online, diabetic obesity.
No. That's one of the main causes, but it's not the number one. Yes, a heart attack is the number one. Whoop. That should have been a So that ends my portion of the day. So thanks very much, everybody, for your participation. Very enthusiastic group. Enjoy your bonbons. Okay. No worries. Thanks for having me.
Thanks, Lindsay. That was awesome. Loved the energy, and way to go, everybody. Really showed off the knowledge that we've learned here today. And now to close off this day, it's my pleasure to introduce Bonnie Quinlan, who's the Director of Prevention and Rehabilitation here at the University of Ottawa Heart Institute.
Thanks so much, Tori. Well, that Lindsay's a hard act to follow. Anyways, I'll just take up a couple of minutes really, and really to thank everyone in person and online for attending this, what I think is an absolutely outstanding event. We've heard of the journey of patients with heart failure from diagnosis, hospitalization, advanced therapies, and supportive end-of-life care. So I'd like to really have a huge round of applause for our clinical educators and all our amazing speakers today. Amazing job. All the sessions were recorded as well, so they'll be sent out to you and available for ongoing learning, so you can review them or share them as well. Also like to thank Phi, our IT support in the back, making all this happen so seamlessly. Thank you so much, Phi. A special thank you as well to our sponsorship from Boehm Ringer Ingelheim and Cloud DX. For the amazing food and support for the day. And I believe the rep from Cloud DX is over at the back. Thank you so much, Courtney. Thank you. So we've had, I'm told, 92 in-person register, 155 virtually, total of 247 folks attend this amazing cardiac nursing series. So thank you so much and look forward to the next event in the fall. Thank you and have a great evening.